Internal sphincter is not in the voluntary control. You can see over here. This is the part of your internal sphincter, and this is the external sphincter over here. So your external sphincter is basically the skeletal muscle, and it can be controlled through the relaxation of the sphincter. You can do voiding, you can misturate. Now we'll see about the muscles. The muscles of the pelvic floor are divided into different layers, but first, the superficial layer that you see over here is once you rip off the skin, the fascia, you come across this layer. And two important muscles that we are going to talk about today is the Virgo Cavernosis. This is the Virgo Cavernosis muscle over here, and this is the Hpc Cavernosis muscle over here. Now, if you see the origin of the Virgo Cavernosis, it originates from the perineal body. This part is called the perineal body or the medial raphe. And it originates from here, and it is inserted towards the proximal end of the bulb of penis. And the second muscle is the Hpc Cavernosis. Second muscle is the Hpc Cavernosis. As the name applies, it originates from the ischial tuberosity and is again inserted towards the proximal end of the bulb of penis. So these are the two important muscles that we are going to talk about. Now, what are the functions of pelvic floor muscles? It helps in improving the sexual health, prevents and helps to treat erectile functioning, prevents and helps to treat premature ejaculation, helps in urinary health, helps in prostate health, helps with bowel control, and prevents pelvic pain. Now, what are the causes of prostate dysfunction? So first is urinary tract infection. Second is BPH, that is benign prostatic hyperplasia, inflammation of the prostate, narrowing of the urethra, scarring in the bladder neck as a result of previous surgery or any kind of trauma. Even the kidney stones can also lead to prostate dysfunction. Causes of prostate dysfunction: problem with nerves that control the bladder. Basically, the pudendal nerve is the control. Cancer of prostate, infective conditions, obesity, arterial or venous disorders, systemic disorders like diabetes, hypertension, and drug-induced or trauma. Now, what are the signs of prostatic dysfunction? So, frequent urination, weak or interrupted urine flow, the urge to urinate frequently at night, blood in the urine, blood in the seminal fluid, and onset of erectile dysfunction, pain or burning sensation, discomfort or pain in back, hips, or in your legs, swelling or fluid buildup in your feet, unexplained weight loss, fatigue, changes in bowel habit, and the most important, that is the urinary incontinence. Now, these are the common types of dysfunctions. That is your benign prostatic hyperplasia. The prostatic growth begins from the puberty and it goes on till the end of your age, right? So what happens in the early testicular removal can also lead to prostatic hyperplasia, hormonal imbalance, chronic prostatitis, bacterial prostatitis, and traumatic or surgical. So dysfunction affects the pelvic floor muscle. So increased weight may cause urethra. BPH may cause a lot of the pelvic floor muscles, resulting into pelvic floor muscle dysfunction, damage to the internal sphincter, damage or loss to the tone of the external sphincter, affecting in penile erection due to disturbances in the neurovascular function. Now, these are the common dysfunctions: erectile dysfunctioning, premature ejaculation, and incontinence. Let us go to the quick assessment tools. So we all know about the traditional Oxford MMT grading scale. So as you can see, there are 0 to 5 grades with which says it is weak, very weak, moderate, good, and strong. But we found that there are two limitations in this scale. First is it cannot assess the relaxation, as pelvic floor muscles are not only meant for contraction, they are also meant for the relaxation. So this scale is not assessing the relaxation part of the muscle. Second thing, the terminologies are very subjective. Like my stronger could be your moderate could be my strong. So this is the limitation in the scale. So we usually prefer Hayes assessment scale. So here you can see the grading, the positive gradings, the plus grading, +1, +2, and 3 are connecting about the contraction, and the minus gradings, -1, 2, and 3 are talking about the relaxation of the muscle. So what this grading system is basically is, suppose this is the anal opening, and what you need to do, how you're going to assess it. So 0 is the baseline tone. If you try to insert the finger and if you're unable to penetrate, that means your muscles are very tight, right? They are unable to relax. So that is your grade -1. If you are able to penetrate but with symptoms, patient feels pain, right? So that is -2. And if you're easily able to penetrate throughout, and if the patient is totally comfortable with that, then it is -3. Now, once you're inside it and you ask the patient to contract, if you feel a strong contraction, you feel your finger is getting pulled inside, right? So that is your grade 3, +3. Now, if you feel that there is patient is able to contract, but you're not getting that pull, you might feel a circumferential grip around the finger. So that is grade +2. And if you find some flickering type of the movement, then it is grade +1. Now, how to evaluate erectile dysfunction? So, according to the classification of Alberg and Lewis, out of 10 attempts, if you are able to successfully have 7 to 8 satisfactory erections, then it is considered as a mild erectile dysfunctioning. If 4 to 6, then it is moderate, and 0 to 3, it is considered as a severe form of erectile dysfunctioning. Now, let us go through the Hayes MSF scale, that is male sexual function scale. So, there are a lot of questions. I will just go through the questions, try to focus on the questions. So, first thing is, are you sexually active? Second, if yes, what is your current frequency of sexual intercourse? What was your past frequency of sexual intercourse? Do you have any other medical conditions which might be affecting your sexual health? Are you apprehensive of urine leakage during intercourse? Do you have any problem with prostate health? Do you suffer from any type of urine problem? Do you have history of any surgery like prostatectomy or other? Now, the second component is the pain and discomfort. So, do you have any pain in your private areas? Are you able to have pain-free sexual activity? If no, what is your level of pain or discomfort during the sexual activity? How frequently do you feel pain or discomfort during the intercourse? Are you able to complete intercourse even with pain? If there is pain, does it last even after the intercourse? For how long? So please rate the level of pain and discomfort. So this scale that is given at the end of every component is very important. So 0 is uncomfortable and painful, 10 is comfortable and pain-free. Now, the second component is the sexual desire. What is the level of your sexual desire or interest? How will you rate your desire to have sex compared to past or before? Do you always feel receptive towards your partner's initiation? Please rate your overall sex desire. So 0 is no desire and 10 is high desire. The next is sexual arousal or the erectile functioning. Can you get penile erection during sexual activity? If yes, how often can you get penile erections during sexual activity? Do you feel that you have hard enough erections for successful vaginal penetration? If yes, how often can you have hard? Are you able to maintain penile erection throughout the sexual intercourse? If you can't maintain erection, how frequently do you lose erection? If you lose erection, can you regain erection by manual stimulation or any other complete the intercourse? How satisfied you are with the erection throughout the sexual intercourse? How many times did you get satisfactory erections in your last 10 sexual intercourse? How would you rate your erection compared to past? How would you rate your confidence level for maintaining erection throughout the intercourse? Please rate your overall erectile ability during the sexual intercourse. So 0 is inability, 10 is the best ability. The next is orgasm. So do you feel that you find difficulty delay in reaching the orgasm? Do you feel that you are able to last long enough in sexual intercourse? If no, how frequently do you experience premature ejaculation? How intense is your ejaculation force? Are you satisfied with the intensity of ejaculation you reach? Please rate your overall ejaculation experience. So 0 is bad, 10 is very good. Next is satisfaction. Do you feel like you are completely satisfied with the sexual intercourse? If no, how frequently are you satisfied with the sexual intercourse? How is your level of satisfaction compared to past? Please rate your overall satisfaction with your sexual life. So 0 is dissatisfied and 10 is completely satisfied. Next is confidence. Do you feel any nervousness or performance anxiety with the sexual intercourse? If yes, how often do you feel any nervousness or performance anxiety with the sexual intercourse? Does nervousness or performance anxiety negatively affect your sexual desire or sexual performance? Please rate your level of confidence about your overall sex life. So 0 is no confidence, 10 is best confidence. Other questions: how well is your emotional bonding with your partner? How well is your intimate bonding with your partner? Do you feel that emotional distress negatively affects your sexual life? Do you feel that you get distracted due to some negative thoughts during the sexual intercourse? Does your sexual well-being negatively affect other aspects of your life? Please answer the question. So these are a few open-ended questions. Since when are you suffering from this problem? Have you ever had a treatment for this problem? If the answer to the above question is yes, what is your success rate? Please describe your problems in your own words. Now, interpretation. So you saw that there were few scales at the end of the question. So the Hayes MSF is designed to find the sexual score of the suffering from the male sex dysfunctioning. The scale has 5 components: desire, arousal, orgasm, satisfaction, and pain. Pain is not mentioned over here, but pain was also one of the components. The last question in all the components except for psychological factor has score 0 to 10. So we saw the scales from 0 to 10. So there were 5 scales from 0 to 10. That means the maximum score is 50 and the minimum score is 0. Now, if you get the score, 0 to 25 would be considered as poor sexual health, 25 to 40 is average sexual health, and 40 to 50 is good sexual health. So these are the components that we saw, and this is how you're going to score it from maximum 10, and whatever score you're getting will define that what is the level of sexual dysfunction, whether it is poor, average, or good. Now, what could be the possible causes for this? there are two basic causes, two spasmodic, too tight muscles. Too tight pelvic floor muscles can lead to dysfunction, because too tight muscles will lead to pain and other things which cannot be maintained. Second thing is weak pelvic floor muscles. If you are having weak pelvic floor muscles, the Virgo Cavernosis and the Hpc Cavernosis that we saw previously plays the very important role for the erection. So if the pelvic floor muscles are weak, then they will not be able to maintain the erection. The blood flow won't be there actually. So this too, spasmodic and weak muscles can lead to pelvic floor muscle dysfunctioning and can lead to affected sexual health. Psychological factor also plays an important role. Any psychological factors like performance anxiety, relationship issues, low self-esteem, emotional distress, and other issues can also lead to sexual dysfunctioning. Simultaneously, patients should be also referred to other medical specialties like psychiatrists, psychologists, sexologists, or urologists. Now, introduction to pelvic floor rehab. So this is the list of treatments. We cannot definitely go through everything, but we'll try to focus on few of the things. The first is the Hpc protocol. What is this? So it is basically you ask the patient, or you lift the penis and the scrotum, you strap it with the to the abdomen, or you can ask the patient to hold it. You try to find the muscles through palpation. You try to find the muscles. So Virgo Cavernosis, Hpc Cavernosis, and the perineal body, that is the main part where all majority of all the pelvic floor muscles are inserted or originates from there. So you find that you palpate through proper palpatory technique. You find that you apply the pelvic floor 360. So these are the parts of the pelvic floor 360. That is the target activator, the shaft, and the handle. You place, and it is enabled with the application. You can run through your phone application. There are different modes of this, and you place it over the different portions of the muscle. So these are the portions. So you can see the number one is showing you about the Virgo Cavernosis. The second one is the perineal body. The third is the rectal opening, right? So there are muscles surrounding the rectal opening. You can place the target activator of the pelvic floor 360, and you can target the muscles. Along with this target activator, you ask the patient to do voluntary contraction. But first of all, you need to teach the patient that how you actually need to contract the pelvic floor muscles, because patient is very much sometimes confused and he even does not understand what are the pelvic floor muscles and how to contract them. So first you need to teach them, and through this activator, you target the muscle and you ask the patient to voluntarily contract them. So these are the portions that you're going to target. And this is how your muscles will get activated. They start strengthening with it, and there are further protocols which we can follow for the strengthening purpose. So thank you. This was it for today, and thank you all from the team of WOW. Thank you.
Thank you very much, Dr. Kevin, for your lovely session on prostate health. And I'm sure that the way women's health, people are becoming aware about females' health, prostate health or males' private health is equally important. And thank you for giving us an insight about it. And I'm sure that people would take this opportunity to learn more about the male health as well. Shall we have our next speaker then, Dr. Zara Sharma ma'am?
Yes, please.
Okay, so the next in the list we have Dr. Lalita. Dr. Lalita is a women's health physiotherapist, and she's the co-founder of Global Associations for Pelvic Floor Obstetric and Gynecological Association, and she's working as a women's health physiotherapist in Yojna hospitals in Hyderabad. Dr. Lalita, over to you. And we are looking forward to hear about the diastasis, the importance of assessing diastasis rectus, abdominis, and how can be the management about the same. Over to you, Dr. Lalita.
Just 1 minute, ma'am. Sorry to interrupt. Dr. Lalita, I would like to inform all our panelists as well as all our attendees that we also have Dr. Ali Rani sir with us as an attendee of this event. We are welcoming you, sir, through this event, and we are very thankful for your presence, and thank you for being with us and motivating us always. Thank you so much.
Thank you.
Dr. Lalita, you may please go ahead now. Thank you.
Just a minute. Sorry to interrupt, but thank you, Ali sir, for your constant support for pelvic floor. A heartiest welcome to you on behalf of Hate sir and whole WOW team as well. Thank you very much.
Thank you, both the Daras and the WOW group. I'm looking forward to be in Ahmedabad very soon for the conference also. And I'm wishing you all the best. It's lovely hearing. I'm on it. I'm listening, but being away from Mumbai, there may be problem with the network. That's why I'm only listening. Thank you.
No problem, sir. Thank you very much.
Thank you.
Thank
Sir.
you.
Thank you. Over.
Yeah, hi everyone. I'm Dr. Lalita. I'm an internationally certified childbirth educator and trainer too. I'm appointed as childbirth educator trainer for Andhra and Telangana state. I'm a prenatal yoga trainer as well as pelvic floor rehabilitation specialist from WOW group. So we are exclusively working on this women's health area from past 3 years. I'm the co-founder of Global Women's Association also. We have started this Global Women's Association, the formerly called as GLOPT, for pelvic obstetric and gynecological rehabilitation. And we are doing an association with WOW group. We are doing often doing very good programs from WOW. And I firstly thank Dr. Hayes sir and WOW group for giving me this wonderful opportunity in presenting in this seminar, in this conference. Thank you so much everyone. And a special thanks to Dr. Dara for giving constant help and mutual support for anything in this field. Thank you so much. And I would like to go ahead. Today, I'm going to talk about the DRAM management, diastasis rectus abdominis, and I'm going to talk about the review on the strategies of exercise prescription in DRAM. So let's go forward. So first question is, let us start our discussion on this. Focus on rectus abdominis. When should we actually start on focusing the rectus abdominis in diastasis? Is it immediately postpartum, or after we recognize a problem, or the client come to us? So when exactly? So the answer for this question is we have to start focusing on the rectus abdominis while the mother is in pregnancy itself. So pregnancy itself will give a clear picture of whether the mother is going to have a rectus abdominis, diastasis rectus abdominis, or if the rectus abdominis muscle is weak, and postpartum, if it is going to land up into a diastasis, and all these things. So here is a picture. So the answer would be the antenatal period and postnatal period. Immediate postpartum, we can yes, if it is a cesarean section, yes, we need to wait for 4 to 6 weeks. And during the antenatal period also, we need not check the classical checking of the finger width gap checking, and we can't do that in antenatal period. But through observation, yes, we can observe if the mother is having any diastasis. So here, as we see in the picture, that is the first is a relaxed pregnant belly, and the second is doming or coning of the pregnant belly. If the mother is landing up into diastasis, or the mother previously had diastasis in the first pregnancy, post-pregnancy, and the mother is pregnant for the second time, then we can see a pregnant belly coning or doming up like this. So here starts the actual concern for us as a physiotherapist. In the antenatal period itself, we have to check for the pregnancy diastasis and go ahead with the treatment part, because we know that prevention is better than cure, right? So just simple exercises in pregnancy like hip knee flexion and just arm and leg spreading movements. So how to do this? These general exercises should be incorporated with breathing technique. Breathing would be the key for engaging the core muscles. So only in pregnancy we can't do all this lunges, crunches, all this we can't do, because it increases the intra-abdominal pressure. So what we can do is we can give a simple movements which will coordinate with simple other movements, which will general exercises, which will coordinate with the breath, and which will be helpful in activating the core muscles. So that's how we have to incorporate this. So these exercises might be seen very simple, but incorporating with the breathing exercises will be helpful for the mother. So side lunges and free leg movements, everything should be incorporated with the breathing itself. So squats is one more thing. And we all know we'll be discussing about the breathing pattern, how the breathing pattern would be during pregnancy and normal pregnancy time, how the diaphragm and the pelvic floor is going to co-contract with each other. So squatting is one more thing, and we have to incorporate with the breathing along with this. Okay. Next is postpartum or postnatal advice. When we go to the patient, we have to teach them diaphragmatic breathing exercises, Kegels exercises, ergonomics to pick and hold the baby, and explanation of the good posture. As we can see in this GIF, so pelvic floor muscles and the diaphragm, it will work in this synchronization, right? So any activity in the body, because breathing is continuous. So we have to keep this picture in mind and teach the exercises accordingly. You can see the contraction, how the abdominal muscles and connective tissues are moving, how the diaphragm is contracting and the pelvic floor is relaxing and everything. So we have to keep this in mind, and accordingly we have to prescribe the exercises either in pregnancy or post-pregnancy or any core training. So this is one more thing what we can do for pregnant women, like posture correction and post-pregnancy posture. This is the incorrect posture and the correct posture, because core problems, weak core, weak diastasis will also lead to the back pains and everything, right? So getting out of the bed also, no direct pressure on the abdomen, and then to turn towards the side and getting out of the bed. So first, now we will go into the actual topic of management steps of treating the diastasis rectus abdomen. First thing we have to do is to assess, to identify, and to treat. These are the three major steps what we have to keep in mind while treating a patient with diastasis rectus. So this is the normal abdomen in the first picture. As you can see, this is the normal abdomen, and this is the diastasis rectus abdomen. This is the rectus muscle. This is the linea alba, the connective tissue, and the transverse abdominis and the obliques. Okay, so when because of the pregnancy, there will be overstretching of the muscles and overstretching of the linea alba, which will lose the connective tissue and results in the diastasis abdominis. Okay. So this is the, I'm not going in very depth because as physiotherapists, we all know what is diastasis recti. So, but just to brush up, I'm just talking about. So diastasis rectus. So that what actually diastasis, we know the physiology behind the diastasis. So what actually diastasis rectus can look like on a pregnant, postnatal mother. It can be like this, it can be like this, it can be a protruded belly, it can be like this, it can be like this or this. But on observation, if any of these can be seen on a mother, postnatal mother, while observing for diastasis rectus. So any of these we have to take care of in treating. So next is what to assess. This plays a very important role. First, we have to check the inter-recti distance. What is the distance between the recti to the two rectus abdominis muscles? Linea alba length. Linea alba length to be checked from the xiphoid process to the symphysis pubis. And transverse abdominis contraction, because transverse abdominis is the deepest layer, and we have to check in for the transverse abdominis contraction. And pelvic floor, as we all know, diaphragm and the pelvic floor works in coordination together. So we have to observe for the pelvic floor assessment also. And any hernia, is any momentum coming out while sitting or doing any activity, and we have to assess all these things in sitting, standing, and lying position of the mother. Okay, and level of abdominal wall distension. Yes, few mothers may not have any diastasis, but the level of abdominal wall distension will be more. For them also we have to assess all these things: inter-recti distance, linea alba length, transverse abdominis contraction, pelvic floor, hernia, level of abdominal distension, all to be assessed in sitting, lying, and standing positions. So now we will go across the principles in treating DRA, that is diastasis rectus. Position of teaching exercises plays a very important role. Teach the exercises in sitting or standing position while you are teaching the diastasis rectus abdomen. Why? The reason behind that is connective tissue of the abdominal wall slides down in lying position, making it more difficult and to exert pressure to engage the core and perform the exercise. Simply saying, you teach on exercises, teach on exercises for diastasis, ask the patient to do in lying position. Patient will be able to do, but you ask the same exercise to do in standing position, patient will be able to perform it better than the lying position. This is because abdominal wall, all the connective tissues become slacked while lying down, right? So in rather than teaching initially in lying down, teach the exercises in sitting or standing position. Next is principles activation of transverse abdomen. As you can see in the picture, this is normal and this is diastasis. Transverse abdominis, the red color marking, there is the deepest muscle layers and the obliques is in the mid layers. Rectus abdominis is in the outermost layer and the linea alba, the connective tissue, is in the middle. Okay, so transverse abdominis is the major role to close the gap. So transverse abdominis action, transverse abdominis contraction plays a very important role. So you have to make sure the patient is doing the transverse abdominis contraction, but not the obliques. Because once we ask the patient to do the transverse abdominis contraction, what they will do is they will, when the abdominals are weak, the obliques will overtake the action of the transverse abdominis. Then what will happen is, you have, I mean to say, identifying the wrongly contracted abdominal muscle. If our target group of muscle is, our targeted muscle is transverse abdominis, the patient has to activate only transverse abdominis, because when the transverse abdominis is weak and it is the deepest layer, when we ask the patient to tuck in, what will the obliques will do is it will overtake the action of the transverse abdominis. So always check for the internal obliques if it is overtaking. Procedure, you can observe the ribs flaring out. If the ribs are flaring out, then it is not with the transverse abdominis, it is with the internal obliques. Okay. So like this, you have to, likewise, you have to check for the external obliques also. So you have to identify which muscle you are targeting and which muscle actually the patient is doing. That is very important. Next, the 4 stages of transverse activation: bracing or bulging, and relaxed. This is one. Active as much as possible, engaged when necessary. Here you can see there is no rib flaring out much. So that means it is actually the transverse abdominis which is acting, not the obliques. Next, not doing diastasis rectus abdominis specific exercises. Prescribing exercises that are not targeting the diastasis rectus abdominis is also one of the major concern in not getting the results while teaching drug. Teach both general and exercises, the exercises specific to diastasis rectus abdominis. But while teaching diastasis rectus abdominis, along with breathing, incorporate to engage the abdominal muscles. Teaching general exercises or specific exercises related to diastasis rectus, we have to incorporate breathing. Breathing is the major key for anything, either general exercises or teaching the diastasis rectus exercise. So plan accordingly how you are treating your patient, whether you are targeting the abdominal core muscles or you are teaching the general exercises for the overall fitness, and then sidewise targeting the diastasis rectus. Next, principles in treating observing the for doming of linea alba. This is the major important key which gives us a apprehension that whether the patient is whether the muscle is taking overload to do the exercises what we have taught. So if the doming is little, activation of rectus abdominis, then that is fine. Okay, the doming will be little. If the doming is more and the pregnancy pouch is coming out when you are treating a patient, that means the muscle is taking overload to perform the exercise. Then what you have to do is, if the doming is more, go back to the basic exercise. If the patient is unable to do that exercise also, go still more back to the basic exercise. So likewise you have to do, because if the doming is coming more, then we can, it is a clear indication that the muscle is overexerting in doing the exercise. So just go back to the basic exercise, next step to that, and accordingly teach the patient. All these are the principles of teaching the diastasis rectus. So everything you can teach. So there is no contraindication. There is no specific protocol to teach DRA as well. To say researchers have not been proved, but crunches and all these things, we say that you should avoid. Yes, that has to be avoided. But if your patient is good, so always remember there is nothing to do with the distance between the diastasis recti in getting the clinical outcome of the patient. So what is the actual problem of the patient that you have to target? If it is a linea alba which is creating the distance, then you have to target the linea alba. If it is the transverse abdominis which is not supporting the supporting structures, then you have to concentrate majorly on the transverse abdominis. So to assess, it is very important. So what we have seen before, to assess all the steps, interrectal distance, transverse abdominis, linea alba length, everything should be, assessment should be in proper. Then your treatment protocol would be easy. So electrotherapeutic modalities can be used are NMES, it elicits muscle contraction, helps in strengthening of the muscles. So electrode placements can be like this, should be placed bilaterally, one electrode in the origin, that is the anterior surface of pubic crest and in front of the symphysis pubis, one electrode to be placed at the insertion, that is anterior surface of the xiphoid process and outer surface of 5, 6, 7 cartilages. So what you can do is, while doing this, we can use Russian currents as well. What we can do is, we can ask the patient in standing position or in the on force position, we can place the electrodes and we can ask the patient to do the exercise, perform the exercise while the contraction is happening, while we are giving the contraction through the NMES. So that will give a better result than normally asking the patient like electrotherapy once and doing the normal exercises once. Clubbing of both the exercise and the electrotherapeutic modality will give a better result. So Emg Biofeedback is an advanced tool for diagnosis, therapy, as well as client training. Electrodes to be kept on the targeted muscles, and the response of the muscle is shown in the graphical representation, which gives a feedback to the patient. This is the Emg Biofeedback what we will be using for the patient, which will give some. And I didn't get a picture of the patient which will give a feedback. So the feedback will be presented on the monitor so that we can give the this is for the biceps and deltoid they have kept it. So we can ask the patient to perform the exercise, and the required amount of contraction will be seen in the monitor. So that will give a apprehension for the patient that he has to perform little more better. He or she might perform little more better. So this is the tool which we can use, EMG. This is an advanced tool. And the exercises, research suggests that there is no standard protocol to treat diastasis recti. Muscles to be targeted are multifidus, transverse abdominis, diaphragm, and the pelvic floor. All these to be targeted along with the diastasis muscle, rectus muscles. So all these to be targeted, the core muscles to be targeted. It's not a specific to DRA, and in not it's general to all the things. So you have to relate everything to assessment and then only teach the patient, because every patient is different, and every every diastasis mother have different issues. So you have to teach them accordingly. Teach the patient the basic breathing techniques to engage the core muscle. This will be helpful in proper activation of muscles while doing the primary exercise. As an initial treatment part, first teach correct body mechanics, proper posture, appropriate exercises to activate the abdominal muscles, simple belly exercises which does not increase the intra-abdominal pressure. First, these has to be incorporated into the patient's mind, and then only you have to actually go for the major exercises what you actually wanted to. So as to refresh again, so you have to remember this co-coordination of diaphragm and the pelvic floor muscles and the abdominal muscle tissues, and then you have to treat. That is the reason we have said that we have to concentrate on whole core along with the diastasis rectus. Precautions to be taken: never teach the exercises which increase the intra-abdominal pressure. All the exercises which put pressure on the midline and also which bulges out the belly should be avoided. That is nothing but the linea alba doming. Unsuitable abdominal exercises includes sit-ups, straight leg raises, and trunk rotations. Back bending exercises, lying over Swiss ball should be avoided. This is in the initial phase. Okay. Later on, once the mother is fine upon your assessment, yes, you can go ahead with these also. Cat and camel pose can be done without excessive stretch. And advice on lifting and carrying weights and supported cuffing to be given for the mother for sure, because they will come to us, they will know the exercises, they will do wrong type of exercises will be thank you so much. This will be the end of the session. Thank you so much. We learned something new from today's session, and thank you everyone.
Thank you very much, Dr. Lalita. It was nice hearing from you, and looking forward to meet you once again. We are not taking question answer session here, but if there are any questions related to your topic, I'll inform you.
Sure. Thank you so much.
The next we have Dr. Dipali Hyundai with us. And Dr. Dipali Hyundai, she has done her Masters of Physiotherapy in Community-Based Rehabilitation, and she's a certified childbirth educator from USA. She's the professor and HOD of Community Physiotherapy Department, Dr. APJ Abdul Kalam College of Physiotherapy, Pravara Institute of Medical Sciences, deemed to be University Loni. She is the member of Board of Studies at PIMS Loni and Datta Medical Science Academic Council PIMS Loni. She's also the member of Board of International Continence Society, member of European Society of Cardiology, and she is a coordinator of Indian Association of Physiotherapists Women's Cell IAPWC Ahmednagar, Maharashtra State. She has received significant contribution award at the National Indian Association of Physiotherapists Conference in 2015 at Shimla. She received Outstanding Academic Award through Finishers International Conference 2021, which held online on 8th of May 2021. She also has received Linnaeus Palm Scholarship and visited Korolenske Institute, Sweden in the year of 2015 and 2017. And she is the author of the book in Lombard publication and has 55 publications in her credit. So she is going to give us a wonderful, she's going to deliver a wonderful topic, that is fitness beyond menopause. So we all had discussed so much about the other aspects of women's health, but menopause is also something which should not be overlooked upon. So here we all welcome you, Dr. Dipali, for your speech. Thank you.
Good afternoon all. Am I audible, ma'am?
Yes, you are audible.
Okay. Before starting my session, I want to thank a WOW group. They are doing excellent work in women's health. I also place my thanks to Khyati College of Physiotherapy, Khyati Institute of Physiotherapy, IAPWC, and I would also like to thank management of Pravara Institute of Medical Sciences for allowing me to share my thoughts on this topic. As we all know that menopause is a series of physiological changes. What happens when we are young? We are very active, we are financially independent, and that's why we care for ourselves. But when we start aging, generally what happens that we are not that active, maybe financially, socially, and because of this, a series of physiological events starts in our body, and even the psychological and societal changes that is happening around us are very much affect our physical health. If we see the demography of India, now the life expectancy is increasing because of advancement in overall lifestyle, advancement in pharmacology. So people are living more years than before. And because of this, females are spending 1/3 of their life in menopause. And because of that, the problems which are related to geriatric age group and because of menopause are inevitable. Problems like cardiovascular diseases, osteoporosis, weight gain, falls, related injuries, urinary incontinence, depression, and stress is very common. Are you able to see my PowerPoint presentation?
yes, it is visible.
Okay. So the fitness, according to ACSM guidelines, it is called it as a medicine, and it is called it as a medicine because getting people to be more active may be ultimate low-cost therapy for achieving improved health outcomes. What are the barriers of exercises in India? Before going for the exercises, we really need to discuss what are the barriers for exercises. A very important thing is in India, there is no culture of exercise. I feel after our school time, we are not at all more into exercises because we have a pressure of academics. And once we go in our 10th standard, we all are into academics. And because in a society, we feel that the scoring good marks, it's very, very important. Second important thing is that the people who are playing sports or those who are into physical activity, we are segregating that. It is like for normal people, it is not necessary to do the exercises. If we compare with the Western world, they are doing their exercises continuously. Obviously, their environment is also plays very important role. Because of the cold weather, they have to make sure that the body is getting warm because of the physical activity. Awareness about exercises is very, very low in Indian population. Social scenario for old age women is also a very important barrier for exercise. Financial burden, if we want to go or if you want to go to gym, or if you want to take any kind of a consultation for physical activity, again it requires a lot of finances, lack of time, boredom, weather. Because India is a hot country, generally people don't go for more of exercises, and because of the physiological changes, discomfort, pain is there, fear of injury is there, lack of resources, and lack of exercise adherence. Because of this all physical exercises, it is very difficult for Indian population to continue with the exercises. But I feel that thanks to COVID, because of COVID, now lot of awareness about improvement in the immunity and maintaining the physical fitness has improved. So I feel that physiotherapist has a very big market now. What are the benefits of exercise? We all know what are the different benefits of exercises, but very important thing that we need to remember and we need to emphasize that it boosts our immune system, which is very, very important to fight with most of the diseases. Prevention of fall, reduction of depression. Nowadays, mental health is also a very big issue. And if we compare it with the menopausal woman, that is also a very, very important role that the exercise is playing. Improvement in the bone density, improvement in the sleep quality. Sleep is also very much disturbed, and if we don't have proper sleep, it again it disturb your hormonal balance. Plus it also works on our different systems and specifically endocrine system. So sleep is also very important. So these are the benefits of the exercises. So physical activity, 150 minutes per week is very important. Combination of physical activity needs to be there. So it has to be multi-component so that the strength, gait, speed, balance, activities of daily living are going to improve. Aerobic, muscle strengthening, and balance training is very, very important. So you need to target all the components of a physical fitness. Don't only target on strength, don't only target on balance, because menopause is also multi-component, and exercises which we program for menopausal women has to be multi-component. Then low intensity walking as a primary mode of physical activity, it is not beneficial. Indian population, specifically Indian females, they go more for physical activity like walking every day, but this is not sufficient to fight with all the problems of menopause. So every exercise session needs to have a different component. That is warm-up exercise, very important to reduce the injury. Aerobic exercises, cool down. Strengthening exercises, that is specific strengthening exercises of weak muscle. For that, evaluation of muscle strength is very important, and stretching exercises has to be done to avoid the injuries and re-injury. So exercise prescription according to ACSM guidelines, frequency should be at least 3 to 5 days, preferably more. You can do the exercises taking a break of 1 day in between. Intensity, it should be moderate intensity, And rate of perceived exertion, we can say it is from 12 to 4 on RP scale. Very important thing, you can ask your participant that whenever you walk, you should able to talk. When you are talking while walking, it makes sure that you are in aerobic phase of the exercise. Time at least 15 minutes per session should be there, and gradually it can be increased by 30 minutes. Type of exercises are dynamic, rhythmic physical activities, and generally go for large group of muscles such as walking and cycling. Precautions we all know, but the basic precaution that we have to take is when we are doing this curler or any kind of trunk exercises, it should not be repeated because it may lead to vertebral fractures, because already the anterior column of vertebral fracture is very weak. And very important thing is Valsalva maneuver should be avoided. So breath holding, which generally we do whenever we are doing exercises, that has to make sure that the patient is not doing it. It should be strictly avoided because it may increase the blood pressure, plus it may increase the chances of hernia and pelvic floor muscle weakness. Now we'll see some of the important problems in menopause. So osteoporosis is very, very important problem, and it's a hidden problem because the osteoporosis, which is diagnosed by DEXA, the equipment is very, very costly, and generally the screening for osteoporosis is not done because it is very costly. So what happens that even if we go for X-ray, after 30% of bone loss, we can diagnose osteoporosis on X-ray. So that is also not a very good option. When we come to know about osteoporosis, when the patient gets a fracture and when the patient reports to any institution or hospital. So that is why prevention of osteoporosis is very important. So there are two types of osteoporosis, that is primary osteoporosis and secondary osteoporosis. So because the bone loss is going to happen in old age, different types of exercise, specifically weight-bearing exercises, has to given to the patient. So some of the evidence-based studies I'm going to explain you. So this Maria Benedetti, they have done a study in 2018, and they had 3 groups. In that, one group got multi-component exercise, one group only walking, and one group was normal strengthening exercise. And they have found out that multi-component exercises are very important to reduce chances of osteoporosis. And I also request all of you that you can go for more evidence-based studies wherever this DEXA equipment is available in the institution. And they have also said that walking alone is not beneficial. So we have to make sure when the patient says that every day we walk for 30 minutes or 60 minutes, it is not sufficient. Osteoarthritis, this is a very common problem. We see deformities in the knee, and the walking is very painful, and osteoarthritis knee is very common in Indian females. That is because of our lifestyle. So we have done few studies on this, and we have found out that retro walking, it is a very good option with the conventional exercises. So if you are adding retro walking with conventional exercises, what benefit it creates, that in the knee joint, specifically the adductor forces, the forces which are acting because of adductor torque are going to reduce, plus it maintains the alignment. And comparatively, if you are going for dynamic exercises, these exercises are painful, but retro walking, it is not painful, and we have got very good results with this study. We have done few researches with our research group. One more research is coming up, that is BUA, that is better management of patients with osteoarthritis. This is an evidence-based supported osteoarthritis self-management program. It has already proven in all over Sweden, and now we are implementing in our institute. Hopefully in near future, we will come up with the some of the good studies. And in this, lifestyle management is also very important. So when physiotherapists are targeting knee joint, only don't target knee joint. You have to make sure that the patient is doing exercises in good alignment, plus the lifestyle changes has to be done. Next is pelvic floor. We have already spoke a lot of thing about the pelvic floor, and a lot of eminent speaker has explained about it. Muscle awareness is very important in pelvic floor muscle strengthening, because generally what happens, and specifically females who are in rural area, they are not aware how to contract pelvic floor muscle. So muscle awareness, muscle re-education is very important in this. And for muscle re-education, we have a different equipments which can be used, and pelvic floor muscle strengthening can be given. And here you can see a perinometer, which also gives a biofeedback to the females. Then neuromuscular stimulation. Remember that electric stimulation, it is not an alternative for voluntary exercises, but definitely it improves the strength of the pelvic floor muscles. Falls is again a very important problem in a postmenopausal woman. We don't screen generally fall related risk factor. Patient comes to hospital that they had a fall from bed and now it is a IT fracture. Because of this, what happens? The patient will not die because of the fracture. Patient will die because of the other risk or nosocomial infection that is happening in the hospital. So avoiding fall related injuries is very, very important. And for this, environmental modifications should be done, risk analysis should be done, corrective of refractive errors so that the vision is good, assistive devices should be given to the patient so that we can reduce the prevention of, prevent the falls. This is according to American Geriatric Society. One more very important evidence program is there, that is Otago exercise program. This is the individually tailored home-based strength and balance retraining program. It prevents the fall in older adults who are living in community. So this program, it has specific exercises week-wise, how to progress and how to go about the exercises, and detailed description is given. Otago exercises are very safe. We have done this in the patients, and we have also have a good evidence that Otago based exercises are very, very important and beneficial in prevention of fall. Plus in fitness and wellness, nowadays we are having very different physical activities like Tai Chi, then hydrotherapy. These are also exercise, different forms of exercise by which we can improve the exercise adherence in the patient. Relaxation is also a very, very important, specifically in postmenopausal women. Because of the hormonal imbalance and because of the changes in the endocrine system, we have to understand that there is also a lot of biopsychosocial factors which leads to depression in the patient. When the patient is in the depression, or if the patient is having any kind of mental health issue, specifically during that time, what happens? The pain intensity is increases. Then infection is also going to increase because the immune system is not going to function properly. And that's why all the exercises, whenever we are giving exercises to postmenopausal women, irrespective to the problem, relaxation exercises has to be given to the females. So Michel's method of physiological relaxation, contrast method is also a very good technique. Suggestion and visualization, different forms of massage are also available. Then breathing and yoga. I feel that yoga is a way of living, and yoga is not only working on the physical component, it also works on the mental component. So incorporating your exercises with different types of yoga is also going to helpful to the postmenopausal woman. So when we are working with the postmenopausal women, we have to understand that the problem is multidimensional, it is multifactorial. So only physical activity is not going to help to the woman. Patient has to take proper diet, physical activity, and patterns of behavioral modification is also very important. So I just want to give one message on this International Women's Day is that she should be stronger, she should be healthier, and every day she has to work with her own full potential. So menopause, I feel that when she's walking on the path of her life, it should be me, no pause. It should not be menopause. Thank you so much.
Thank you very much, Dr. Dipali. It was nice to hear you. And yes, you have rightly said menopause. That is a very nice, I think, the new meaning of menopause, which we have heard. Thank you very much. And with this, we can have our next speaker. So our next speaker, would like to introduce her. She is Dr. Yojna Mange. She is again a senior women's health physiotherapist. She has done her master's. She is again a women's health physiotherapist, and she is WOW-IP licensed clinical instructor. She has done her master's in preventive and community physiotherapy, and she was a former lecturer with MGM College of Physiotherapy. She was a former therapist at Equicentric Private Limited. She's a certified MET, reformer, antenatal and postnatal Pilates instructor. She's a practicing Equicentric therapist, and she is going to talk about the classification of female sexual dysfunctions and what can be the interpretation for a physiotherapist or a pelvic floor rehab specialist. So over to you, Dr. Yojna.
Thank you so much, Dr. Dhara, for this kind introduction. I hope I'm audible to everyone.
You are audible, and please keep it on the slide sharing.
Yeah, I'll do it. Yes. I'm on slide sharing now?
Yes.
Full screen available? All right, perfect.
Pretty visible.
So let me take this opportunity to thank Khyati College and WOW-IP for giving this beautiful platform for sharing such a important topic and information. So today I will be talking on Watson's classification of female sexual dysfunction and physiotherapy interpretation with the help of Haig's female sexual functional scale. Okay, so before we look at the classification and causes of female sexual dysfunction, what is a normal sexual response? Now, the normal sexual response has different phases. It is the desire phase where the female has the desire to get into a sexual intercourse. Then she has to get aroused, and once she's aroused and reached the excitement, she orgasms, and then it comes down to a resolution phase. So all these four phases are there in male and as well as females, but the timing is different in males and female as per the excitement, as per the desire, as per the stimulation. And definitely orgasmic state is after the state of orgasm, the resolution which is attained, it might be a longer period in male, and a female can attain the second orgasm in a very shorter period of time. So this is a normal sexual response that a female goes through and a male goes through. What happens when there is a dysfunction? So WHO defines dysfunction as the various ways in which an individual is unable to participate in a sexual relationship he or she would wish. So WHO also states that sexual health is a state of well-being. Now, what happens when these all components of desire, arousal, orgasm are getting affected? So these are the when these there are problems in these areas. There are desire difficulties, or there are orgasmic difficulties, there are arousal difficulties, or if there is any kind of a pain, it leads to a dysfunction. So what is the classification of this dysfunction? So Watson's classification describes these dysfunctions into different categories. So if there is a sexual desire disorder, it can be either hypoactive sexual desire disorder, or it can be a sexual aversion disorder in which the female doesn't have a desire to get into a sexual activity. Now, there can be a sexual arousal disorder in which the arousal of the women is affected. So the woman has a desire to get into a sexual relationship or a sexual activity, but she's not getting aroused enough to get. So once there is a arousal, there are different physiological, psychological changes that intensify and takes you to the peak of orgasm. So these all activities are very important. So when these components are getting affected, there is a dysfunction that is happening. Now, what are the causes of dysfunction? We will also be looking at it. Then there can be a sexual pain disorder, which can be due to dyspareunia, that is painful intercourse, or vaginismus, in which the vaginal muscle or the vaginal canal goes into spasm and the intercourse is not possible. So where there is no penetration, it is vaginismus. Where there is painful penetration or symptomatic penetration, it is dyspareunia. And then the female orgasmic disorder. Now, orgasmic disorders are also vast. So on this platform, particularly, we'll be looking at components which are usually I'll be giving an idea of what is the base of it, but these all topics are a lot in depth. Like, just for example, female orgasmic disorder. Now, there are women who don't get orgasms, and there are women who have a permanent sexual orgasmic condition in which a little stimulation, even like using a hair dryer, can give an orgasm. So, permanent sexual arousal disorders are there in which little stimulation or a lot of stimulation also doesn't lead to any kind of orgasm. So there are a lot of dysfunctions. So today we'll be just looking at how to evaluate them. Okay, the causes of these dysfunctions can be large. It can be either physical or surgical cause or medical cause. Hormonal issues like in menopause, where there are a lot of physiological changes happening, that can also affect the skeletal structure of the pelvic floor or the functioning of the pelvic floor, or chemotherapy, where there is a local chemotherapy or radiation happening due to an oncological condition. There can be psychological and social issues or history of very traumatic penetration or a child abuse. There are a lot of things that can affect sexual dysfunction. And then we come to the local cause, that can be the pelvic floor dysfunction. Okay, so the symptoms of sexual dysfunctions can be a large number of them depending on what is the cause of it. So there can be a lack of interest of the women itself, or that can affect the desire. The inability to get aroused due to any kind of a local psychological emotional cause, inability to achieve enough of lubrication. Again, it can be a pathological psychological cause. Inability to relax the pelvic floor muscle during the intercourse, painful intercourse. It can be trigger points, it can be any kind of trauma in the local area, or inability to achieve orgasm. So these are usually the symptoms that a woman can give for sexual dysfunction. Now, looking at the pelvic floor, what role the pelvic floor has to play? So, pelvic floor being the first in contact during the sexual penetration, the reaction of the pelvic floor is very important. So, the basic tone of the pelvic floor plays a very important role in the sexual activity. So, if the pelvic floor muscles are weak, it weakens the grip over the penis. It can reduce the sexual sensation. It can reduce the libido, and it can also reduce the intensity of orgasm. So the grip over the penis, when it is less due to the hypotonicity of the pelvic floor, when the tone is less, the grip is less, the proprioception is less, and hence it can affect all this. If the tone is very high and the pelvic floor muscles are not able to relax, there can be inability to have sexual intercourse. The penetration is not possible. If the penetration is possible, it will be a very painful penetration, and it can give a very long lasting pain in the private area. So the perineum can be sore for a very long time if the pelvic floor muscles are not relaxed during the intimate relationship. Okay, so these ways the pelvic floor has to play a role in the intercourse. There are conditions where it can be also the incoordination. So the pelvic floor muscle is relaxed, but during the intercourse, it can suddenly go into spasm, or it can completely lose its tone suddenly in between the in between the sexual activity. So also it can be involuntary incoordination activity of the pelvic floor, and it usually happens when there is penetration and thrusting movement. So just to give you an idea, there is a condition known as penis captivus. So in penis captivus, during the sexual intercourse, suddenly the pelvic floor muscle can go into a spasm and the penis can get locked into the vaginal cavity. Now that's a very serious and a medical emergency state in which you have to rush to the hospital. So that's an incoordination of the pelvic floor. So the pelvic floor can be either hypertonic, it can be hypotonic, or also there can be incoordination of the pelvic floor. Now these need to be addressed as per what is the dysfunction and what is the problem. Now, when we do a pelvic floor evaluation and when we see whether the pelvic floor is hypotonic, hypertonic, and we do digital examination, everyone is very familiar with the Oxford grade of scale. So when we do the evaluation of the pelvic floor, it is done from 0 to 5. The pelvic floor can be very weak, moderate, good, or strong. Now we are aware of this scoring. Now what happens in this scoring is the limitation is it is very subjective. Weak for you, moderate for you, might not be weak for me or moderate for me. And secondly, it cannot access the relaxation. So once you enter the pelvic floor, you are able to assess whether it is weak or it is very weak or it is strong or very strong. But what if you're not able to enter the pelvic floor? So that's the limitation of the Oxford's MMP, and that's where we are introduced to Haight's MMP. Thank you, Haight sir, for giving this tool. So when we look at Haight's MMP, there is a very clear-cut differentiation. 0 is the baseline tone. The muscle has to relax to -3, and then only you can assess the grade 1, grade 2, and grade 3. So it's no gray area. Before me also, Aarti ma'am and everyone has explained the Haight's MMP in detail. So I won't be going in detail. So basically, when you compare it to Oxford's MMP, Oxford MMP has a very gray area where you don't have a clear-cut discrimination of the muscle strength, whereas Haight's MMP gives you a clear white and black picture of what is the grade. Now, everyone must be wondering, how come the medical faculty has not paid attention to the hypertonic muscle? How did they miss out on the high tone of the muscle? So there is a Lamont grading that is available, which gives you an initial scale of whether the patient is ready for pervaginal or not. But the scale and the grading, the grades of the Lamont scale is only a psychological effect of the psychological condition of the patient, whether the patient is psychologically ready and how is she reactive for pelvic floor examination. So it is used to see the psychological involvement, but it cannot give you the actual picture of pelvic floor. So if you see at the grades of it, it just gives you the withdrawal syndromes that she's not able to relax, she's lifting off her buttock from the table, or she has uncontrolled shaking, screaming, hysteria, jumping off the table. So these are all psychological reactions that the patient is giving to pervaginal examination. But it is not giving us a clear-cut picture of how the pelvic floor tone is and why she reacting that way. Okay, that's where we use Haight's MMP. Now coming to the sexual dysfunction scale. So the International Institute of Urogynecological Association gives us female sexual functional index. Now what happens in this index, it gives you sexual components to check, but the scoring of this scale is very cumbersome, and it is designed by urogynecologists, so it does not pay attention to the pelvic floor muscle. And again, the hypotonic and the hypertonic. So both of these tones have effect on sexual dysfunction, and this scale particularly does not evaluate the hypo and the hyper component. That's when we have the Haight's female sexual functional scale. Now, Dr. Kevin has also shared the male sexual functional scale. So in the female sexual functional scale, it's quite similar. So it is divided into two parts. It is the hypertonic component and the hypotonic component. In the hypertonic component, we take in consideration the pain, and in hypotonic, we take in consideration the laxity. And according to the components, we will come to know how the how is it affecting the components. So the questions of each scale has 5 leading major compartments, which is the desire, arousal, lubrication, orgasm, and the psychological component. In hypotonic dysfunction, questions are related to pain, tightness, discomfort, and basically every component has a last question which has a scoring. So desire has a last question which has a scoring from 1 to 10. Arousal has a last question which has a scoring from 1 to 10. Lubrication has a last scoring of 1 to 10. Orgasm has a last scoring of 1 to 10. and the psychological component has a last scoring of 1 to 10. So all these components, when we take the maximum score, it is 50. The initial questions of these components are basically to find the clinical understanding, and it gives you a picture of how their sexual activity is and how are they performing in it. Only the last question of the components give you the value. So once you look at the interpretation, in hypertonic, questions related pain, and hypotonic, laxity. And then desire, arousal, lubrication, orgasm is very common in both the scales. Once you get a score out of 10, you will be writing the patient score here and a total score. So when the total score is gained, if the score is 0 to 25, the sexual health is poor. If it is 25 to 40, it is average. If it is 40 to 50, it is good. So the accurate cause of the female sexual dysfunction can be diagnosed at looking at each component. So these are the few questions. So this is the pain and hypertonus scale. So initial questions are related to the sexual activity. If how are you active, how many times in a week or month, what is your frequency? Then questions related to pain are there. Are you able to have sexual penetration? Do you feel any kind of pain? And so long it goes. It has many components. Then the last question in each component, as I said, has a score of 0 to 10. Whether please rate how comfortable and pain-free your sexual intercourse is. Very uncomfortable and painful, or comfortable and pain-free. So this has the pain component covered. Again, the sexual desire has different leading questions like, do you fantasize yourself? Or how is your desire? How was your desire before pregnancy? How are you receptive to your partner's initiation? Again, there is a score of 0 to 10, where 0 is no desire and 10 is high desire. Then we look at the sexual arousal, again a scale of 0 to 10. Lubrication. So there are questions leading to lubrications. Do you feel any kind of difficulty in achieving? Do you feel lubricated during the intercourse? Or do you feel the lubrication is reduced over a period of time? And then again a score of 0 to 10. Then we come to the orgasm component, where have you ever felt an orgasm? How intense is the orgasm? Are you satisfied with the orgasm? Are you able to reach to the orgasm? And again, how would you rate your experience, as no orgasm or best orgasm? So again, you get an overall view of how is their orgasmic desire, arousal component. And then other question which gives you a psychological interpretation of how is your bonding with the partner. Is there any emotional distress, or do you get distracted by negative thoughts during sexual intercourse? And then again, at the end of the questionnaire, we have open-ended questions. So if the client is not able to place themselves in this questionnaire, if they have some queries which are not been addressed in the questionnaire, they can always provide that in their own words. So we don't miss out on any component. Now, this is the laxity and hypotonus evaluation of the female sexual function. So again, basic questions which in desire. Now the questions start changing as per the pelvic floor. Is how in laxity, where there is no response or the proprioception is less, do you feel aroused easily? Is there enough of foreplay? So every component according to the hypertonus and hypotonus has been designed in a very beautiful way, where it covers its dysfunction. So again, a scale of 0 to 10. Lubrication. Now in hypotonus, mostly what happens is there is a lack of lubrication, the arousal is less, the proprioception is less. So we get a part like if the pelvic floor is hypotonic, and if her lubrication is affected, we know that the Bartholin gland, the tone of the pelvic floor, where to stimulate, what is the area to be taken care of, which can help the client the best. So if the desire is good, the arousal is good, and the lubrication is only the one which is bringing the overall score of your sexual functional scale down, we know where to focus on. As a physiotherapist, we know how to go about it. Okay. Now, that brings me again to the other questions, that is, how is the emotional bonding? So these all questions are very leading and will give you an idea whether another expert needs to step in on. So you get a, a feedback from the client that the emotional bonding of the patient is not good, or is there any psychological trauma that is affecting all these things, that will help us to bring in a psychologist, psychiatrist, sexologist. So our expert needs to step into the time perfectly, because we cannot waste this time. Sexual activity is a part of a daily activity of a sexually active person. So, and it's a very emotional and a very deep bonding activity. So, it should not be neglected and it should be taken care of at the same time. So again, as I bring you all to the components of it. So just that looking at this chart, we will get an idea of which component is affected and which component needs to be targeted in the treatment plan. So what happens if you see there is a less of score in the laxity part or the pain part of it? Okay, so if there is any kind of a mechanical obstruction like the pelvic organ prolapse, it can give you discomfort, pain during sexual intercourse, or also it can it now this mechanical obstruction is due to hypotonic pelvic floor, but it can also give a interpretation in pain. So there is also a pain part in this mechanical obstruction. Now in hypotonic pelvic floor, usually there is a lot of incontinence during sexual activity. So due to the smell and embarrassment, the women can have a emotional distress, which can again affect the desire and arousal. And even asymptomatic vaginal laxity may negatively affect the sensation. So the grip over the penis, the proprioception, the libido, everything starts affecting the desire, the arousal state of the sexual function. Now looking at the desire, how will the pelvic floor affect the desire? So overall desire means it can be either self-driven or receptive to partner's initiation. Now if the pelvic floor muscle is too tight, it can lead to pain, tightness or discomfort, and it can reduce the desire. So just the memory of old pain can reduce your desire and withdraw you back from getting into a sexual activity. If the muscle is too loose, the sensations are reduced and the desire to get into a sexual activity due to the lack of sensation is again reduced. So that's how the hypo and hyper will affect the desire. Arousal, if the muscle is too tight, anticipation of pain, the arousal can be affected. If the muscle is too loose, then the clitoral activation is very difficult and it becomes very difficult to attain and maintain the arousal state. Lubrication, again, if there is a less lubrication and there is vaginal dryness, it can reduce your sexual it can increase the friction, and it can be anything due to your menopause, hormones, psychosomatic dysfunction, and it can again give a lot of pain and friction during the intercourse. Orgasm, if the pelvic floor muscles is too tight, there is pain and discomfort. It can reduce or delay your orgasm. If the pelvic floor muscle is too loose, then it can reduce the sensation and also fail to perform the strong orgasmic contraction. So orgasm can either be absent or it will be very delayed. Now the psychological factors like relationship issues or low self-esteem, which are covered in the scale. So there are open questions which can compromise the sexual wellness. There are leading questions which can bring out all these issues. The treatment is not only about the pelvic floor rehab, but it is also the role of the pelvic floor rehab specialist to refer to other specialists who need to step in and in time to take care of the issues. And the scale, the unrelated questions of the scale for the pelvic floor and all give us a better clinical understanding and how to take care of the treatment and how to take a holistic approach towards the treatment. So it's very important to look at the scale. So the scale is a definite help for the therapist, physiotherapist, to consider what is the part that is getting affected and how to take care of that part. Well, that brings me to the end of the presentation. I hope I was able to explain about the female sexual functional scale and how it is really helpful for physiotherapists, and it can help us to target the problem area. Dr. Dhara, over to you.
Thank you. Thank you very much, Dr. Yojna, for a lovely presentation. And yes, you have, you really gave a beautiful understanding of what are the classifications of female sexual dysfunction, what can be the causes, and probably what should a pelvic floor rehab practitioner should use as an outcome measure to find out the actual causes. And thank you very much for a wonderful presentation. The next in our panel, we have Dr. Samiksha Gupta. And Dr. Samiksha Gupta is again a WOW-IP licensed clinical instructor, and she is the owner of SG Pelvic Floor Rehab, which is first of its kind pelvic floor clinic in Rajasthan. She is the vice principal of Jaipur Hospital College of Physiotherapy, Jaipur. She is a passionate physiotherapist and a wonderful lecturer. Her topic for us today is enhancing the role of physiotherapy management of back pain through pelvic floor activation and coordination. I would really like to welcome Dr. Samiksha Gupta. Dr. Samiksha, over to you.
Hello, am I audible to you?
Yes, you are.
Okay. Let me thanks to WOW IP and also Women's Cell, IIP Women's Cell, to organize such a wonderful event for everyone to understand more, let more understanding for the pelvic floor and all these women health issues. So here my topic, I would like to share my screen. Just a minute, let me.
Dr. Samiksha?
Yeah, is my screen visible to you?
It is not visible, and your audio was also off. Your screen is not visible. Your screen is not becoming visible, Dr. Samiksha. There will be a screen sharing option at the bottom where there are the buttons for audio video. So there will be a green colored screen sharing option. If you will press on it, you will get an option to share your screen. You can open your PPT on your desktop first.
Well, I'm using my mobile phone. I'm just doing it. Just a minute.
Dr. Dhara, if someone else has a presentation, they can share the screen and let Madam speak. That also is fine.
Yeah, yes.
Yeah, okay, I'll just wait for a while. There's some issue over here.
You can just WhatsApp your presentation to me. I'll run it for you.
Okay, okay. Thank you so much. I'll do it. Hello.
Yeah, hello. Yes, I'm waiting for.
Yeah, okay. Can you please start some other speaker? I can wait for the next my turn.
Okay.
Yeah.
So the next we have, I think the next speaker has not yet joined, but then we have Dr. Sharmila and Dr. Sharmila with us. I can see Dr. Sharmila.
Yeah,
So
just a second, ma'am. I just connect with my phone.
Okay, can we have your presentation, Dr. Sharmila?
It will be oral and demo presentation, ma'am. Yeah, I will press. I do. Give you 2 minutes.
Okay, okay. So let me introduce Dr. Sharmila to all of us. Dr. V. Sharmila Devi, she has done her Masters of Physiotherapy in Pediatrics, and she's a certified oculo-neuro rehabilitation therapist from USA. She's a certified neuromanual therapist, and she's also the director of Indian Ergonomic Healthcare. Dr. Sharmila is going to give us you're going to deliver a topic on ergonomical care which needs to be taken during pregnancy. We have talked a lot about antenatal exercises, postnatal exercises, lactation, labor, and whatnot. But a very important factor which should not be missed upon is to take care the work ergonomics, to take care about the postures and to prevent the dysfunction rather than to cure them. So with this, I would really like Dr. Sharmila to please join us, to please start your presentation. You can you can on your audio and video, and you can start your screen sharing.
Hello, hi everyone. Am I audible, ma'am?
Yes, yes, you are audible.
Yes. Yeah. Hello, hi everyone. Very good afternoon. I take my pleasure to thank our group, Dara especially, and the IAP Women's Cell, and everyone, all the organizing team for giving me the opportunity. So let me straight away go to my topic, that is ergonomical care during pregnancy. And you all might know about ergonomics. Ergonomics is nothing but the fitting a job or a work or an activity for an employee or an individual. That's it. That is fitting an activity for an individual is the ergonomics. The activity may be from that is household activity, even that household activity is a laborer's activity, to the work site, any office work or any occupational, that is in manufacturing company. Any activity that we do in our ADL is said to be an ergonomics. Okay. Yeah. Okay. So usually the most of we do ergonomic analysis and provide a ergonomic recommendation for an occupational task. Usually there are more studies in under ergonomic analysis, that is for school going students, teachers, and how to lift a box, like that. And very few literature and very few study have done on the that is childbirth on pregnancy. So actually previous, that is the name labor itself have mentioned, that is a laborer's work. Childbirth is a laborer's work. That's why my screen is changing on. Okay, so childbirth is also a laborer's work, and for that ergonomic design has to be performed and ergonomic analysis have to be done. One study recently I went through, that is ergo design for childbirth. That was beautifully explained about the each stages of labor and different position of labor, its side effect, its advantageous position for labor, everything they have explained a lot. That is the only study which that is that done on labor, ergonomic during a labor. That is all through the 3 phases of labor. So that is the only study. So very few literature, very few study have done. So we have to work on it. Actually, before getting into the labor, that is all through the pregnancy from the first week toward the labor has to be considered because all through the pregnancy leads to a good labor. That is good position for a child to adapt and get delivered. So all through it is economic analysis on all through the pregnancy, all through the trimester is important. Very few studies have done, and that too very few concepts, very few scenarios have taken and have analysis. But whole complete posture from head to foot, or most important pelvic posture, even that pelvic posture and ergonomic analysis tool, those were lagging. So we have to do a more research on an ergonomical part upon phases of pregnancy. So this is one thing. And upon posture, that is, as I said earlier, ergonomics is, I am a follower and a student of American Posture Institute, that is Krista Bond. I am a student of Krista Bond. Usually what people do is, under ergonomics, they will give a preference to a environmental aspect of ergonomics. That is, they will analyze office chair. They will give recommendation of what chair to choose, what table to choose, how that box has to lift. So environmental aspect, more is given to the environmental aspect. But what Krista had defined the ergonomics is, she defined in 4 categories, that is postural ergonomics. First thing is a postural ergonomics or structural ergonomics, and the second is the functional ergonomics. Third is a brain-based ergonomics, and fourth is the environmental aspects. So all these 4 aspects have to be studied of all 4 aspects of ergonomic concept has to be studied in all 4 stages, that is all stages of pregnancy. So that is all through these postural assessment, whatever the case. So I am following all those things, and okay. So that is today, like if we analyze a posture, there are a lot of postural defect is there during pregnancy. That is because of the anterior weight shift, because of the baby bump, there will be an anterior weight shift, anterior pelvic tilt will be there, and because of the anterior pelvic tilt or the increased lordosis, and will happen that because of the increased lordosis, straight away if we move upward, there will be a forward round head posture, and forward head posture will be happening. And if we move descend down, there will be a hyperextension knee and flat foot. It ends up in flat foot. So because of that simple concept, that is anterior pelvic tilt, and because of anterior shift of center of gravity, all through the changes happens from head to foot, and we cannot constrain with change, that is correcting the posture at one point. We have to manage all through from the head to foot in order to prevent a back pain or sacroiliac pain during the pregnancy, and in order to provide a good position. That is, in a womb, there are three things we have to consider when we are into posture. That is, a child during labor, it will end up in that is, the child will rotate and move out of the birth canal through the anterior position. That is a very advantageous position. And second is, a child move through the birth canal through posterior position. That is occiput. That is in close approximate with the spine of the mother. That is very hard. It takes a lot of time to get delivered. Okay, third is this. Third will be breech delivery. It will be end up in cesarean mostly. So why I am saying this anterior and posterior position of that is a rotation of a child. It depends upon this will happen during the labor stage, and this position of a child, it depends on how we are adapting the posture during all through the pregnancy from the very first month. That is how our pelvic floor muscles and how core muscle and how the gluteal muscle, everything plays an important role. I say you a simple example because if I speak about the whole postural system, it will take a lot. So I speak about a sitting posture during pregnancy. Okay, I take this concept, sitting posture. So ideally, how people have to sit, where we are sitting. Have you ever think where we are sitting? We are sitting on the chair. We are sitting using our buttock. And where on the buttock we are sitting? The ideal position to sit is by using the ischial tuberosity. How we have to feel that ischial tuberosity? How we can find that we are sitting over the ischial tuberosity? That is, if we sit in the chair comfortably with the foot over the ground, we have to instruct the person to contract the gluteus. How to contract the gluteus? If we contract the gluteus, a bony prominent will touch the chair, or you place your hand under your buttocks. Okay, under your gluteus. If we instruct the person to contract your gluteus, a bony prominent will be feel over the hand. That is the ischial tuberosity. Through the ischial tuberosity, you have to sit in the chair. This is the ideal posture we can instruct the person, whoever. That is not a pregnant woman, to whoever, this is the ideal posture to sit in an office chair or anywhere. So, in this sitting posture, if we sit in this posture, that will be optimal and give more space. And if we sit in this posture and if we keep the pelvis leg apart, it will give that is open the pelvis, and the child will rotate and move. It gives, in simple word, it gives a room for the baby. Okay, if we sit in the over the ischial tuberosity, it will give a room for a baby with the legs apart. Okay, so what happened if the person is tilting already? Mom will be having an anterior pelvic tilt. Along with it, if a mom is further tilting a pelvis anteriorly, what happened? It will lock the pelvis. So this is one case. It will tighten up the pelvic floor muscle, and that is the rotational process, and that leads to abnormal tightening of pelvic floor, and the child which is coming during the labor, it takes a lot of time. And what happened if a person is slouched? What happened if a person is slouched is, this will pelvis goes to the posterior pelvic tilt. Pelvis goes to posterior tilt. If a woman is practicing or sitting a long time over this posterior pelvic tilt posture over the sofa or in chair, what happens is the child won't rotate. That is, the child will be presenting with the posterior presentation. While processing through the birth canal, the child will be in the position of posterior position. So while all through the pregnancy, we have to instruct the mother to not to adopt this slouched position. Even if they want, they can adopt the anterior pelvic tilt. Even if they are adopting a slouch position, that should not be maintained for a long time. So this is a most important thing. This slouch position have an influence over the position of a child while during labor. It also determines whether it goes up in the normal delivery or even the cesarean. So the posture during the simple sitting posture, it decides the delivery mode. So this is the concept which I tried to say. Usually, previously, what happened is we women usually will be doing a laborious activity. That is we are doing a physical activity all through the thing. That is from the sweeping the floor, or that is mostly we will be adapting a cross leg sitting over the chair or over the floor. That is cross leg sitting over the floor, and we will be adapting the knee to hand. That is kneeling position mostly to scrub the floor. And mostly that is for cutting the vegetables. Mostly we adapt the floor. Previously, that is some 10 years back and all. So our female activities will be like this. A physical activity will be there. But nowadays, people are into the sedentary activities. That is, they're constrained within the office chair. Even if the company is giving a maternity leave, they will be sitting under the sofa, sitting on the sofa. They will be using a laptop. Even that too as sedentary. There is no physical activity. Physical activity is there, and also there is no pelvic mobility. As they are constrained into chair, there is no pelvic mobility. Now, if you consider that is one group of women mostly is going to an office, that is computer work, and another group of people are in the teaching line. So proportionately, a teacher also, if they have taken a 3 or 4 class, remaining hours they will be constrained into sitting. So sitting is mostly adapted. Nowadays, even the two as they are sitting for an extended period of time. That is a problem. Sitting is not a problem. How they are sitting is a problem, and how long they are sitting is a problem. So if we create an awareness over them, it will leads to a simple labor work. Okay, so what tips, that is, if the person is coming, the client is of office worker, she used to sit for a long time in chair, office chair. There is no other go. So what advice, ergonomical advice we can give as a physiotherapist and ergonomic practitioner is, that is ischial sit. We have to instruct them, we have to teach them, and we have to train them. Another thing, that is mostly while sitting, they will forget to activate the gluteus, and also they will forget to activate the abdominal muscle. Both these things are most important, not only for while during pregnancy, that even before pre-pregnancy, it is more important. Why? Because it determines the pelvic floor muscle strength. So we have to teach them how to activate, contract the vagina, contract the gluteus, contract the abdominal muscle, tuck in the abdomen, activate the abdomen. As like a posture break is, that is posture reminder is set on a clock. This activation break, that is, this activation may not be activation exercise cannot we cannot may not instruct this to practice over the break, ergonomic break time. Even while at work they can practice without knowing to any of the colleague. Okay, so simple task they can do. And also for a posture, one that is a key point. There are two. There always in our body, the posture will be determined by the proximal segment and by the distal segment. So if a pelvic tilt is not maintained, if a person is not sitting properly, and they will be slouched, as they, because of the baby pump, there will be an anterior pelvic tilt will be there. They will have adapt a posture of rounded shoulder and forwarded posture. So we can utilize to change to activate that pelvic tilt. We can use the proximal key from the head. We can activate our pelvis mobility through our neck. How we can do is, as the woman is adapting this forwarded posture, because of higher lordosis, they will be that is for visibility. What they adapt is, with the external neck, they will adopt a positive head posture, and usually they will, because of laxity, pregnant women have a temporomandibular joint laxity will be there, and have a temporomandibular pain. So what this may aggravate the upper back pain. That is, as that will be due to a posture change, increased lordosis, thoracic kyphosis will be there, increase. So altogether, what it can lead is, it will increase the temporomandibular pain, and also from the early pregnancy toward the late pregnancy, there will be a shortness of breath will be there. Initially, due to increased level of progesterone, there will be a shortness of breath. Later, because of the higher level, that is, the uterus goes up, it will push the diaphragm to 4 centimeter upward and the lungs. So it will decrease the breathing capability. So what we can do is, what happened because of this forwarded posture and anterior pelvic tilt posture is, so the airway get narrowed. So how we can change and how we can teach altogether with simple exercises. Usually we will teach. Even this you can follow for any patient who coming for neck pain. Okay, usually we will teach a chin tuck exercise. This chin tuck exercise we will be instructing. Okay, what happened in this chin tuck exercises? Even if you perform this and you can make a feel, there will be a shortness. The breathing will be little difficult comparing to the normal position. In this position, you can breathe normally. If you do chin tuck, some patient may hold a breath. So as airway will be narrowed, and in this position, the temporomandibular joint goes backward comparing to the normal head posture. So what happened is, altogether it will narrow the airway. So how do you have to teach this chin tuck exercises? We have to instruct the person to open the mouth or glide the lower jaw anteriorly, and have to perform the chin tuck exercise like this. Open the mouth and move the jaw forward. and have to breathe normal. This you follow. If we follow, it will relax the muscles around the neck and around the shoulder, everything. So it will be, breathing will be quite normal. It won't be create any suffocation for a pregnant woman or for breathing. Already as they are having a breathing shortness of breath, if the person is coming with neck pain, woman is having neck pain or temperamental pain, means you have to teach like this. Okay, so and for round shoulder, and as diaphragm is a knot position, so you have to teach a diaphragmatic breathing position, and also as there is round shoulder in sitting. This exercise we can teach at workplace itself. Okay, with the this pelvic pectoral stretch and all those shoulder circumflexion, every postural exercise that we teach for a normal office worker, we have to teach them in sitting posture. And another most important is this pelvic tilt and pelvic tilt exercise. This pelvic tilt exercise nowadays, even for office worker, they are providing with these Swiss ball. They are at the work break, they can use that Swiss ball for their pelvic tilt exercises and all. So these simple, and also while on sitting, the legs should not hang. It may lead to a varicose vein. Okay, due to accumulation of fluid and increased pressure. So we have to instruct them not to hang the leg. Okay, another thing during work, that is during a work break, what we can instruct them is, that is modified sitting is, if there is any, that is even, they can do it, they can use it in home even. Okay, they can use a stool of low stool, that is like footstool. They can use that footstool and sit on the footstool. So it will give a squatting position, that is supported squatting position with the abducted leg. Okay, this will help in the labor during the late stage. So what are all the advantages that we can utilize over sitting with a good posture? We can advise them. So with this, I may end up. I hope you all understand how we can use the sitting posture in a right way and how it have a great influence over the phases of labor. I hope you could understand. Thank you, Dara ma'am. Happy to see Samiksha ma'am.
Long time no see. How are you?
Yeah. I think Samiksha ma'am.
Dr. Dhara.
Yeah, thank you very much, Dr. Sharmila, for your wonderful presentation. And we have Dr. Samiksha Gupta here. So I think, Dr. Samiksha, then we shall start with your presentation.
Yeah, definitely, ma'am. We can start. Can you see my screen? Is my screen visible to you now?
No, your screen is still not visible.
Okay.
Let me do one thing. Let me run your PPT.
Yeah, okay. Thank you so much.
Let me do that.
Okay.
Share पे click करो.
I'll
Share नहीं है.
I'll open your PPT. Do not worry.
Share पे click करो.
Okay, okay.
Down नीचे.
Yes. So, is my screen visible?
Yeah, but your the PPT is not visible right now.
Yeah, it would be now.
Okay. Thank you so much, Dhara ma'am. Actually, you were running this, so finally, and there was an interruption because of me, and sorry for that from my side. And thank you, IAP, for setting such a nice platform for the speakers and for the listeners. Right now, my topic, which is given to me, is enhancing the role of physiotherapy in management of back pain through pelvic floor activation. So please change the slide. This is basically a very nice topic, which is very close to my heart. I've been practicing regularly in my clinic, and it is there are wonderful results of it. I'll show you the things later on. We all know the basic things. We'll go fast forward with it, that pelvic floor is a basic tempoline-like muscle which hold the viscerals from like urinary bladder, the uterus, the rectum over it, and it has a functionality which works like a trampoline downwards from up and down. And side to side, it runs from both the tuberosities, right to left, and from anterior to posterior, from the pubic bone to the coccyx. So this basically trampoline has not only the function of giving stability and holding the organ, but its functionality also works like it has the sphincteric function also. So here we are talking more about the stability of it. Please change the slide. Let us have a short review of the pelvic floor muscles. This picture can be clearly will be showing the layer 1, layer 2, and layer 3. The first layer, it consists of the Hpc Cavernosis muscle, which you can say it's going on sideways from up to down. Virgo Cavernosis muscle, which is around the vaginal orifice. The superficial transverse perineal muscle, which is the transverse muscle starting from the perineal body to the lateral sides, and last the external anal sphincter. This is the first layer of the pelvic floor, and the second layer is more of the sphincteric function. First is external urethral sphincter muscle, and next is compressor urethrae and urethral vaginal sphincter. So this is the second layer, and third layer is major layer, which is levator ani, which we'll be talking about. It provides stability, and it consists of ileococcygis, ischiococcygis, and pubococcygis. Please change the slide. This picture I have added here to have a view of a perineal body. Perineal body is it is at the middle part over here. We can say just in between the vaginal orifice and the anal sphincter. So it works like a pivot to the entire pelvic floor. For stabilizing function and for activating. This is the most important trigger point which we can use with our equipment later on. Please change the slide. Hello, can you please change the slide? Yeah. The function of pelvic floor are this: it supports the internal organs, it has the sphincteric functions, urethral, vaginal, and rectal sphincter controls, it has sexual functions, and also it works as a slump pump activation for the venous and lymphatic drainage. So, and also it provides the stability to the pelvic joints. It is not only these functions are enough, even please change the slide. It also works for other functions, like it is very important in sexual functions. Also, it gives lumbar stability along with the pelvic stability, because only when the pelvis is stable, thereafter the lumbar stability will be there. And later on, it also works with diaphragm, and it helps in breathing also. So these are the major functions of the pelvic floor. Please change the slide. When we talk about the core, it consists of the 4 major walls inside our torso. Upside, it is a diaphragm. Downwards, it is pelvic floor muscles. Posterior, on the back side, there are back muscles, mainly multifidus. And anteriorly, it covers the transverse abdominis. So it completely forms a course right now, which we'll be talking about. Please move the slide. Basically, this picture shows that the abdominal wall, respiratory, and pelvic diaphragm create a functional cylinder-like structure. This cylinder is created by muscles that must contract and become rigid in order to protect the spine and pelvis during any mechanical loading. A lot of time we are coming through mechanical loading, we are lifting weight, we are pushing, pulling things, we are sneezing, we are coughing. Whenever there is a mechanical either loading or there is a Valsalva type maneuver, entirely on the entire abdominal wall and inside the cylinder, it has to be strong enough to combat that compressive force. In some patients, the pelvic diaphragm does not contract. This causes weakness of the entire support system. That's why. Please change the slide. As the abdominal muscles, respiratory and pelvic diaphragm contracts, the intra-abdominal pressure increases, and this intra-abdominal pressure is equal everywhere, equal on the diaphragm, on the abdominal muscles, on the back, as well as on the pelvic floor muscles. The entire abdomen becomes more rigid and is able to transmit the greater mechanical forces without hurting the spine or pelvic joint, only if all the muscles are strong enough. Please change the slide. This picture we can better understand by this balloon model. If we press it from the middle part, superior it is diaphragm, below it is pelvic floor, on the right side there is spinal muscles, and on the left side there is the abdominal muscles. So if it is punctured from one side earlier, there is a small hole, then the entire air will flow outside from that. So this small model can tell you anywhere if there is any weakness in muscle, either it is abdominal, either it is pelvic floor, either it is any weakness in the joints or wherever. From there only the entire biomechanics of the spine and the loading system has been compromised. So this is the basic reason why, because of not recruiting the pelvic floor, low back pain occurs. Please change the slide. Please change the slide. These are the basic things we can understand in the next slide. Please change the slide, the next slide one. Yes. The intra-abdominal pressure, according to this piston diagram, whenever intra-abdominal pressure has been increased, the diaphragm functions similar to a piston within a cylinder to create an intra-abdominal pressure. The abdominal muscles from the wall of the cylinder forms the wall of the cylinder, and pelvic floor is at the bottom. So you can see entirely over the abdomen, over the abdominal muscles, over the back, over the diaphragm, over the pelvic floor, everywhere there is equal abdominal pressure is transverse, which has to be combated by a strong abdominal core. Please change the slide. We all know the diaphragm has a function, respiratory function. That is very true. But after it is working as for a respiratory function only when a minimal load is there. When the load is increased, the diaphragm's functions just steps forward next to the stabilizing function. As a load of effort of the diaphragm or load of to our body increase, the function of the diaphragm switches from purely respiratory to the stabilizing function. In most situation, it performs both function at the same time. When we are doing heavy strenuous activities, at that time it happens along with, for example, athletic activities, running, doing any gym exercises, or at that time stabilizing function has become more prominent along with the diaphragmatic respiratory function. So as the diaphragm descends within the thorax, it also causes intra-abdominal pressure to increase, and the increased intra-abdominal pressure pushes outward in all the direction and has to be met and controlled by the pelvic floor and abdominal muscle, as we said above. Please change the slide. So as we can say, wherever the point is weak, for example, in the last picture, you can see an orange area in which the SI joint is weak, in which the lumbosacral junction is weak. So there only the biomechanics will get changed because of that. And because of this altered biomechanics, later on it will affect on posture, later on it will effect on further functionality and the functional capacities of the patient. And what happens when we are not recruiting the pelvic floor muscle in our daily routine exercise protocols for the low back pain patient, at that time the problem will reoccur again and again, and the low back pain patient will not be cured for a long time. If we want long-term result, we have to recruit abdominal along with the abdominal and back muscles. So you have to recruit the pelvic floor muscles. That is very important according to this the load system I explained right now. Please change the slide. Let's have some discussion about the low back pain. Low back pain it is a number one cause of the global disability, and also the number one reason for visiting a primary healthcare provider. In our OPDs, we are maximum seeing the low back pain patients, and highest prevalence of low back pain is among women aged between 40 to 80, which we see because of this regular loading, childbirths, various type of functional activities which increase the intra-abdominal pressures, coughing, sneezing, lot of other things. So this prevalence has increased in the age group of 40 to 80. What is the link between the low back pain and pelvic floor dysfunction? There are very much literature has been proved, and a lot of literature, a lot of people have researched on this, and it has been proved that pelvic floor and low back pain has a strong correlation because of its transverse loading system. Please change the slide. the factors which are responsible for low back pain and pelvic floor dysfunctions, studies have reported that pelvic floor muscle tenderness, either it is a higher resting tone, that is hypertonus, or a decreased relaxation, and the weakness, both are associated with urinary incontinence and related with the lumbago, that is pelvic pain. So it is seriously interlinked, both the things are interlinked, and this has to be understood by all the physiotherapists who have been working and dealing with the patients regularly, so that the outcomes becomes much better in case of low back pains. Please change. Other factors are ineffective management of pelvic floor in contribution to the management of intra-abdominal pressure to support the transfer loads during functional movements. Whenever we are teaching a patient the core exercises, at that time, we are just not only recruiting the abdominals and back, we are also, at times we are regulating the breathing, and not only breathing will be enough, regularly pelvic floor activation should be recruited with that. When we are dealing with all these things together, it will be difficult for us to make the patient understand once. But once the patient understands these things, then the result will be long lasting, and the patient will definitely be able to manage small pains within herself, and there will be no recurrence again and again. And I hope the therapy will be long lasting, and it will multiply the network of patients accordingly. Please change it. Result of negligence of the pelvic floor in society is that 80% of women suffer from a pelvic floor disorder in their lifetime. 1 in 3 women struggle with urinary incontinence. 1 in 9 women need surgery due to pelvic floor problems. 50 of women after having a first surgery will definitely require second or third or fourth surgery for the same issue. I have seen many patients of the same category from last few years that once they have gone through surgery for some hernia, for a diastasis, after some time they are getting the same problem again because of the abdominal muscles. So that is also a big chapter. So we have to cure it without any surgical interventions. That will be a better option, and recruitment of pelvic floor is the best thing to combat with. The last but most important myth is that the pelvic floor issues are isolated to childbirth issues only, but that is not true. It is not only related to childbearing time, but before also and after also the childbearing period, pelvic floor activation and recruitment in general fitness, as well as the treatment interventions and physiotherapy and everywhere, it is needed. Please change the slide. So what is the normal functionality? What is the normal movement of the diaphragm with the pelvic floor, which we should recruit? Is that when we inspire, at the time of inspiration, the pelvic floor muscle should be relaxed, and when we expire, it should be contracted. And both these things should be recruited with single each and every exercises in the OPDs. Please change the slide. For this purpose, we have a 2-step for magical integration. I thank to Dr. Desai to give us the beautiful, this innovative technology, that is pelvic floor PF360. And that is, wow, PF360 is a very nice technology. I'm also using it in my clinic. And there are 2 steps to use that. First, patient education about the core and pelvic floor, how we will educate, I'll tell it now. And next is perineal body activation. Perineal body activation, we saw in the previous slide where is the perineal body between the vaginal orifice and in between the anal sphincter. So there we have to put the head of the pointer of the pelvic PF360, one of its own technology of neuromuscular education for the core activation. And when we activate this, at that time, the patient have a mechanoreceptive stimuli, so that patient will understand where I have to contract the muscle. What I see in OPDs, maximum of the patient doesn't know where is pelvic floor located in their body and how to contract. Even if patient try to contract, the patient is either using glutei, either using the abdominal muscles, either using adductors. So we have to first isolate the muscles so that the patient can do the exercises in a proper way, and the outcome measure should be in a nice manner. So for that, we have to palpate the abdominal muscles, we have to rectify that, and there are various techniques to go through it. And the best technology right now we have is WOW PF360, because with the help of this, we need a lot of time, we doesn't need any perineal exposure, which is most of the times not comfortable for the patient. So without the perineal exposure, we can also use the PF360 on the perineal body, which can be judged easily from externally. Please change the slide. So this is basically patient education. How will we educate the patient about the core activation? Please change the slide. Yeah, please change the slide. Yes. So here we have for core muscle activation, the breathing system and the movement of the pelvic floor has to be recruited meanwhile. And for that thing, we have to put our tip of the fingers over the ASIS, one finger's middle to the ASIS, and a few fingers middle to the tip, 3 centimeter middle to the ASIS, and we can palpate the contraction of the abdominal muscle, which usually the patient do. And we have to isolate that. Thereafter, we have to see whether the patient is contracting the pelvic floor muscles or not. We have to put PF360 over the perineal body. Along with both the things, patient has to recruit both the muscles, abdominal muscles and pelvic floor muscles. When they are contracting both, meanwhile, we can progress the exercise once the patient understands breath regulation with that. First, patient has to contract both the muscles. Thereafter, breath regulation has to be done. Thereafter, the patient, we can increase it with the limb loading exercises. So gradually like this, however difficult the condition and complicated condition is there, when we start with this protocol, it is going to give a very nice effect later on. Please stay in the slide. So how will we stimulate, co-activate the pelvic floor? First, patient will be in the croup-lying position. When we are exposed here, first we have to see, we have to tell the patient how the pelvic floor muscles are contracted. For that, we have to use a handheld mirror in front of the patient's perineum, which patient can see herself, and when it is exposed, the pelvic floor muscle contraction are easily visible. So area between the rib and the pubic symphysis first is exposed. Thereafter, self-palpation by the patient along with the therapist is done for the transverse abdominis with the pelvic floor muscle activation, and posterior pelvic tilt is done. Supine progression to the functional position. So this is how we are doing it. We are just contracting the muscle, transverse abdominis. Along with that, we are doing the pelvic floor muscle contraction with WOW PF360, and we are doing a posterior pelvic tilt. Both these things have to be done meanwhile. Thereafter, once patient had understand, we have to recruit the breathing exercises, means breathe regulation with that, along with inspiration, relaxing the pelvic floor, along with expiration, contracting the pelvic floor. Once the patient understands this, we can increase to the limb loading exercise, lower limb loading, and this should be done regularly with progression, with increasing the loading of the limb. First, starting with the leg slides, thereafter 90-degree flex position, thereafter SLR. So like this, first with holding and later on with the movement, later on without holding the lower limbs one by one. So this limb loading exercises can be increased after after recruiting such. In this condition, when we are teaching the patient these things, what happens? Patient is very likely to do the trick movements. The trick movements are breath holding, abdominal sucking, abdominal bloating. That has to be avoided. We have to take care of. So most of the patients will be doing it nicely. But few patients will not be understanding it. At that time, the Higgs reflective result scale will be more helpful for us. Please stay in the slide. All of us, we are, it is everybody, when we talk about the pelvic floor exercises, everybody know about Kegel, but Kegel is not just sufficient. We have to do just more than Kegels. And this more than Kegels is what we are talking about right now. The old model is like you have to do Kegels whenever the pelvic floor exercises has been talked about. So what other things we can include in our treatment procedure to make the treatment more effective in case of low back pain is positioning and biomechanics of the patient, and body mechanics of the patient, and functional movements has to be recruited, structural changes has to be taken care of, emotional state of the patient has to be taken care of, because in hypertrophic patients, emotional state is very important. Also in case of urinary incontinence like conditions, patients very emotionally unstable at times. Next, past injury and trauma, if there was any, and awareness and education of the patient in both the things, the similar things is very important. Please change the slide. Pelvic floor muscle training and functional training technique include basically visual feedback we talked about right now and many more, transvaginal manual techniques, relaxation techniques, stretchings for the hypertrophic and tight pelvic floor muscles, pelvic floor activation and relaxation with BOW PF 360, treatment with BOW ease and fit, which we are using regularly, have a very nice effect and very good mechanoreceptive stimuli to the patient. Treatment with various physiotherapy modalities, cryotherapy, pelvic ring drop training, vaginal cones, and many more things are there which we can use for the recruitment and treatment of the pelvic floor muscle if there is any type of problem with the pelvic floor muscle are there. Please stay in the slide. So what is the final take-home message with that? What I suggest personally is that we have to screen each and every female patient in our OPD with low back pain for pelvic floor dysfunctions, any hip pain or any case, we have to go for a pelvic floor dysfunctions. So we can have an idea, either we have to be more cautious for the pelvic floor or not. Further on, we can aware the patient for the forthcoming problems. Next, we have to develop the skills to assess, to treat both the states of pelvic floor dysfunction, either it is hypertonic or hypertrophic or hypotonic, both these conditions, and weakness should be treated with the internal assessment if there is any finally. So this was my presentation for this topic. I hope it will be helpful for us, and thanks a lot to Hey Desai sir for giving us these wonderful technologies and for making this helpful for all of us. Thank you, Dhara ma'am. Thank you everyone for listening me.
Dr. Samiksha for a wonderful presentation on low back pain, and I'm sure that many those who low back pain is a very commonly occurring condition which many of us are treating into our routine, and this will definitely help us to understand the other aspect of low back pain as well. And with this, I would really like to call upon our next speaker. That she's Dr. Rajisha. She's an associate professor at St. John's Medical College, has completed her bachelor's from Niti Institute of Physiotherapy and her master's in cardiorespiratory from and general physiotherapy from Oxford College of Physiotherapy. She's passionate about women's health, and she's a women's health physiotherapist, and has given actively involved with different NGOs, MNCs, including Infosys, Hero Group, and she is involved in bringing awareness of physiotherapy in obstetrics and gynecology. She has been recognized by RGUHS for her contribution in the field, and she has many papers published in national and international journals, and is at the forefront of the research in the field of women's health physiotherapy. So let us welcome Dr. Rajisha. Are you there? Dr. Rajisha, you can start your presentation. Dr. Rajisha, kindly unmute yourself.
Good afternoon. Good afternoon, Dara. Thank you so much for inviting me for such a wonderful webinar. I see Dr. Ali Rani is also there. I'm currently pursuing my PhD under Sir. With that, we will directly start with my topic today. Dara, the video is not working. It is coming as host has stopped it. Can you do something about it?
Dr. Manisha ma'am, can you just take care of it? She's unable to play her video.
One moment.
Yeah.
Yes, it is visible now.
Yes. Is the slides visible?
The slides are not visible.
Now?
Yeah, it has started.
Yeah.
Yes, it is.
Okay, so thank you so much for inviting me. I'll directly start with the session. The topic allotted to me was postnatal weight management. Today, I'm not going to speak only as a physiotherapist, but as a mother myself and someone who has struggled with postnatal weight again and again and again. It's a big cycle where I have gained weight and lost it and again gained weight. So these are things that have experienced first-handedly as well as through my patients as well. Before going into the weight management of it, I'll just want to introduce two terms, that is gestational weight gain, which is often called as GWG, and postpartum weight retention, that is PPWR. So these both are extremely important because we will be discussing about this in depth. So gestational weight gain, it is a total amount of weight gained in normal term pregnancies since the conception to 34th week post-pregnancy. During pregnancy. So the whole gestational weight gain, the term has three components, that is the maternal component, the placental component, and the fetal component. The maternal component comprises of fat mass, fat-free mass, and the total water body, body water in the body. The placental component would be having the placental weight due to the placental growth component and the development component. Fetal component again has amniotic fluid as well as the fetal growth component. Both fat mass and fat-free mass has to be considered. Now weight gain, especially the gestational weight gain, is going to differ from person to person. For each one of us, it is going to be different. There has been many studies, I have given the references later on, where we have seen a very good relationship between the pre-pregnancy BMI and the GWG. So these both are inversely proportional. Higher the BMI of the person pre-pregnancy state, the lower is the weight gain during the gestation. Even throughout the pregnancy, also the first trimester, second trimester, and third trimester, the second trimester seems to be the place where we start gaining at a faster rate. Now that can be contributed to the fetal growth, the placental growth, etc. Now, if you look at the potential determinants, it can have three common factors, that is your social factor, the environmental factor, and maternal factor, and the energy balance. So in social and environmental factor, it is a culture, the family, the living environment. So often in India, we see that lower income families tend to take carbohydrates as the main part of the diet, which will ultimately increase the GWD. Even the culture of it, that, especially the eating for two, component of it, you're pregnant, just the calorie difference is going to be just 200 kilocalories, which can be gained from a glass of milk. But because of the awareness being less and the education not being there, often we hear especially women itself would tell other women that you should be eating well now, you should be eating for two people now. No, that is not required. So that is there in our culture itself. The family, I already spoke about the low income families and the living environments. Now maternal factors such as the ethnicity, genetics, and comorbidities that the mother has, whether the pre-pregnancy BMI was underweight or overweight or obese, depending on that also we can get look at the GWG. Now it is calculated as the pre-pregnancy weight and the 34th week weight. When you take the difference of it, it would give you the GWG. Now, Institute of Medicine have given guidelines for GWG. Even the Indian Association of OBGs, as well as Karnataka, that is Kasuga OBG associations, also actually adopt this one. Where if the BMI, this is a relationship between how much your BMI is and how much is the weight that you should be gaining, ideally in a normal pregnancy throughout the gestational period. So less than 18.5 would, the requirement would be around 12.5 to 18 kgs. 18.5 to 2.4, 24.9 BMI, if you have, then it would be somewhere around 11.5 to 16 kgs. 25 to 29.9, it would be around 7 to 11.5 kgs, and 30 above, that is the obese category, would be expected to gain only 5 to 9. So as I said earlier, there is an inverse relationship between the pre-pregnancy BMI and the pregnancy weight. Now coming to postpartum weight retention, PPWR it is called. So these many research has shown that the pregnancy and the first year postpartum, this seems to be affecting the weight management area of women, especially on a longer run. So it is variable. The weight retention that happens is variable, with women averaging around anywhere between 1 to 5 kgs of increase at around 6 to 12 months postpartum. Importantly, this weight reduction during the childbirth bearing years can substantially alter women's lifetime weight gain trajectory. So if you have a higher amount of weight retention, postpartum weight retention, over the years, there is very less chances that you're going to reduce it, if not looked upon specifically. So the trajectory will also be affected. Now coming to the Indian scenario, PPWR as well as the obesity has become a major concern in Indian society. Prior, it was not like that, because soon after delivery, they used to go back and do their normal chores, which was pretty physically demanding. But right now, seeing the modern nuclear family setup, often pregnancy itself is taken as a pathological condition instead of a normal physiological condition. So people start taking full bed rest. There is absolutely no physical activity going on, and so on and so forth, which have increased the obese women in India to a higher statistics. So public health concern has been woken up, and there are programs introduced by the government under mother and child health care program as well. Now, especially the eat for two mentality, as we spoke, even in the postpartum period, there are traditional methods of treatment, especially down south. We have this 56 days of no physical activities and high carbohydrate diet, which they say helps with the lactation, but through research and through science right now, we know that it's not the carbohydrates, the protein that is needed for lactation. So this one problem, that eat for two mentality, has to be taken care of. Often as a physiotherapist, we should be, if we see that there is a abnormal or unnecessary gain in weight during the pregnancy period, it is our responsibility to have a counseling session with them and get them the required help. Now, there is poor awareness about what is to be done in case of retention, and poor dietary habits. Our main component still is the carbohydrates. It's not a balanced diet, it's more of carbohydrates. So that also needs to be looked at. Now, what are the risk factors of postpartum weight reduction? One is gestational weight gain, which was excess, which was out of control. So I don't know if you have come across this. I don't know if you have come across this, but Kim Kardashian had told in the first pregnancy that, you know what, I eat a full pizza now because anyway, I'm going to get fat. So that seems to be the normal mentality of Indian women as well. So excess weight gain during that period of time is going to have a very bad impact later on. Now, pre-pregnancy weight or pregnancy BMI being higher is also posing an issue. Shorter duration of breastfeeding, that is, women tend to stop breastfeeding and start them on formulas or so and so forth. That is going to have an issue. Serum vitamin D seems to be a major concern because there is an inverse association with obesity. That is, if the vitamin D is lesser, there is higher amount of adipose tissue being collected in. The GL, that is the glycemic load during the pregnancy, that is how much amount of high glycemic index food have been taken by the person. Now, there are possible confounding factors as well, like your age, dietary habits of a person, and the level of physical activity that the person has prior, during, and in the post-delivery phase. Now, if you ask any women what are the main problems that they are facing as far as weight is concerned, this would be the major component, that is barrier to physical activity. Now, as we were telling that prior, we had a very good support system. We had a joint family where kids were taken care of by aunts, uncles, and the supporting family. But now we have moved from a joint family to a nuclear family setup, where the child's primary carer is the mother. So yes, of course, there is an issue with not having enough time for it, as well as not having enough space for it, because even the the space, the availability of time, the environmental factors do count as far as physical activity is concerned. Now, sleep deprivation is one of the major concerns, because to feed the baby, we'll be getting up even at night every 2 hours or 3 hours as the baby wakes up. Sleep is essentially needed for a good metabolism, a balanced metabolism as well. Now, lack of knowledge, impact of postnatal diet, what is the diet that they are having, the amount of carbs, the amount of fat that is being that is there in the diet as well. Lack of motivation, time, and support. Yes, as I told earlier, the primary caregiver becomes the mother itself. So there isn't much time for her to go away from her child and do a physical activity. So there wouldn't be a second hand to help or look after the child when the mother steps out. Then yes, the motivation part of it, I'm already married, one kid is there now, this is normal. So normalizing the problems of women have been a trend that we have seen throughout Indian history, and that needs to change. That even when we are mothers, our quality of life should be looked at. Whether we are able to run around with the baby, we are able to do the mother's role properly or no. So often this motivation seems to be a major concern, because anyway married, one kid is done now. Even if I look like one pumpkin also doesn't matter. So that should not be the mental mentality towards it. So as physiotherapists, if we ever find patients who are having such mentality, it is a good idea to have them into a counseling session. And we often, because the amount of time that we spent with the clients, we often become a sort of counselor ourselves. So motivation is another issue. Stress and depression. Now the stress part of it increases the cortisol in our body, which is a flight and fight hormone. We'll be talking about it in detail later. And eating for psychological or physiological comfort. Whenever there is a threat or perceived threat, we normally go and look at high carb food, or high calorie food. So that eating or binge eating, what we call, or stress eating, what we call. So that also seems to be one of the major problems that women are facing currently. What are the complications of this? Poor maternal and infant outcomes. Yes, the family's health actually depends on the health of the mother, health of the women of the family. So if the mother is weak, then everything else gets affected ultimately. Health issues for the mother, like your heart, cardiovascular diseases, musculoskeletal diseases, knee pain, back pain, neck pain, all these things seems to be major complications of weight retention, and psychological and physical effects as well. How do we combat it? It is always better to prevent it than going ahead and curing it. So prevention is gestational and postpartum period is very important, especially the first 1 year after delivery. So in this time period, you should be having good balanced diet, which has all the macro and the micronutrients as required. Physical activity according to the trimester. So in the trimester itself, if you're gaining according to the guidelines of IOM, then there is no issue. It is much more easier for us to go back to our pre-pregnancy weight. But if you are not doing that, then there might be difficulty later on. So even the physical activity during the trimester is very important. We often have antenatal classes. So that is a good way of keeping the weight in control, as well as asking them to have a brisk walk, at least 20 to 30 minutes, not lying down after immediately after food, and so on and so forth can be introduced to them, and the education can be given to them. Now, this is a precede and proceed model where we have actually proposed 6 themes under 3 main predisposing factors. So the first one is the predisposing factor, next is the enabling factor, and the last one is the reinforcing factors. Now, theme 1, motivation to have a healthy baby. So during the pregnancy, one of the most important motivation that you can ever give to a mother would be to have a good outcome of the pregnancy, that is a healthy baby during the pregnancy, and after the pregnancy to get back my pre-pregnancy body. Now, whether it is entirely possible, no, but to get physically fit, it is possible. Okay. Theme 2, I have very heartfelt goals, that is pre-pregnancy knowledge is the experience that the person have gone through, the experience and the knowledge that the person has of pregnancy and the postpartum period as well. So I often say that more than what I have learned from textbooks, I learned it through my own experience of having 2 babies. So yeah, that is sort of, the second theme, where we have our own goals and our own knowledge, our own perceptions and experiences. Now, the enabling factors would be, theme 3 would be the prioritizing wellness during pregnancy and postpartum sustained behavioral changes. That is the wellness during the pregnancy, the exercises, the diet, having proper, even mental peace during that period of time, and taking that to the postnatal period also, or the postpartum period also is important. Then the social support, that is the power of the social support, as the old saying goes, it takes a village to take care of a baby. So if we have proper social support, then it's going to be much more easier for us to one, stick to the good behaviors, and if we didn't, then we have ended up with the retention, then to take care of that as well. Now, the reinforcing factors, accountability. It is a good idea to have weight loss buddies or weight management buddies, where the physio can put 2 or 3 people in a group and then give the exercises, so that they are accountable to each other also. Integration with technology to reinforce behavioral change. Yes. So now we have WhatsApp and Insta and Facebook and whatnot. So it's very easy to keep, reinforcing and encouraging others as well. So all of these components interact, and healthy behavioral changes brought about, weight related self-management can be brought about, and we can have a healthy gain of weight during the pregnancy, and postpartum weight loss or management in the postpartum period as well. These are components of it as far as the behavior is concerned. The capability, that is the physical and the psychological capability of the person to do something, the motivation, that is the reflective motivation or automatic motivation. Automatic motivations are habits or physiological drives of the person, and the social opportunity like social norms, support, pressure from others, physical opportunity like the finance, time, resources, etc. So all this together have a direct effect on the behavior during the pregnancy as well as in the postnatal period. Now, when you're looking at the evaluation, other than the physical fitness evaluation, one thing I wanted to stress upon is do not look at the weight, the number, the digits over the weighing machine, but instead look at the inch that you have lost. So this is a measurement tracker where you take the measurements of the given areas, that is a chest, right arm, left arm, waist, hips, thigh, left and right, and weight of the person comes last. So to keep all these things on the first day of the exercise program, and then later when they finish the exercise program, the same measurements can be taken, and the difference would give you how many inches you have lost. Steps in weight management. So first is identification, then second is reflection, find what is wrong. Third is assess and set a achievable goal, action, tracking, achievement of goals, and maintenance. Now, identification seems to be the most important part. Often women say that, up to ho gaya, like I have already given birth, now I will never be able to go back to my body. So it's okay for me being like this, or sometimes they do have a denial as well in their mind, in their perception. Their body would would not have actually gained weight. So that also needs to be looked at into a psychological aspect also, but identification of the problem seems to be the most important part, and physios are at forefront to make sure that it happens properly. So during the postnatal visits, if you have a program running in your setup and you have the postnatal visits at around 3rd month, it is good to have a physical fitness evaluation of the person done, and ask them look at the BMI of the person, and give the feedback or give the education to the person that you are overweight or underweight and you need to do this and this and this. So reflection, find what is wrong. Now, this is going to be a self-motivated part. We have to find where we are lacking. Like, I am lacking in maintaining the weight, or I tend to get overconfident that I can lose weight when I want to, and then I start overeating. So such things, such reflections, such evaluation of self is very much important to find where what is being lacked by each person, and then working on it. Now, the assessment and setting of the goal, it should not be like, the person is 80 kg and your goal is to reach 50 kg. It should not be like that. Instead of that, you give small goals, okay, short-term goals. Within 1 month, you're going to lose 1.5 to 2 kgs. That's something which is acceptable and achievable. But if you give a goal as 10 kgs I want to lose, that is not going to happen in a healthy way. Now, you have to take an action about it. You have to track your progress. Not only action, it is a good idea to actually have a fitness diary with them, so that they can actually put on day 1, this is what I have done, day 2, this is what I have done. Okay, so tracking also should be done. Regular follow-up with the physiotherapist has to be done. Once the achievement of goal is there, then maintenance have to be done. I am not the right person to talk about it because I really don't maintain my weight. I reach my target weight and then I put on again. So that needs a lot of correction from my side as well. Components of weight management, there are 4 components, that is the psychological, hormonal, diet, and exercise. Now, in the psychological component, if you see, denial is often one of the most important thing that we will come across in new mothers. And law of inertia, that is tomorrow is the day, not today, tomorrow onwards I'll start doing it. Or we look for the best muhurta. Okay, so that is never going to happen. Then depression, stress eating, binge eating, overconfidence. Once you lose weight, being overconfident and getting back to eating unhealthy and gaining the weight all over again. So these are going to be your major concerns or psychological concerns behind weight gain. As far as the hormones are considered, cortisol, insulin, leptin, and ghrelin, these 2 are the hunger and safety.
Sorry
Yes.
to interrupt, but we are running short of time, so if you can just quickly.
Yes. So these are some of the hormones that play a very important role, especially the cortisol, because stress and the sleep deprivation is going to have a very bad effect on you. I'll quickly run across. Now, as far as diet is concerned, do not have any fat diets, no keto diet and intermittent fasting while you are feeding the baby. It is always best to have a balanced diet with macro and micronutrients. So if your grandmother has eaten it, then you can as well. Now, coming to the exercise part of it, in the first 6 months, it is prescribed to be a moderate intensity exercises. That is 3 to 5 days per week. MHR should be around, THR, that is intensity should be around THR, target heart rate should be around 40 to 50% through your Carbonance formula, or RP around 13 should be the rate. Time around 20 to 25 minutes, and best is a circuit training where a core, 3 minutes of strength, 2 minutes of cardio, lighter cardio, and 1 minute of core should be looked at, especially the pelvic floor muscle activation, the pelvic floor re-education along with the programs, along with the exercises should be stressed upon. Now, coming to post 6 months, you can actually start with high intensity exercises, 5 days per week, THR around 60 to 80%, and RHR, RP around 15 to 70. Time you can increase up to 40 to 60 minutes, and type you can give a high intensity exercise or circuit training, again with the 3-to-1 protocol, but with higher strength training, higher high impact cardio, as well as 1 minute of core. The 1 minute of core and the pelvic floor muscle has to be reinforced again and again. Now, coming to the tips, aerobic exercise do burn the fat, and strength training builds the lean muscle, which invariably increases the metabolic rate and helps to maintain a healthy weight. You have to remember your core and your pelvic floor muscles always, and train the person according to that. Look at your inches, but not your weight, okay? Because 2 kgs of fat and this muscle, 2 kg of muscle, you can see the space that it is occupying. Exercise tips, you have to first work on the form of the exercise, and when the progression starts, the form should be really good. The reference points of each exercise should be told, and that should be corrected, and then only progress to the next level. Resistance after can be introduced only after the person have achieved a correct form. Superimpose, make most of your workout, that is upper body and lower body, you can work out together. You can do back rows along with squatting, so that the amount of time is lesser. So these exercises can be taught to the mother, which can be done at home itself along with the baby. If you use it in the right way, it can be a bonding experience for the mother to the baby as well. You don't have to hit the gym. just if you get a good physiotherapist to take out the tailored program for you and teach the reference pointers, you can do it at home as well. So these are the references, and if you have any questions.
Thank you very much, Dr. Rajisha, for a lovely presentation from your side. And not taking much time, I'm just introducing the next speaker. She is Dr. Amrit Kaur, and she's working as a professor and the principal in MVP College of Physiotherapy, Nashik. She's a gold medalist in Masters of Physiotherapy in Community-Based Rehabilitation from Dr. D.Y. Patil College of Physiotherapy. She's an author of 3 books in physiotherapy. She's a faculty for, she has received certificate course in lifestyle management and hypertension by IAPEN. She has published more than 36 research papers in national and international journals. She has received fellowship from Indian Society of Hypertension in 2019 and received Investigator of the Year award from Indian Society of Hypertension in 2017, 2018, and 2019. So over to you, Dr. Amrit, and we are looking forward to listen to you on the lifestyle modification for the gestational diabetes.
Thank you very much, Dr. Dhara. Hope I'm audible. Hello.
Yes, you are audible. There is some echo, or maybe the mic is too near.
Okay.
You can just repeat that.
It is coming that you cannot start your video because the host has stopped it. So just kindly switch on my video.
Dr. Manisha ma'am, if you can just help her out in the video.
So thank you, WOW team and organizing committee for providing me such a wonderful opportunity. So are you able to see my screen?
Yes, your screen is visible.
Okay. Thank you. So I'll start now. So my topic is lifestyle modification in gestational diabetes. And as we know, the gestational diabetes is a glucose intolerance with onset or first recognition during pregnancy. So in the women, those who have never diagnosed with the diabetes before. So gestational diabetes is a type of diabetes that occur only during pregnancy. So the stomach.
Sorry for the interruption, Dr. Amrit, but if you can just keep it on the slide sharing mode, we can see the slide listing, but the slide is not being shared.
Yeah, just a minute.
If you can just press Shift and F5 together.
Can you see now? Can you see the whole slide?
We can see the slides, but it is with the slide listing and not the slide sharing. So if you can just go to the slide.
My laptop, it is visible. I don't know why it is not coming.
You can go for slideshow. Slideshow.
Yes, I have done the slideshow. It is visible to me, the slideshow.
Okay, okay. It's not fine, no problem.
Yeah, but just a second. I'll do one thing. Now is it better?
Yes, it is better.
Okay. So the high level of glucose, which is produced when the insulin resistance is there, it will enter in the baby through placenta, and the baby's pancreas will make more insulin to handle this excess glucose. Now, the gestational diabetes affects the mother in late pregnancy. So at that time, almost the baby is fully developed, but it is still growing. So the more energy which is getting through this extra glucose, it will put extra amount of fat in the baby. So these babies are generally of higher weight. So this gestational diabetes and this higher weight can put the woman into the problem during delivery. Like these babies need to be delivered through C-section and may have a breathing problem. And as an adult in the later life, they can develop the diabetes or obesity. So in India, this prevalence of gestational diabetes is increased a lot in past few years. Like it is approximately 10 to 14%, which is much higher compared to West. And in 2010, India has the 22 million women with diabetes in the age group of 20 to 39 years. So with this high prevalence, the Indian government has released national guidelines for diagnosis and management of gestational diabetes in December 2014. So pathophysiology is the gestational diabetes. It is mainly characterized by hyperinsulinemia and insulin resistance. So in the first and the early second trimester, there is high level of insulin because of high level of estrogen. And in the late second trimester and third trimester, The insulin resistance is mainly because of number of antagonistic hormones, especially the placental lactogen, leptin, progesterone, prolactin, cortisol, and adiponectin. So this gestational diabetes will bring extra weight to the babies, plus many other health problems. So the risk factor to develop this gestational diabetes, if you are having a previous history of gestational diabetes in your first pregnancy or impaired glucose tolerance, if you are obese, ethnicity of African, Southeast Asian, and Native Americans, family history of gestational diabetes or type 2 diabetes if it is present, especially in the first degree relatives, if advanced maternal age is there, excess weight gain in pregnancy, previous history of microsomic baby, previous history of stillbirth, and many other factors.
Yeah, the video on, if you can just manage that.
The video is disabled by host. So the implication of diabetes in pregnancy. So the risk of serious birth injury, it doubles with the gestational diabetes. The type of cesarean delivery triples with the gestational diabetes. And the incidence of neonatal intensive care unit admission, again, it is 4 times higher. So, and in later life, the pregnant women who suffered with the gestational diabetes, they are more prone to develop type 2 diabetes. So when maternal hyperglycemia is there, it will decrease your cortisol production. That will again decrease surfactants in the lungs, and it will lead to respiratory distress syndrome in the neonates. In the similar way, it will also lead to polyhydramnios, fetal microsomias, and the most common defect is Erb's palsy. Congenital abnormalities, abortion, and RBC breakdown, like the risk of hyperbilirubinemia, is again very much high in the women suffering from the gestational diabetes. And even maternal complication like abortion, preterm labor, preeclampsia, polyhydramnios, and during labor, prolonged labor, shoulder dystocia, and other postnatal disorders are very common in the female with the gestational diabetes. So how you are going to diagnose it? With the symptoms and with your investigation. So mostly gestational diabetes women are asymptomatic unless and until the glucose, it is very much high in the blood. Then the insidious onset is there. The polyuria, polyphasia, and polydipsia is present. There will be a lot of fatigue in the women suffering from gestational diabetes. Sometimes even weight loss is the same. And in the severe cases, the gestational diabetes can also lead to retinopathy and neuropathy. The signs are elevated serum glucose, ketonuria, elevated HbA1C, and greater than the normal abdominal circumference. And even there, glucose tolerance tests will be affected. So target blood glucose level for pregnant women is, for pre-existing diabetes, it should be 60 to 99, between 60 to 99 for the fasting, and 100 and 129 after meals. For gestational diabetes women, it should be less than 96, and after meal, it should be less than 120. So lifestyle changes, it is very much essential in the management of gestational diabetes. The first line of treatment in gestational diabetes is medical nutrition therapy, together with the weight management and physical activity. So it has been suggested that lifestyle modification alone is sufficient to control blood glucose in 70 to 85% of women diagnosed with gestational diabetes. So the life cycle approach, which can be given for the prevention of gestational diabetes as well as managing the gestational diabetes, it is divided into pre-pregnancy phase. If you're already planning for the pregnancy, you can assess your risk factor, how much risk factor it is present in your case to develop gestational diabetes, and you can work on that with the lifestyle changes. The pregnancy phase and even the postpartum phase, as these women are more prone to develop the type 2 diabetes, so certain advices should be given to these women, like they should check their sugar level at regular interval, they should check their HbA1C, the lifestyle they should continue to follow even after delivery. Exclusive breastfeeding they should use to avoid the chances of getting type 2 diabetes, and the other healthy eating behaviors. So now we'll come to the management part of the pregnant woman. So the pregnant woman management part is, one is definitely it is very much tackled by healthy eating. Exercise part, maintaining a healthy weight, as our previous speaker also spoke, like it should be the weight gain in the pregnancy, it should be decided upon the current BMI, or your preconception BMI. Then the regular amount of sleep and the stress management. So gestational diabetes dietary guidelines is you have to gain the weight gradually. You have to combine your food groups for the blood sugar control, like the protein, carbohydrate, everything should be in appropriate amount. Then you have to gain weight according to the pre-conception BMI, and the action plan, like the individual nutritional plan, should be tailor made for the woman with the proper dietitian. So I'll be talking more about the exercise part. So the 30 minutes of exercise alone can reduce the risk of diabetes by 40%. So where to begin? So we have to use the physical activity pyramid and the FIT principle. So for every day, try to do maximum housework by yourself. So as I think previous speaker also mentioned, nowadays the pregnant women will treat themselves as if they are going through a pathological condition. So it is not like that. Pregnancy is a very normal thing, and you can definitely carry all your household chores by yourself during pregnancy. Then comes to the exercise part. At least 3 to 4 times in a week, you have to do the aerobic activities and along with the recreational activities which are safe during the pregnant time. Then at least 2 times in a week, you have to do the strength activities. Okay, so even strength activities, they are safe during pregnancy. Only it should be designed or it should be done under the supervision of a physiotherapist. So strength training and flexibility program, at least 2 times in a week, it should be provided. Plus, you should cut down the time on your idle sitting, like sitting in front of computer or TV. So you have to cut down this time of idle sitting. So for the beginners, so non-weight bearing activities, it poses the least risk of injury, and 20 to 30 minutes of activity a day at a comfortable pace should be done. The women who were previously active, so they can participate in the higher intensity exercises. Aerobic exercises are generally safe if they are already being trained in that, but the exercise at the high altitude is again not recommended. Then the weight training, the light weight and the moderate repetition will maintain the flexibility and muscle tone, and it will also reduce the risk of joint and ligament injury. So you should be able to converse while exercising, like the intensity, how you can decide for the woman is not only you have to just depend upon your heart rate. Okay, so it is always better that you prescribe the talk test. If you are able to converse between the exercise, you are doing at a comfortable pace. Listen to your body. Stop if you feel breathless, nauseatic, dizzy or tired. And the pulse of the woman, it should never exceed beyond 140 beats per minute. So the component of this exercise session, the single exercise session, it should be comprised of warm-up, stretching, conditioning and a cool-down program. Again, you can just remember the mnemonic sport, that is strength training. So strength training, again, as I told, lot of researches has been proved that the blood pressure and the glucose, it will be regularized by if you're having a good muscle mass. So strength training, again, it is a very important component for exercise training. You have to identify the barriers, the patient barriers, like the place, environment, time. Already they are having one kid and they are busy with that schedule. So you have to design the program accordingly, identify the patient's barrier and design it. Then other people, sometimes social connection, it plays an important part. So you can suggest the patient to join the local running group or the friends for the daily walk or with their partner. So the social connection is very important. Then run or walk and the time. So again, time is very important factor for the exercise. Minimum 150 to 180 minutes per week time they should find out for themselves for the exercise. Safe exercise during pregnancy. So at least be active 30 minutes a day. Never exercise to the point of exhaustion. Measure your heart rate. It should not exceed beyond 140 beats per minute. Don't lie flat on your back after the 4th month. Okay, after the first trimester, don't do exercise in supine-like position. Do not stand still for longer period. Listen to your body. Avoid dangerous sports or contact sports. Always perform warm-up before exercise. Wear comfortable clothing and exercise with your caution. So you can use this PowerMed X also for screening the patient before prescribing any exercises during pregnancy. So modifications which has to be done during pregnancy is the fetal blunt trauma should be avoided. Any activity which put the woman into the risk of falling, that should be avoided. Exercise in extreme environment that will lead to overheating should be avoided, and avoid prolonged exercise lying on the back in supine lying position, as it lead to supine hypotensive syndrome, and do not exercise to the point of exhaustion. Okay, so excessive tiring, basically in the diabetic cases, the patient will be tired soon. So you have to design the program in such a way that the patient should not feel extremely tired. So the American College of Obstetricians and Gynecologists and ACSM guidelines says that the intensity should be based upon do not exceed 140 beats per minute and beyond 12 to 14 Borg scale. Duration, nowadays, previously it has been saying that don't do exercise beyond 15 minutes, but the pregnant woman can safely exercises even after 30 minutes also. Okay, depends upon the type of training they are receiving, depend upon the previously active state. Only thing, the exhaustive exercises should not exceed beyond 15 minutes. The frequency, it should be at least 3 to 5 times in a week, or 150 to 180 minutes in whole week. Then again, no supine lying position after 4th month. The mode of exercises, it should be compromising both of aerobic and the strength training. And the body temperature, it should not exceed beyond 38 degrees centigrade. So now absolute contraindication, if you are having hemodynamically significant heart disease, restrictive lung diseases, incompetent cervix, multiple gestation, or certain bleedings will be present at the 2nd and 3rd trimester, placenta previa. So in such cases, the absolute contraindication is for aerobic exercises, and you have to teach the warning sign and symptom to the patient when to stop exercise, like vaginal bleeding, dyspnea, dizziness, headache, any chest pain, any weakness, and if it is double exercise. The second important thing, you have done exercise. Now, that doesn't mean that you should spend your whole day in prolonged sitting. So second lifestyle change, which is very important, is avoid prolonged sitting, because even if you are sitting whole day and doing exercise for 30 minutes, it will decrease the benefits what you are getting from the 30 minutes of exercise, because the prolonged sitting will put systemic effect on your vascular, autonomic, and metabolic system, which will decrease your blood flow, lead to endothelial dysfunction, decrease your sympathetic nervous system activity, and increase vasoconstriction, decrease GFR and renin release, and metabolic demand will be more. So that will finally lead to insulin resistance, more insulin resistant. And all these things will lead to oxidative stress. And this oxidative stress will further lead to dyslipidemia, hypertension, and hyperglycemia. So prolonged sitting should be avoided. So prolonged sitting with even moderate food intake will induce higher nutrient load, where muscular activity and energy expenditure is low. So this will lead to elevation in circulating glucose and insulin level documented to occur with prolonged sitting in association with feeding, would again cause sympathetic excitation and non-adrenaline release from arterial nerve terminals. And even this will lead to preeclampsia also sometimes. So this represents another possible pathway that may contribute to hyperglycemia and blood pressure elevated during the prolonged bouts of sitting. So maintain an active lifestyle throughout the day. After every 30 to 40 minutes, at least get up and have a walk for 5 minutes. Next important factor, which is very much disturbed during pregnancy, sleep. Okay, whether because of stress or whether because of extreme fatigue, frequent urination, or you are not feeling well. So this sleep is very much affected during pregnancy. And when sleep is affected, it will lead to altered glucose metabolism, disturbance in your appetite regulation, lower energy expenditure, that will finally lead to weight gain and insulin resistance more. So you have to provide the sleeping well tips to the woman that ensure that the natural light, you should expose yourself to the natural light in the daytime. And when you are sleeping, make your bedroom quiet and dark, as comfortable as possible. Eat regular healthy meals and stay hydrated. Minimize caffeine drinks, especially in the evening. Exercise regularly in the daytime. Again, exercise will also improve your quality of sleep. Limit the use of electronics. That is very much prevalent in nowadays. Women, they surf a lot. Okay, so using a lot of mobile phone during night, it will affect your sleep quality. Consider relaxation techniques. If you're having difficulty in sleeping, try to use meditation techniques during night, which will induce a better sleep. and try to sleep at the same time every day and get up at same time every day. Next possible lifestyle factor which can affect your sugar level is stress. So stress will affect your neuroendocrine pathways, inflammatory process and autonomic process. So it will increase central obesity, increase level of lipids, directly affect on beta cells, and it will trigger hepatic glucogenesis. The inflammatory process, again, because of stress, will have effect on insulin sensitivity, down regulating your insulin stimulated glucose transport and lipid uptake, and telomere shortening. And autonomic system, as it is known, it will increase your blood pressure, it can increase your central obesity, and possibly direct effect on insulin sensitivity. So stress is something which is really need to be tackled during pregnancy, and that is quite like possible to do it through meditation. Deep breathing exercise have a very good effect on tackling your stress. So you have to teach the good deep breathing exercise perform whenever they are feeling stress and before sleeping also. Then exercise, definitely if you do regular exercise, it will decrease your stress hormones, and try to spend some time in nature. Try to spend some time while relaxing in nature. Sleep well, connect socially, eat well, and make the list. You have to prioritize your task. So in lifestyle management, it is important that you have to give the advice based like doing regular physical activity, tackling the stress, sleep well, and definitely eat healthy. So that all can lead to decrease incidence of gestational diabetes, and definitely the women, they won't develop the type 2 diabetes in future if they are cautious. So that's it for my presentation. Thank you very much for your patience.
Thank you very much, Dr. Ambedkar. It was really a lovely presentation. And with this, I would like to call upon our next speaker, Dr. Ushma Bhojani, who is WOW IP licensed clinical instructor, and she has done childbirth educator training under Lama's program. She has completed 4 parts of McKenzie's certification. She is a certified kinesiology taping practitioner, a certified aqua fitness and aerobic trainer, a certified dry needling practitioner. She is certified IASTM and cupping practitioner, and she is the founder of Ushma's World of Wellness, and she is associated as visiting consultant at Cloud9 Hospital and Sanjeevani Hospital, Mumbai. So I welcome Dr. Ushma on behalf of whole of our team.
Thank you, Dr. Dara. Thank you for the wonderful introduction. I hope I'm audible to all of you.
Quite audible, and your video is also visible, and even your slides are there.
Thank you. So good evening, everybody. First of all, before I start, I would like to really acknowledge WOW team and Khyati College of Physiotherapy to come up with such a unique topic to talk on when the Women's Day is so close. And all the topics which have been curated are so beautifully taken. And I think they're the rarely talked topics in our day-to-day practice. As well as I would like to thank our mentors, Dr. Ali Rani sir, and rest all of the team members to be present to make this event so successful and so wonderful. Today, what I'm going to talk to you all is on physiotherapy management of urinary retention with WOW PF 360. Now, this is one of the topics which is really close to my heart, because when we talk about any kind of pelvic floor dysfunctions, the most commonly heard ones are incontinence or sexual dysfunctions or, organ prolapse. But urinary retention is something which so many people suffer with. We're not even sure half of the times that the females are suffering with it. And, it's a little tricky to treat as well. And the guidelines to treat, again, urinary retentions are not very, gray and white. They have a lot of overlapping phases when it comes to pelvic floor dysfunction. So what I've thought is that for today's talk, before I go to the management, let us just talk a little bit in brief about urinary retention. So what will a patient walking into your clinic with urinary retention tell you? So the most common complaints, they will end up telling you is that I don't feel that, my bladder is completely empty once I have passed urine. Or else they will see, that it takes a little time for me to start urination. Or they will say that while passing urine, I feel that, it stops in between. There are a lot of breaks. It takes me a little time to complete the voiding process and then come out. After that also, I feel that, there is something left. I feel a little heaviness. I don't feel the satisfaction that I have completely voided at one go. The force of passing urine is not adequate enough, or else they will say that, then there is a little pain before starting urine, or there is a little abdominal pain or discomfort that they are going through. So these are the kind of symptoms that not very often patients will walk into a clinic, but yes, most commonly they walk into a urogynecologist and eventually maybe they will walk in. But if the patients come into you and in general you are taking all history, then I would suggest that you should always ask female patients about their urinary symptoms, and you will find that 10 out of 2 or 3 will end up telling you similar kinds of complaints. Not only females, it's very, very common with men as well. And why is that so? Because obviously with age, again, pelvic floor dysfunction is also part of male aspect, as well as obstruction is also one of the causes. So we'll be talking about it. So what are the common causes? Such symptoms when a patient brings to us, why does that happen? So the most common causes, when we categorically divide, we can divide it into 5 major functions, which is either obstructive, infectious, neurogenic, or else medication. I've written pelvic floor dysfunction a little separate because it at times overlaps with all 4 of them. So it needs to be screened out very, very nicely. That first and the most important thing, when a urine retention patient walks into you directly, we really need to screen out that is that patient does it fall into our category of treatment or not. And in all 4 above causes, the pelvic floor dysfunction may not be there. So ruling out and thorough assessment are key to the success. So before we go to the assessment, let's just understand about the causes a little bit more. So obstructive causes, what could it be? So as I said, in men's, again, it's very common because of benign prostate hyperplasia. As you see in this picture, if that becomes a little bigger prostate, then it is, ends up, squeezing the bladder neck a bit, again, causing just a mechanical obstruction rather than any other problems. Prostate cancers, bladder stones, fecal impaction, and pelvic organ prolapse. Now, fecal impaction is, where a patient has chronic constipation, and maybe that is causing a little bit, pressure over the bladder. And pelvic organ prolapse also depends, either grade 1 or grade 2, in such a way, either urethrocoel, cystocoel, rectocoel are going down in such a manner that they are causing a little pressure over the bladder neck, causing difficulty to either initiate or maintain the stream of urine or complete the stream of urine when the patient is voiding. Same thing is again very common with TVT slings. So TVT slings, when they are put post-operatively, if at all it's put really tight, or else, it's all good once operated, but few years later, you hear this patients talking about retention. Could be one of the reasons, because when the TVT sling is inside the body for long, it gets absorbed. If it gets absorbed and if it gets a little bit twisted here and there, it can again cause a little trouble on the bladder, giving it retention problem. So such patients needs to be referred to their surgeon, particularly if you know that there is any TVT sling history in past. Okay. The next part would be infectious cause. Infectious cause is again one of the common ones, where you see very young females walking into a clinic, maybe age of 16 to 25, telling you that, I have urine retention problem. I don't think I can completely void, and I have break of stream. And you will wonder that laxity is obviously not a problem. So in such cases, you really need to rule out as recurrent urinary tract infection and acute vulvovaginitis. So a thorough history of particularly any kind of infection, so fever, flaring up, pains, burning, discharge, urgency. This all you need to take history before you actually start treating this patient. And if there is any kind of infection, you first refer, you get their infection sorted. After that, still if the symptoms persist, then a pelvic floor assessment needs to be done, and then according to the assessment, the patient needs to be treated. Same way, prostatic abscesses also work, and even post-TVT sling infections also work. So a thorough history is very, very important. I'm repeating it again and again because it plays a very big role for us in order to plan the treatment protocol. The next cause is neurogenic. Now, this is like quite, obvious causes like cord compression, transverse myelitis, multiple sclerosis, and all of these conditions, if you will see, there is already a neurogenic cause, we all know. And in such cases, yes, you can assess the pelvic floor muscle and then decide that what is the impact of it and how you can help the patient. We'll be talking about all the pelvic floor assessment as well. Okay, the last one would be medication. So whenever you take the assessment, make sure that the patient is on any kind of medication, particularly psychosomatic causes. So patients already suffering with psychological conditions, do take a thorough history of their medications. Medications having anticholinergic activities or tricyclic antidepressants or opioids or any kind of antipsychotics. please take a thorough history of it. If you need be, you can even talk to their psychiatrist that is it a complication to the medication, and then only move ahead with your assessment, right? As I said that, last pelvic floor assessment, I've kept it a little separate is because that it starts overlapping. Why did I say overlapping is that pelvic floor dysfunction with the patient walking in with urine retention can go into any spectrum. So we know that pelvic floor dysfunction are of 3 types, right? There is hypotonus, hypertonus, and incoordinated. So hypotonus means that the muscles are lax and weak. Hypertonus, we know it means that the muscles are tight. And incoordinated is that, particularly in functions, it behaves either in a tighter form or in a weaker form. But when you assess, they do not really resemble to the actual symptom that the patient is talking about. So more like dependent on the functional activity. And that is why it's incoordinated without showing a typical picture of either hyper or hypotonus. So if the causes are even obstructive, like for example, take an example of pelvic organ prolapse. Pelvic organ prolapse, if it's occurring and that is causing a pressure on the bladder neck, then that is, again, it goes into a category of hypotonus, right? We know that the pelvic organ prolapse will happen only when the pelvic floor muscles are weak. Same way, if we talk about hypertonus, like take an example of infection. If a female is suffering with infections, like I had a patient who was suffering with infections for 7 years. So like every year I undergo 3 cycles of antibiotics and I have on and off infection. And eventually the muscles around it were becoming so sensitive that it went into hypertonicity. She had trigger points all around, a lot of pain, discomfort, difficulty initiating, difficulty maintaining. So earlier 4 causes can give pelvic floor dysfunction, but as a pelvic floor assessment or as a part of pelvic floor rehab specialist, our job is to figure out that where and what we need to really treat. So the treatment of this urinary retention cannot be done in a form of a very generalized pattern. It needs to be done in a proper invasive method. There should be a set protocol and then only they should be treated, right? So in order to talk a little bit more about pelvic floor dysfunction, I'm pretty sure that we all know phases of urination, right? So there are 4 phases. The first one is bladder filling, in which you know that the detrusor muscle will relax, allow the urine to fill up, and the pelvic floor muscle will go into a reflexive guarding. So they are the ones who will protect, as well as the sphincters will go into tightening, and it will protect any kind of involuntary leaking when we are in a filling up phase. The second stage would be where you get the first sensation that I would like to void, but this is something which automatically gets inhibited. And the last one is where you actually go for micturition. And this is the phase where your pelvic floor goes into relaxation and your detrusor muscle goes into contraction. I'm telling you about this all because the pelvic floor muscle in the phase of urination plays a very big role, because we need a good sync and coordination between our involuntary and our voluntary muscles. Right. So as I said, a key to success, thorough assessment. So what do we need to do when we have to assess and a patient walking in with urine retention to us? So the first thing we always go ahead with is our standard assessment, which is subjective history. So you take the history of their age, lifestyle, habits and lifestyle, again, has a lot to do with their stress, alcohol habits, smoking habits, eating habits, again, a lot to do with their job as well. You know, I had one patient who used to have only complaints during their work times. So the person was so stressed out during the work times that only that phase he had urinary symptoms and rest of the time he did not have. And rest, everything we assessed for him was absolutely normal. So in such cases, it is necessary to take sometimes we don't really have much role and we just have to refer it to a psychologist or maybe to a psychiatrist to help with some medication to calm down with the anxiety, and the patient is good to go, right? Same way, chief complaints are again very, very important. That what are they going through, except for urine retention or the break, not able to void completely? What is it? Is there any pain? Is there any discomfort? Is there any heaviness? Is there any past history of trauma, injuries, surgeries? Childbirth, again, very big role is played by childbirth and sexual life. Childbirth, if at all you're taking history, make sure that you take history of how many kids they have, how well are the how well the pregnancies were separated from each other. If the labor was normal or C-section, that's fine, but did it follow after a normal trial and then C-section? If it's just normal, how long did it go? So this will give you a more deeper picture about how much has the pelvic floor gone through in so much of years that the patient has been suffering or coming to you. A little bit detailed question about every aspect of the subjective history will help you to go in a particular direction with regards to your actual physical assessment. Apart from that, postural objective assessment. So posture assessment is again very, very important. So particularly people suffering with anxiety or, or who have very tight adductors, this again tells you that maybe, there might be a category into hypertonicity. Observing perineum and pelvic observation. So before you start actually doing any invasive assessment, observation is very, very important. So here you can actually screen out any kind of infection. So in such cases, do not do any assessment further. First thing is to get the infection sorted, refer and then ask the patient to come back to you. The next thing, once you know everything is clear, perineal vulval observation is done, then we do an actual invasive assessment. And in invasive assessment, we do our manual muscle testing and other tests. Right. The next is obviously palpation. Now, before you actually go invasively, so this is a pelvic floor area, right? We always recommend that if you are not comfortable, if you do not have an idea about how to do an invasive assessment, initially all you can do is just do a perineal observation. Second thing is do a palpation externally. This even patient can do on their own in a circular pattern. See if there is any kind of tenderness, if there is any kind of pain. Again, that will signal to you a little bit that what is going on around in that area. Is there any kind of infection? Is there any kind of tightness? Even manual palpation around the adductor muscles will tell you about, in general, hypertonicity in that area. Right? We have periometer, EMG, and bladder diary. Yes, bladder diary is one more very, very effective tool without going invasively when patients have urine retention. The pattern of, that is it in the particular part of the day that the patient is suffering with this kind of problem, or it's there throughout, or it's followed by any kind of activity. Like a lot of people complain that after waking up only they have problem, or, they have problem only when they are into their work environment. So such cases are very easy to screen out when you ask the patient to make a bladder diary. Right now, in such cases, the normal assessment that we do is an invasive internal assessment. And Haight's assessment scale that we follow. Now, this scale, I think we have spoken quite a bit at this all of our top sessions. And it's one of the best scale. Only reason being is that there are no other scales that talks about relaxation. And that is very, very important when you are seeing a patient with urinary retention. So strength is definitely a part of it. But as I said, or how to, before you start treating this patient, you need to have a relaxation scale. Right? So we do a Haight's assessment of the MMT, and accordingly, you will create a baseline that yes, this patient is suffering with urinary retention. Cause is not any of the red flags. It's just the physical pelvic floor dysfunction. And then you categorize it into either hyper or hypotonous dysfunction. There are sometimes, as I said, that there are incoordinated dysfunctions as well, where you will not find much of the problem in either of the scales. So grade 3, grade -3, both are quite okay. So in such cases, you can do a reflexive result scale as well. So Haight's RR scale can also be done, where you actually have to see that how much is the patient able to do intentionally. So this is one of the scale particularly designed to see the functions of the patient. So this is done when you are able to not find much in your MMT scale. Right? Now, let's say that you assess the patient properly, everything is done, and you know that the patient comes into a category. We'll take example for each, okay? When we talk about its management. The question is that, yes, I did the assessment. I think my patient falls into a grade 1 of -1 or -2. I find some kind of, it's a hypertonous case. It's not able to functionally completely relax. I can find some trigger points around, and I want this patient to recover without me doing any kind of invasive treatment. So in such case, WOW PFA is one of the best modalities, or one of the best assisting tools that can help you out to treat your patients without going invasive. In such case, how are you going to use PF360 is, if you are treating hypertonous dysfunction, you always know that the rule is relaxation. We want complete relaxation of the pelvic floor, which patient should be able to appreciate. So in order to do that, what you will do is I'll show you the treatment methods on the pelvic floor itself. Okay, so before you start, what you need to do is to understand the machine. So this is the probe of your PF360. If you look over here in the picture also, you'll get to see, and here as well, that it has a target activator like this. The best part of this target activator is that it can go on the individual aspects of your pelvic floor. Like for example, if you want to do your paraclitoral, then it can fit in nicely. If you want to go on the either sides of your paraurethral muscles, you can go individually thanks to the target activator. Okay, now what does this machine do? This machine has a set program which is associated to the mobile phone or the app, and it gives you a mechanical vibration which helps activate the pelvic floor muscle. Okay, so when you are doing or treating a hypertonus muscle, you know, hypertonus pelvic floor dysfunction, you know that you are trying to create relaxation. So for that time, what you're going to use is you're going to use a Glazer's protocol. Now, when you do Glazer's protocol, what you need to do is place the shaft like this. For this, you can even do it wearing your clothes on it. If you don't want to do any kind of invasive, you can just ask the patient in sitting wearing clothes to put the shaft on the perineal area, right? Now, this first 5 minutes, you just let it contract and relax passively. Patient doesn't do anything. This 5 minutes of activation is to create a neuromuscular coordination. Second thing is to improve the blood supply. After you have achieved that, the next step you will do is you'll do a Glazer's protocol. Now, what does Glazer's protocol have? It has 10 minutes of contraction and 10 seconds of contraction and 10 seconds of relaxation. So, for example, if you're trying to relax the whole pelvic floor in a go, so the most favorite is urinary retention. So if we talk about sexual dysfunction and all, we can place it on the clitoral area. But when we talk about urinary retention, you need to focus on the muscles which are around the urinary glands or paraurethral glands or paraurethral muscles, or else the perineal body is one of the best place where you can give this program because it takes care of the whole pelvic floor. So you need to take this activator, place it around the perineal body, okay? And whenever the machine has a mechanical vibration, you need to ask the patient to do first 3 seconds, 10% of their capacity squeeze. So you have to ask them to do the squeeze. So you have to teach them before you start this machine, okay? So you have to ask them to squeeze and squeeze it to 10% of their capacity and only for 3 counts. After 3 counts, the vibrator still continues, but for that 7 seconds, you will ask the patient to completely relax. So the mechanical vibration will make sure that your pelvic floor muscles are activated throughout in that 10 seconds. And then last 10 seconds, the break time is the one when you will ask the patient to relax completely by breathing in with their nose and blowing out with their mouth. So the whole idea about the Glazer's protocol was that if the patient is already into a constant state of tightness, where they don't know how to completely relax, it is very difficult to ask them if you tell them relax, relax. Okay, you cannot command them that relax and they will just start relaxing. So in such case, if you give them a very small contraction followed by relaxation, they are able to appreciate relaxation better. And in this, there is no invasive procedure, so the patient can understand and you can do it very comfortably. Right? Follow it up usually with all kinds of stretches. So whenever we have a hypertonus patient, it is not only the pelvic floor areas. Along with the areas, you also have to take care of the muscles around the pelvis. So your glutes, your hams, your quadriceps, adductors, all of this needs to be given a basic stretching program. And in all of this, the idea is to train them that how to relax even when they're doing their stretches, and then follow it up gradually as per their symptoms, and then you can slowly help them out of it. The most important thing that I would want to talk when we talk about urinary retention is that Kegels exercise are not the answer for all pelvic floor problems. So as I said it from the start of the session, that thorough assessment is very important. The reason was this, that in particularly in urine retention, we don't really know that when we that the patient is coming with tighter muscles or lax muscles. So without assessment, just with help of symptoms, if we start doing Kegels exercise, we might end up worsening the condition of the patient, right? So this is one particular condition when we do not ask the patient to do any kind of strengthening or Kegels exercises. All we want to promote is relaxation, right? Apart from that, next one is hypotonus. Now, my personal experience so far treating urine retention cases has been that once the relaxation is done, After that, I see a lot of the time hypotonicity unmasked, so you eventually come to know that they require a little bit of strengthening. So the goal, whenever you discharge these patients, is to make sure that they have complete, so there is this last part of it, it is very, very important that in order to have a proper urinary function of neither having leaking to neither having retention, the patient has to be from 3 to -3 scale. That is, they should be able to completely contract and completely relax voluntarily and even consciously and unconsciously as per the need of function. So eventually, once you see the patient's conditions have started improving, make sure that when you're doing relaxation program again and again and again and again, at the end, you should not leave the patient with any kind of laxity. So bring a balance of it and then discharge the patients, right? Coming to the next one is treatment of hypotonus. Now, hypotonus is again very simple. It goes similar in lines of laxity. So the same program will work even for the incontinence patient. And in that, again, PF360 can be worked. So the best part of PF360 would be that it works for either of the dysfunctions, right? So in this, what do? Is you do a little bit deeper assessment. You figure out that you do a ring clock assessment. So when we do Hpc MMT, so we know what the Hpc MMT is, right? You all want me to brief up once again. So your Hpc MMT is that whenever, you put a finger inside vagina transvaginally, you ask the patient to squeeze. Once the patient squeezes, you just feel here and there a little bit of contraction. It is grade 1. Grade 2 is you feel a nice circumferential grip. Grade 3 is a nice circumferential grip, then upward, inward pull. Okay, so if you realize that your patient is around grade 1, you need to do an individual ring clock assessment. Okay, and that will tell you that which area of the muscle do you need to train more. And then accordingly, you are going to use PF360. So again, shaft activation remains the same for all the patients. If you do not want to go invasive, this can also be done on clothes, where simplest program you can do if you have not been able to do ring clock assessment or anything is do 5 minutes of just shaft activation and follow it up in the same fashion. So maybe around the perineal body or around the shaft. Whenever the machine goes with mechanical vibrations, that is the time you ask the patient to squeeze. And whenever the mechanical vibration stops, you ask the patient to relax. This condition apply, make sure that you see the patient, that the patient is able to do the squeeze rightly. So the only problem with hypotonic patients, which we have seen, is that if you do not assess, so if you don't want to go transvaginally, you can just ask the patient to, you can just expose the perineal part and you can just do a perineal observation to see that what is the movement of the perineum. The perineum movement should be inwards. It should not be outwards. Imagine the patient is doing reverse Kegels again and again, and you further reinforce it with the PF360, you are just going to end up worsening their condition. So pelvic floor and pelvic floor exercises, we all know as physiotherapists, right, that almost 80 to 90% females end up doing it wrong. And particularly these are the females who are having weakness and they are not able to activate the muscle on time properly. And that's why when they try to force it too much, they end up doing reverse of it rather than doing the actual upward inward movement, right? So make sure that the patient is doing it right. And then you can give the mechanical vibration with the set protocol, either strength, endurance, or strength hypertrophy, whichever you want to select as per the assessment. And with the mechanical vibration, you ask the patient to squeeze. And once the vibration stops, you ask the patient to relax, right? Another way which actively patient can do is wow fit or vagina fit. In this case, what you can do is, this is an active assessment. So vagina fit looks something like this, okay? And this you can add, this is one person use. The patient has to have their own vagina fit. What you do is you ask the patient to insert the vagina fit completely into their vagina, leaving this much part of the vagina fit outside, V fit, okay? And you're going to ask patients to do 3 types of activities. So 10 coughings, 10 squats, and 10 jumps. Patient has to maintain this inside for all 3 activities. If this falls off in any of the activities, then, so for example, inability to hold. So this particular testing is to be done in standing position, okay? So if it falls off in any of, before completing any of these 3 activities, it comes into a category of C. Eventually, if it doesn't fall off, but it just slides down, it comes into a category of B. And one is where it's able to hold throughout and all of the activities is, it comes into a grade of A. So this is an assessment which your patient can do on their own also once you teach them. And they can, they can do their active exercises also with this, because you want to strength train the patient. And gradually you can give them a home program of their strength training with their with mirror biofeedback. You can give it with VFit. You can just give it normal exercises in positions which they are able to do it better. Like a lot of time, all 4 positions are better, or sitting on the toilet and doing it is better. Make sure you tell them that do not do it while passing urine. Okay, that will just add on to the problem and not reduce the problem. So accordingly, as per the patient's condition, cognition, and everything, you can design a program for that, right? So eventually, once you know that you are treating a patient with hypotonicity coming with urine retention, you need to complete it with any kind of core training as progression. Core training, and including that, along with that, I would prefer muscles around the pelvis. So again, glutes, quads, hams are again the ones that I would really like to work before I discharge this patient, because pelvic floor tightness does have associated tightness. At the same time, pelvic floor weakness also has associated accessory muscle weakness, right? When it comes to incoordinated dysfunctions, now incoordinated dysfunctions are the
sorry,
ones...
Dr. Sorry for the interruption, but we are running late.
2 minutes, I'm done.
Thank you.
Okay, thank you. Incoordinated dysfunctions are the one which, again, you will have to eventually, bring it into hyper or hypertonus, but there are certain more assessments that you need to do. So check for the psychosocial component, check for posture, day-night patterns, bladder diary. There needs to be a little further assessment with it, because you will find that the basic assessment is all fine, but they are giving you symptoms. So team approach and a little bit detailed history after that is better to go ahead with coordinated dysfunctions. We'll not talk much on coordinated dysfunctions, is because they are a little tricky also to treat, and it just makes the things more difficult, right? So as I said, that whenever you're treating your urine retention, your goal is to achieve grade 3 to -3. So patients should have good contraction and good relaxation to have a normal urination function, right? So with this, I would like to complete my session. I hope that you all enjoyed today's session, and I wish you all a lovely evening further. Thank you.
Thank you very much. Yes, indeed, Dr. Ushma, it was a very wonderful topic which you had chosen, the urinary retention. And we already know that that's one of your favorite ones. But urinary retention is really a very major problem with many people they are facing. And it is something which needs to be addressed. It's not something, and there can be multiple causes. You had explained it very beautifully. Thank you for that. And now let us go and call upon our next speaker. Here we have Dr. Smarnika. I'm sure you would not require more introduction for Dr. Smarnika. She is the founder and co-director of Curmos Physiotherapy Clinic, and she is a Goa State coordinator for IAPWC, and she is also into the digital and technical team of IAP. So majority of you might already be knowing her, but let us know her today as a speaker, and let us see that how will she be able to deliver us with the topic, enlighten us with the topic of musculoskeletal disorders in the postnatal period. We had discussed about the postnatal weight management, we had discussed about the postnatal physiotherapy, but then specifically if we want to discuss about the musculoskeletal disorders, and then what should that be, let us have a word from her. We welcome you, Dr. Smarnika.
Thank you, Dr. Dara. I would just like to screen share first.
And we are not going to have any technical problem here because you are there for this speech.
Can you see my screen?
Yes, it is visible. You just need to slideshow.
Okay. Okay. I'm just resharing it. It's visible? Everything is visible?
It is visible, but the slideshow is not there. The slide listing is there.
See now. Is the slide changing?
The slide is not changing. The screen is steady.
I have an internet issue. Now, can you see the screen changing?
It's not. Shall I share it for you?
That would be great.
Okay, let me do that.
I'm stopping my share. So while Dr. Dhara is sharing my screen for you all people, I would like to thank both Dr. Dhara Shah and Dr. Dhara Sharma for organizing this beautiful program just before Women's Day. So our theme remains the same, that is of the Women's Day. And we are basically talking about all the procedures, all the problems that women face. Today, what I'm going to take is management of postnatal musculoskeletal disorders. I think my screen is visible now. Yes,
yes, it is visible and it is changing also.
Okay, fine.
But you have shared the PDF with me.
Yes,
So I'm just
you have to
sharing
just
the
go
PDF.
press enter, it will keep going.
Okay. You let me know, I'll do that.
Yeah. So basically today's topic for the day is going to be the management of the postnatal musculoskeletal disorders. But before that, why is it important? Why is it so much important to know about this? So almost 100% of the women experience musculoskeletal discomfort during their pregnancy. If you look into the statistics, this is definitely not India. India's numbers are going to be much bigger. But 32% report for low back pain. About 25%, that is 1/4 of the all population of the pregnant ladies, do mention it to their providers, get some specific treatment for the low back pain. So I'm looking at those 25% of pregnant ladies who are finding temporary debilitating symptoms in low back pain. So that's such a huge number that we can address to as physiotherapists, and that is why I thought that I should take this topic, though a bit of it has already been taken in detail by Dr. Lalita or Dr. Samiksha, but I wanted to give an overall view as a physiotherapist, what all can we do for every pregnant lady, postnatally, prenatally, both. Next slide. Dr. Dhara, you have to screen share and go for next. Previous. So looking at the musculoskeletal changes that we can see, the next slide, Dr. Dhara. Yeah. So I'm just going to talk about the changes and then take a summary out of it. So as we know, the abdominal muscles are stretched up to its elastic limit by the end of the pregnancy. There is a shift of COG, which decreases the mechanical advantage of the abdominal muscles. And there is also a decrease in the ligamentous tensile strength due to the change in the relaxin and the progesterone levels. We see joint hypermobility along with joint laxity. Pelvic floor stretches so much that it drops about 2.5 centimeters. That's like 1 inch, which is a huge amount. Stretch and compression of the pudendal nerve, which is a nerve which supplies the pelvic floor area. Lumbar and thoracic curves are increased, so both kyphosis and lordosis. The distance between the two recti muscles basically widens and the linea alba splits under the stress. This is called the diastasis recti. And in the third trimester, we also see increased water retention, which result in varying degree of edema in the ankle and feet. Next. So I'm coming to what is the reason behind this. This three beautiful hormones that is basically relaxin, progesterone, estrogen. They help us retaining the pregnancy. At the same time, they give these all problems to us. So let's see next about what exactly are the physiological changes I can expect. So as a physiotherapist, my aim should be on the anterior pelvic tilt, the increased lumbar lordosis, pubic symphysis widening, the ligament laxity that I am seeing, edema, peripheral nerve compression. Increased weight also will increase the joint loading. So vascular compression will also come with that. So neural and vascular compressions are also a part of this musculoskeletal issues. Next. So what are the problems? We are going to see these problems one by one and a solution to it as an overall program. I will not go very much deep into it because this has already been taken by other speakers. So first we see is diastasis recti of abdominal muscle, low back pain and pelvic pain. So we need to also distinguish between the two. The reasons could be postural in nature. It could be because of posture. It could be because of sacroiliac joint, which is majorly your pelvic pain. It could be a combination of both of them. It could also be a combination of postural, sacroiliac and coccydynia. So looking at what is the reason and how to look into the solution part of it. We also see varicose veins, varicosities even around the stomach area. Joint laxities, pelvic floor dysfunction, needless to say, because if pelvic floor is involved in pain, there is definitely some kind of pelvic floor dysfunction. Then we can look at diastasis of symphysis pubis, which is osteosis pubis. Thoracic spine pain, the upper cross syndrome is the major reason behind that. Then we have osteoporosis. Majority of the osteoporosis is seen in the hip pathology, so I'll come to that in detail. Coccydynia, cramps, and also the compression of nerves. Next slide. So when we come to diastasis recti, as we know, it is a separation between the abdominal rectus muscle. So what we have to do here is, obviously I have to do muscular strengthening of abdominal muscle, but always when postnatally ladies come to you with back pain or let's say SI joint pain, any pain, check for diastasis, which sometimes we miss out. See, some ladies, even after the 2-3 years of pregnancy, they don't know they have diastasis. So you can definitely check for anybody who is a multipara, that you check for diastasis whether they have it or not. When we do the abdominal strengthening in their case, we have to look into lumbar stabilization, also core engagement. So after checking, make sure core engagement, transverse engagement is there. Also the pelvic tilt exercises. Since we see generally anterior tilt, we are looking into more of abdominal tucks, teach them abdominal tuck-ins in each position. Also how to do abdominal tuck along with all the strengthening exercises. Abdominal supporter or binder is also very important here, because we are looking at mother postnatally. She would be doing a lot of chores of her house where she is bending down, including the child care. See, in India, majority of the times we don't use a chest of drawers or a higher table to change the baby or to feed the baby. We are generally using our regular bed, which is a lot of bending and standing up and sitting. So in such cases, abdominal support does give a lot of help. In extreme cases, cosmetic surgery called tummy tuck can also be done, which is creating a fold in the linea alba and suturing it together. It also creates a tighter abdominal wall. Next. So next is major problem, LBA, lower back pain. But here, the pain is not only lumbar in origin, it is lumbopelvic pain, rather I would call it. What could be the reason behind it? As we know, ligamentous laxity is there. So because of the extreme weight, especially on the inguinal ligaments, there is going to be a lot of pelvic ligamentous strain. Sacroiliac joint involvement could be there if there is imbalance in the pelvic floor itself. Then there is discogenic pain. Now this could be previous. This could be a previous incidence with the mother that she has some discompression and now she's undergone the pregnancy. Nerve root compressions, vascular compressions, and even hip pathology could be a reason why a mother is suffering from a lumbopelvic pain. Next. So here I'm not going into what is lumbar pain or pelvic pain, but to distinguish, because it's very important clinically when the patient comes to you, whether I'm looking at it only as a lower back pain due to the lumbar origin, including the lumbar radiculopathy, or it is something to do with pelvic girdle. It could be a combination as well. But if I'm getting a separate case, then how do I identify basically? So lower back pain, you have to ask the history. The history could or mostly is seen even pre-pregnancy. Whereas pelvic girdle pain is generally only during the pregnancy that the mother has started experiencing the pelvic floor pain. When you see the pain localization, we would see that this is generally in the lumbar region of the mother. Whereas when we look at the pelvic girdle pain, it is seen in the posterior iliac crest area or the gluteal fold. So you can say SI joint area basically. The range of motion of the pelvic, the lumbar area, when we check, we will see that the lumbar region, there is no decrease in the range of motion in case of a pelvic girdle pain. Whereas there is going to be definitely a decrease in the range of motion when it comes to a lumbar originated pain. When we start palpation, we check the palpatory areas, we can see that here the lumbar paraspinal muscles in the case of LBA would be affected. We see majorly there. Whereas in the case of the pelvic girdle, we are going to see majorly in the sacroiliac joint and gluteal musculature. But having said that, you can have both of them together also. Now, the other thing that we see is about when does the pain come. Generally, a mother who's complaining of a lumbar originated pain, she would say, I can't sit and feed my child. The moment I sit more than 15-20 minutes, I start getting terrible pain. I have to change my position. So it is more on stagnant positions. Whereas a mother who's having the problem in pelvic floor, she will have more problem in weight bearing. So she'll say walking is difficult, step climbing is difficult, stair climbing or standing for long time is difficult. Pain is pretty much consistent when it comes to the lumbar origin pain, whereas the pelvic floor pains are more intermittent. When we come to the testing, we have certain pelvic floor provocation test, which I will just talk about in the next slide. So these tests are going to come positive in case of the pelvic girdle and negative in case of the lower back pain. Next, please. So we have posterior pelvic pain provocation test. How it is done is you ask the patient to lie down supine and 90 degrees of the hip flexion, knee flexion, stabilize the pelvis at the ASIS, and then start putting pressure on the femoral longitudinal axis. You will see that there is a pain which is initiated at the gluteal region. So this is one of the provocation tests which we can do to see, okay, now pelvic floor is also involved. Why I'm saying also involved? Because it could be lumbar as well as pelvic floor. Another test is Faber test. So in Faber test or Patrick test is, as the name suggests, Faber is basically flexion, abduction, external rotation of the hip. So we ask the patient to lie down supine, go for the flexion, abduction, external rotation of the leg, which is going to make a figure of 4. And as we keep the leg on the opposite knee, we let this knee to fall down on its own. When we do that, pain is seen either in the ipsilateral SI joint area, or it could also be the pubic symphysis area. Both of them will suggest that the person is having a problem with their pelvic floor. Along with that, we do have a long dorsal sacroiliac ligament test, which is done on sideline with slight flexion of both hip and knee. And here we basically do a palpation and we find out what is the severity of the problem. So this test is not done initially, it is after the diagnosis that we do this particular test. Along with that, we have our normal SLR, which will also tell us about the pelvic floor problem if the leg is raised one, but here we keep the distance 20 centimeter between the legs. This is also more about the intensity of the pain. And the pain provocation can also be done in a Trendelenburg test, where we are asking the patient to stand on one leg and the other leg is 90 degrees bent and off the floor. So it will be positive if the pain is there in that area during the maneuver, but after that she's standing, it is okay. Next, please. So how do we know? See, pain can commonly come due to the postural changes of pregnancy. So definitely a postural component is there. When we will see the postural component, when we see that usually it is worsening with muscle fatigue from static postures. As I said, sitting pain or standing pain continuously will be more. Whereas sacroiliac joint symptoms may be more ligamentous coupled with your postural problem and muscle imbalances inside the pelvic floor. So here the pain would be localized more to the posterior pelvic area. The description of pain is more stabbing and deep rooted in nature, as if they say my buttocks are paining, and it's more lateral to L5-S1 area. So you can say the SI joint line is where they touch and they say I have a pain over here. Pain here can also radiate, but this radiation will happen only till the thigh or the knee. It won't radiate all the way to the foot. So it is going to be something similar to sciatica, but not exactly sciatica. So this is also a factor that we have to consider. The moment we see radiation, we should not only say, okay, this is lumbar in nature. I have to also look at it from the SI joint point of view, that there could be a radiation because of this also. Next. Now coming to the symphysis pubis pain. Now the term that we are using here is the osteitis pubis, which is basically the diastasis of the pubic symphysis. The incidences are low, which is 20 to 30%, and the presentation here is a very typical word they call stinging pain. They get a stinging pain at the pubic symphysis, and it can also radiate, but this radiates to the thigh, mostly from the inner side. So that is also a distinguishing factor for us. When the pain is in the front, that it could be related to this. The worsening here also is weight bearing. So walking, stair climbing is having more pain. And the risk factors could be a fetal macrosomia, or a history of pelvic trauma or even multiparity, we can see this particular condition. You can see the X-ray. It is encircled. How exactly? You can see a gap between the pubic symphysis. Next. So here we are basically looking into the management part if there is an acute condition. So we have to give bed rest, and what we have to give to the lady is slight abduction and flexion. Binding the hips with a long roller towel may also give some relief in such cases. So since she cannot walk, step climbing, we have to give some assistive device like a walking frame, sticks or crutches should be provided. Icing should be done multiple times because this area is very painful. Also, in such cases, ultrasound can be given in this area, but with keeping the water in between, like with the gloves filled with water, and then you use it, or a condom filled with water, and then we can use it. Next, osteoporosis. Now, this is a very rare thing to see in pregnancy, but as I said, we have to look into hip pathology in this case. So it is rare, but we should be aware about the back and hip pathology. So what can happen is back pain together with a vertebral collapse and a consequent loss of height. So here we can see a problem in the hip also. Okay, next. Majorly it is because of the transient osteoporosis, or it could be avascular necrosis. So sometimes it is missed out why the patient is having hip pain. But both of them present in the third trimester. Weight bearing hip pain is there. Both of them can be diagnosed on MRI, and basically we have to give a protected weight bearing to prevent any sort of progression in this case. Next. Now we come to coccydynia. Coccydynia is another condition which is very painful for a mother to sit for a long time or even for normal feeding. So painful coccyx and neighboring sacral area is basically coccydynia. Coccyx is very loosely articulated to the sacral area and moves backward. Basically, when the baby is coming out, the coccyx has to move a little bit backward to create that space into the birth canal. So because of that, there is a trauma to that particular region. In other instances also, heavy weight gain in terms of pregnancy, anterior pelvic tilt also causes nutation, anti-nutation. So that also pushes the sacral area a little bit back. So coccyx moves out majorly due to the childbirth in this case, but there is a little bit of it because of the posture also. Symptoms would be definitely pain while sitting and arising from the chair. Patient would not want to sit down, will sit very slowly and will want not to sit for majority of the times. What is the management here? See, sitting in acute phase is absolutely discouraged. But how do we give sitting then? Because the mother has to feed. So use of a coccygeal cushion or lumbar roll while feeding. Side sitting can be used with weight transferred through the thighs, or else side lying prone position, but this is for resting. Ice packs can be used. Frequent gluteal contractions along with the pelvic floor rehabilitation or exercises will help this particular case. In terms of our treatment in electrotherapy, laser, ultrasound, TENS around the area can be used and is useful. See, constipation plays a very important role over here. If a mother is having constipation, it could be because of the food that she's eating, not having enough fiber or not drinking enough water. Even in such cases, in defecation, she's going to have problem. So we have spoken about physiotherapy in gut mobility, and the entire role comes here that even with constipation, she will have problems. So we have to avoid constipation as well. Avoid forward movements and lifting. This is a golden rule for any new mother for all the conditions actually. Next. Pelvic floor dysfunction. Now, this is also seen in almost every mother, little high, little low. Depending on the severity, we might see them in our OPDs. Otherwise, they don't even come because they think this is the part and parcel of the pregnancy. But the process of labor and vaginal delivery can produce significant trauma to the neuromuscular junction, which can have prolapses. It could also go into incontinence. It could also have hypertonus and pain. So here the entire pelvic floor rehabilitation comes into the play. And this is a missed part. Basically, mother comes to us with back pain majorly. We don't see whether it is SI joint related or not, whether it is having any pelvic floor dysfunction. If we don't tell them, they will not know, because then many of the mothers are not aware about the pelvic floor rehabilitation. Once the coordination has improved, then in such cases, the client can progress into integration of the pelvic floor activity with lumbar stabilization. As I told you, with pelvic floor contractions, relaxations, we also engage the abdominal muscles, and then other functional exercises. This will actually help them in a long run. Then superficial heat, ice, and manual therapy. Manual therapy can help also a lot in this case. TENS as well. So in pelvic floor dysfunction, if you find a therapist who can work on you transvaginally, then it is the best. You'll have to find people from WOW group. They will be able to do it. But if not, then at least we look into the normal pelvic floor rehab along with abdominal workout. Alone it will not work, because when talking about core, you need to have abdomen, you're seeing abdomen, back, front and back, no, but we have to look into the diaphragm and the pelvic floor also, then only it is core. So if you're doing an entire core, pelvic floor cannot be missed. Next. Then we talk about joint laxity. So majorly joint laxity doesn't cause a disease or a problem as such, but it makes the person more risk worthy, or basically chances of injuries increase, because the tensile quality of the ligament support is decreased. So here in this case, we have to teach the woman to do safe exercises. Sometimes she might get overexcited and say, no, I don't need any support of the wall or support of the chair. I will do it myself. So we need to tell her that, right now you are not at the best of your balance, or your ligaments are lax till you're feeding. So let's try to do it in this way. This is better. Also, we try to give more of non-weight bearing exercises like floor, because now postnatally she can do that. Also, exercises like walking, swimming. Swimming is a wonderful exercise which can be given, which is aerobic in nature. At the same time, you don't have to put so much stress on your joints. Next. Next slide, Dr. Dhara. Yeah. So now we come to a very important aspect of what I should be doing in terms of postural analysis when a lady is coming to me postnatally. So this is talking about COG and posture correction. The COG will shift, or the center of gravity will shift upwards and forwards in a lady who is pregnant. This requires a postural compensation for balance and stability, because now my balance will become less. So the shoulder girdle, in response to it, the shoulder girdle and the upper back will become more rounded, and the scapula will become more protracted, and my whole upper extremity will go internal rotation. The cervical and the lumbar lordosis will increase. Obviously, because of this posture, kyphosis is increasing, lordosis will also increase. Weight shift will start happening towards the heel. This is one of the component which we generally miss out when we are doing a rehabilitation. Change in the posture, but we have to understand, will not spontaneously come to normal after the childbirth. So we go to the next, we see about the upper cross syndrome and the lower cross. So upper cross syndrome and lower cross syndrome is not something that you can see specifically in one person. It is basically both, because spine is one. So if I'm seeing upper cross syndrome, I will see lower cross syndrome also. So what happens in the upper cross syndrome is that I would have weakness in weak neck muscles, that is the forward deep neck flexors. Along with that, it will be the lower trapezius, and it is going to be the serratus anterior. And I'm going to see the tightness in the opposite pathway. So in the opposite pathway, it is going to be tight pectorals, and there is going to be tightness in my upper trapezius serratus, the levator scapulae. So this causes a postural problem over here. Along with that, we see lower cross syndrome in the mother, which is going to be weak abdominal gluteal muscles. Along with that, we see very tight back muscles, along with the tightness of the iliopsoas muscles. So this, as we know, can be corrected by the means of stretching, strengthening in the correct methods. So we basically strengthen the weak muscles, and we start stretching the tightened muscles over here by giving more repetitions of stretching onto the muscle than the opposite group. And this is how we can improve the condition. Next. This is one part we generally miss out on, and that is a medial arch collapse, and what could be the biomechanical cascading after that. So like any other part of the body, your feet will also undergo some change in pregnancy. It is not only the hormones, but also the swelling which comes in, that the foot slowly goes for the pronation, and we start seeing the acquired flat foot or a medial arch collapse. So in such cases, what actually happens when we have an medial collapse of the arch? The pressure shifts to the medial part of the knee. It can cause knee pain. From there, if the pressure shifts higher, it will go to the hip joint, then to the back, then to the neck. Miraculously, in one case of cervical problem, basically she came with cervical headache to me, cervicogenic headache, and we saw this particular problem. We saw everything in her. There was upper cross syndrome, lower cross syndrome, even the arch was collapsing. So as we started the electrotherapy just to relieve her symptoms, because she was not really ready to do much exercises actually, so we gave her an arch tube, and she said my headache just went off because of that. So her thing was only few machine treatment, and that machine treatment she was taking elsewhere also. But when she came, she said, this has worked miraculously with me. So this is how we have to do the assessment, that either you correct from top or you correct from bottom, but you correct their posture. And you tell them that it's not going to happen in one day, it will take little time. With this, we can also see if they have any foot problems, any foot aches, then we can go with intrinsic foot exercises, medial arch placement in their shoes.
Sorry to interrupt, Dr. Smanika. Dr. Smanika, I'm really sorry to interrupt, but we are running a bit late. If you can just.
I have just 3 more slides to go.
Okay.
Yeah. Next one. So I'll just come to what are the other issues that can take place. This is just for the knowledge of, easy understanding. Cramps, which can happen due to the calcium deficiencies, ischemia, or nerve root compression. Generally, we know it happens in the night, and it will happen in the calf muscle. So calf stretching, movement of the ankle, and also the supplementary calcium and daily intake of vitamin B1 will solve the problem. Next. Other musculoskeletal problems could be labral tear, meniscal injury, recurrent ankle sprains, ACL tears, and lower extremity stress fractures. Next. We also see peripheral neuropathies in case of pregnancy, like that of carpal tunnel syndrome, which is because of the medial nerve. And similarly, I had told earlier about the femoral nerve compression that can happen along with the lateral femoral cutaneous nerve because of the inguinal ligament compression. Next. Now the last part, that is the vascular compression. So it is again not seen in everybody, but who has varicosities will see an increase because of the uterine weight. We can see varicose vein around the stomach as well. It is because of the venous stasis and increased venous distensibility. So it is not something which is symptomatic in everybody, but generally itchiness and discomfort is seen around the area. And if there is discomfort, then exercise can be modified, elevation of the lower extremity is given, and elastic support stockings can be given during pregnancy. I think with this, I've come to an end. You can go with the next slide. So if there are any doubts, because we don't have time here, my number and email ID is given. Regarding this topic, if there is any doubt, you can definitely put up a question over there and we will answer you. Thank you so much, Dr. Dhara.
Thank you very much, Dr. Smanika. And I'm really sorry to all the speakers that we have to rush you, but it was a gentle request as we are running short of time.
We understand
so
that.
It was a really very nice presentation from you, Dr. Smanika. So with this, let me introduce our next speaker. She's Dr. Dipali Hyundai, and she's an associate professor at MBPS College of Physiotherapy, Nashik. She's IAPWC Nashik coordinator, and she's an ambassador in ACNAP and ICS 2021. And Dr. Dipali has wonderfully presented a case, article in ICS Melbourne 2021 as well. So over to you, Dr. Dipali.
Thank you, Dhara ma'am. I'm audible, ma'am?
You're quite audible, and I'll just start your screen sharing.
Yes. Good evening, all. I would like to thank Khyati College of Physiotherapy, Khyati Institute of Physiotherapy, WOW Group, Dhara ma'am. Thank you so much for inviting me as a speaker. Yes, Dhara ma'am.
Yeah, I'm just sharing your PPT.
Yes, ma'am.
Yeah, here it is.
Yes, ma'am. So as we can see, so today's topic is role of physiotherapy in different urinary incontinence. So before starting this webinar, I would like to ask, like, have you ever experienced urinary incontinence? Ma'am, please change the slide. So objectives, definition, myth, types, physiotherapy assessment, physiotherapy treatment, and abstract. Ma'am, next slide. So before going to know urinary incontinence, we should also know the definition. So continence definition is ability to control your bladder, and incontinence, it is the condition in which an involuntary loss of urine it happens, and it is a social and hygienic problem, and it is objectively demonstrable. This definition is given by ICS. So involuntary loss of urine, it can be a small triple to a total loss of bladder control. So common myth, the myth can be not many people have urinary continence, only women get this after childbirth, and it's a normal part of aging. So it is not like that, but 65% of population will have urinary incontinence at some point of their life. Then it can happen to anyone, including men. Then UI, it is not inevitable. And lastly, UI is common but not normal. Next slide, please, ma'am. So urge incontinence, as the word says urge, it is a strong urge to urinate. It is provided due to involuntary muscle spasm. The causes can be hyperreflexia of the detrusor muscle, the psychosomatic disorders like stress and anxiety, idiopathic, postural, surgical, post-surgical. The clinical features, it can be loss of urine before reaching the bathroom, urgency, frequency, nocturia. Okay, urge can be triggered by listening to the sound of running water, or strong urge, as it can come home while key in a lock, or garage door syndrome. Next slide, please, ma'am. So stress incontinence, as it is defined as involuntary urethral loss of the urine when the intravesical pressure exceeds the maximum urethral pressure in the absence of detrusor activity. So causes can be childbirth, obesity, aging, developmental weakness. Clinical features, as we can see, there are grades, grade 1, grade 2, grade 3. Grade 1 is during coughing, sneezing, pressure, and laughing. Grade 2 can be urine loss during lifting, running. Grade 3, urine loss during standing without physical activity. Next slide, please. So mixed incontinence. So this is the combination of urge as well as stress. The complaint of involuntary leakage, it is associated with urgency and also with exertion, effort, sneezing, and coughing. And lastly, we have to see the overflow incontinence. It can result in urinary dripping or constant leakage of small amount of urine. The causes can be nerve supply to detrusor, it may be impaired, and urethra is obstructed. Next slide, please. So evidence, these are some evidence. Evidence says that supervised pelvic floor muscle training should be offered as a first line treatment for women with SUI. Weight loss should be considered a first line treatment to reduce UI prevalence. Then pelvic floor muscle training is better than no treatment or placebo treatment for women. Pelvic floor muscle training is better first line treatment than electrical stimulation or vaginal cones. Next slide, please, ma'am. So incontinence associated with sexual activity. The urethra and the bladder lie in close proximity to the vagina. Thus, sexual activity can cause urinary symptoms and lower urinary tract dysfunction. And this in turn may give to sexual problems. Honeymoon cystitis and postcoital dysuria with or without infection is common in young women, and dysuria, urgency, urinary tract infections are noted in postnatal women. Many women also have urge to void urine during or immediately following coitus, and some experience actual leakage during intercourse on penetration or orgasm. Next slide, please. So assessment, detailed history should be taken. VAS, so you can ask the patient to score like no leakage or total leakage. Next slide. So perineal and vaginal assessment. So perineum is observed for the skin condition, signs of infection, vaginal discharge, then prolapse or evidence of episiotomy or previous surgery. The patient is asked to cuff and strain. Evidence of prolapse or any urine leakage is noted. Wearing gloves and using a lubricant. The physiotherapist then separates the labia. After further observation, the index finger of the dominant head is gently inserted into the vagina. The texture of the walls, evidence of the prolapse, quality of sensation, and any pain caused are noted. The physiotherapist curls her finger over the levator ani muscle, and the woman is asked to contract the pelvic floor muscle as if to stop the leakage, or to grip the therapist's finger and prevent its withdrawal. The ability to contract and or not is recorded, and where the voluntary contraction is possible, it is graded. Next slide, please. So pelvic floor muscle strength, as we can see in the slide, there are two: modified Oxford grading system and Hpc MMT. Okay, so there are some limitations to modified Oxford grading system, as we have attended yesterday's conference also. So that is the gradings are fair, good, and strong. Okay, so this grading is subjective, okay, and it can vary from person to person. And so Hpc MMT, the grades are from 1 to 3 for contraction and from 0 to -3 for relaxation. Next slide, please. So palpation, as we know, perfect. So mnemonic stands for power, endurance, repetition, fast contractions, and every contraction time. And as we can see here is Hpc self assessment. So perfect, again, it has some limitations. The limitations are the performance is measured using modified Oxford, which we have seen prior, and the measurement, as we can see, fast contraction F. Okay, so it tells that it falls under 50% of maximum voluntary contraction. So as me or as you, no one can tell exactly that what is 50% of maximum voluntary contraction. So we can use Hpc self assessment. So S stands for strength, E stands for endurance, R stands for repetition, and F stands for fast twitch muscle movement. Next slide, please. So pad test. So this is pre-weighted absorbent perineal pad is put on. Patient is asked not to void at the end of the test. Patient will drink 500 ml of sodium-free liquid in 15 minutes, then rest for 30 minutes. In that 30 minutes, the patient walks around, climbs ups and downs, and perform these following exercises. Exercises: standing up from sitting for 10 times, cuffing for 10 times, running on the spot for 1 minute, bending down to pick up an object, washing hand under the cold water. And the scoring is less than 2 is normal. And if the score is from 4 to 20 gram, then it is mild. 21 to 74 grams, then it is moderate. And more than 75 gram, it is severe urinary incontinence. Next slide, please. So these are the outcomes which we can use in urinary incontinence patients. Example is QUID, that is questionnaire for urinary incontinence diagnosis. And even you can use self-urinary incontinence. Next slide, please. So coming down to management, so teaching pelvic floor contraction. Okay, so in this, the starting position, the initial position is sitting on a hard chair, leaning forward with the forearm on the thighs, with the knees and feet apart. Okay, the perineum is against the chair seat. So what happens? There is some perineal stimulation as the feedback. Second is mirror biofeedback. In this, the patient is in crook lying, and the position you can handheld the mirror in such a way that the patient can observe her own perineum and ask the patient to contract the pelvic floor. Okay, first ask the patient to do quick pelvic floor contraction. So this will increase the muscle awareness. Okay. And next, you ask the patient to hold the pelvic floor contraction and note in the seconds. For example, if the patient is able to hold for 2 seconds, then you can make her to hold for 1 second, 10 repetitions, 3 sets. So what this will give endurance. So this will increase endurance. So goal can be 10 seconds hold with 10 repetitions and 3 sets. Next is perineometer. This is the instrument for measuring strength of voluntary contraction of pelvic floor muscles. Next slide, please. So vaginal cones. So you need to select appropriate cones. Okay, the lightest cone is inserted into the vagina. The position can be semi-squatting, half lying, or standing with 1 foot on chair. So cone is inserted and the patient then stands and walk around. If the cone can be retained for 1 minute, so you can progress to the next cone that is slightly heavier in the weight. And so on, you can continue until the cone slips out in 1 minute. Okay. So the goal is the heaviest cone that can be retained for 1 minute is used for the exercise. Next is electrical stimulation. So it is used for 2 purposes: to produce the muscle contraction and to utilize the sensory stimulation. To produce the muscle contraction, it is used to assist the patients who seems unable to produce a voluntary pelvic floor muscle contraction or have very weak pelvic floor muscles. Okay, to utilize the sensory stimulation, it causes inhibition of the detrusor activity and it normalizes the reflex activity. It is useful for the patients who experience urgency and urinary incontinence. Next, it is interferential therapy. So IFT can be used for muscle re-education. Then technique, 2 methods you can use for the electrode placement. One technique is 1 electrode can be placed under the ischial tuberosity and 1 inferior to symphysis pubis. The next technique is 1 electrode can be placed under the upper aspect of the thigh and other inferior to the symphysis pubic. Next slide, please. So bladder retraining. So we need to bladder retrain. The aims would be to correct the faulty habits, to control the urgency, to reduce the incontinence episode, to reduce the daily number of voids, and to build up the patient's confidence. Next, as we can see, is WOW PF360. This is the non-invasive technology. It helps to activate the muscles surrounding the urethral opening. Next slide, please. Yeah, so I'm very happy to share that we have Dhara ma'am, myself, and Dr. Amrit ma'am. We have submitted our abstract to International Continence Society Conference, Melbourne 2021, and it was selected and it is published. The topic was effect of pelvic floor rehabilitation of female sexual function, HATES FSF, and pelvic floor muscle strength, HATES MMT, in women with stress urinary incontinence. The conclusion was pelvic floor rehab was effective in improving female sexual function and pelvic floor strength in women with strength urinary incontinence. Next slide, please. So here I end by saying Happy Women's Day in advance. Thank you so much. Thank you once again, the organizers and Dhara ma'am.
Thank you very much, Dr. Dipti, for a wonderful presentation. And yes, thank you for giving a different idea on stress urinary incontinence, that it is not just the stress one, but even the sexual component can be equally involved. So with this, I would really like to, there is just a small shuffling into the speakers. So the next speakers who I would like to have on for all of us would be Dr. Priyalini Sarkar. Dr. Priyalini Sarkar, she is the founder and director and the senior physiotherapist of Healing Touch Physiotherapy Clinic in Andhra Pradesh. She is the founder of Agape Charitable Society, and she is also the state coordinator for IAPWC Andhra Pradesh. She has many awards to her name in her list. So just to name few, it is Nari Shakti of Physiotherapy 2021 by Sports Connect in Delhi, Audience Influencer Speaker and Best Guest Speaker in 2019 by IARH International Conference Chennai, significant contribution in the field of physiotherapy and social services in 2019 by Kites Guntur, a significant contribution in the field of physiotherapy in 2018 by PFA Hyderabad, Ugadi Puraskar for Social Services, Seva Mitra 2019, Ugadi Vishesh Seva Puraskar for Social Services 2018, and Dr. B.R. Ambedkar Young Achiever in Social Service in 2017. So thank you very much, Dr. Priyalini, for joining us, and please give us an information about the requirement of hormonal balance for every female at any age.
Thank you so much, Dr. Darasha, for having me here. First of all, I would like to thank Dr. Diksha Singh for giving me her slot, which is hers. So everyone, I'm Dr. Priyalini Sarkar, and you heard my introduction. So I'll straight away skip to the topic. Before that, thank you so much, Khyati College of Physiotherapy and IAP Gujarat for having me here. And I guess Dr. Darasha ma'am is here, and also the entire WOW group. Dr. Dara, I'm sharing the screen.
Yes, please, you go ahead. If you have any problem, I have your
sure. Thank you for being on standby always. And each and everyone, hearty welcome to this conference. And today I will be taking you to the topic called as hormonal tranquility for women at any age. It's not surprise to say that, you know, when a woman is spoken about, many people correlate two things to her. One is hormones and the other one is emotions. And it's also not strange that even hormones and emotions go hand in hand. So let's check out how it's going to be. What exactly are hormones? In a clinical way, if we are going to speak, hormones are the body's chemical messengers, and they flow through all the bloodstream to the tissues, and it impacts various organs. And also they work in such a way that over time, they have a huge impact in all the development of the whole body. Be it right from growth to metabolism to sexual functions, reproductions, and our mood swings, each and everything is directly affected by these hormones. While we are still studying in schools, even when you are colleges, whenever our height is low, a bit less than the normal size, what they say is, you need more hormones. So yes, we are told that we need hormones, but we are not taught how to get them. So let's get into the details about it. How are hormones produced? And here it is. As we all know, endocrine glands are the special cells, and we can also call them as the production house of hormones. In both male and female, we have pineal glands, pituitary, thyroid, thymus, adrenal, and pancreas, which affect every system equally. But when it comes to the male hormones, they are produced in the testes, while for the female hormones, they are produced in the ovaries, which has a very more bigger role to play in the entire life of a woman in the upcoming stages. Now let's talk about how powerful these hormones are. Actually, why are these hormones very powerful? Because they are actually controlling the whole body system of a person, of a human being. So absolutely they are powerful, and a little bit of fluctuations, either they are going high, that is going to affect us, either they are going to go low than the normal ranges, yes, they are going to affect us. And yes, I love this meme that I found online. One does not simply have a good life without having good hormones. And yes, good hormones, when we talk about good hormones, we talk about balance. When you see this week, it's very clear that, the woman is struggling to walk on the tightrope. Exactly what happens to each and every woman once she reaches the menstrual phase stage. Till she reaches the menstrual phase stage, that particular hormones will not have that much effect on her. But once the menstrual stage comes and then she gets into the marriage system and everything, the hormones become so imbalanced, and in the whole process of balancing her life and balancing her hormones, the woman's life is complete. So let's know what is this hormonal imbalance in women. What are the basics we need to understand about hormones? What exactly is imbalance? As I told you before, even when you see a balanced peak, even outside the court, even in any peaks that you have online also, no two balances are the same. One always, hinders here and there. 5% above, 5% below is okay in any balance, but more than that is gonna affect you high. And at what age women are affected? Women are affected at any age. As long as her reproductive system is active, as long as she has that intact in her, yes, it's gonna affect her more. What causes hormonal imbalance? A lot of things, but we being the millennials, we can say that, the lifestyle that we are living, the food that we are eating, the stress we are taking, a lot of things cause this hormonal imbalance in women. I'm particularly talking about women because today it's all about Women's Day. So what are the symptoms? As a teenagers, it starts with acne. And then it goes to headaches, it goes to irregular periods, it goes to painful periods, it goes to vaginal dryness, it goes to mood swings. I guess most of us have heard this concept called as, when we are showing our irritations or something, our friends or even at homes, they call, are you PMSing? Are you in your chumps today? And once our mothers post 40, if a mother is getting a little bit hyper or if it get agitated, we directly blame it on her menopause. We don't try to understand what she is going through internally, but what we try to do is we just name a particular, we give it a name and we say, oh, she's PMSing today, she's on chumps today. But how are we trying to take care of her during that time is what gives her more comfort. Now, what are the signs for this hormonal imbalance? Hair loss, the thinning of hair is also so more in the hormones when they are imbalanced. Now let's get into the symptoms once. The stress, the acne, the thinning of hair loss, constipation and diarrhea, deepening of voice. This happens when the teenagers hit the puberty. And breast tenderness. Once you actually try to ignore the red flags that your hormones and the body are telling you, you know what, girl, there is something going on in your hormones, check it. But when we ignore these red flags, yes, it develops into the breast tenderness. And the weight gain suddenly happens in the thyroid issues. Please do take care of each and every red flag. And difficulty in sleeping. The sleeping pattern itself changes, and at times we lose the sleep a lot. That's because we keep on stressing about something is happening inside, but we are not able to understand it. Excess facial and body hair. This we need to make a note of it, because most of the time when women are going for some problem to a gynae, some physical periods problem or some birth problem, when they're going to them, the first tablets they are prescribed mostly in most cases are the oral contraceptive pills. That actually takes care of the problem in a medical way, but the side effects of it are the excessive facial and body hair, which no one actually tells us. Not just this, they get the migraines, they get the severe headaches and the stress headaches and all, which they are not told beforehand. So when they are developing all this sudden facial hairs and everything, they get so stressed out, they don't know what to do. And the decrease in the libido, the depressions. Yes, obviously, when you're not knowing what is happening in your body, when you're not understanding what's happening in your body, it leads to depression. Headaches, as I told you before, it's going to be, migraine is going to hit you very severely. Change in the blood pressures and vaginal dryness. Now we have spoken about all the red flags that we are getting because of the hormonal imbalance. Now, how to balance the hormones? Unless you make peace with something that is bothering you, you can't live a better life. You can't live a good life. Let's make peace with the hormones and move in a hormonal balance and live a better life. So let's learn how it is going to happen. So the top ways to overcome imbalance are healthy diet. If we all remember, if we all go dig into the deeper basics and all, our ancestors looked after food as the medicine. But these days we take medicines as food. Before food we take a medicine, after food we take medicines. The food content became very low, that the medicines became very huge that we are taking. Healthy diet. Maintain a proper diet. In the healthy diet, you need to take a lot of proteins. Make sure at least 20 to 30 grams of protein intake is in your meal. Be it your salmons, take your high protein diets called with eggs, with chicken breast, or if you're going for, if you're a vegetarian, please check the please check the diet chart, or you can even consult a nutritionist for this, and make sure that you're eating adequate diet, because we are living in instant age, so we want everything instant. And what is happening is instant foods, these are also adding a lot of problems to our health, because they have a lot of preservatives in them. Make sure to eat a healthy diet that is very fresh and very clean. Adequate sleep. An adequate sleep is supposed to be somewhere around 6 to 8 hours at night. But how are we able to sleep that much hours without stressing? Without stressing, we hit the bed at around 10 p.m. till 12 or 1 p.m. we will always be on our cell phones, and then we wake up somewhere at around 7 a.m. and then the lag is going on. So make sure you get adequate, good sleep. For this sleep, you can actually use your sleep frequencies in the YouTube, where you can get the audios and any sleep thing that is going to help you. Please make sure that you do it to get the adequate sleep. Lower your sugar intakes and exercise regularly. When you exercise regularly, you are giving your body that activeness that it is supposed to have, and the organs will remain more active in this particular period. And please, when you exercise, make sure you take the suggestions of whoever is available with you. Don't exercise vigorously, because I did 2 days before and yes, I felt very badly on my face. So please do take care of your exercises, but make sure you stay hydrated during this time. Manage stress. This stress management is a huge red flag which we have to overcome, because the moment we get up till the moment we sleep, we are in whole lot of stress, but we forget to live in that particular process. Particularly women, they have a lot of things to do, be it they have to actually balance their professional life as well as the personal life. And in the meantime, where exactly is a woman getting time to spend on herself? Where exactly a woman is getting time to take rest for herself? I seriously urge every woman to take at least 15 to 20 minutes of the 24 hours a day for herself, so that she can able to balance both of them without feeling that, why is my life all for everyone? Why is it not for me? That is a major factor too. So please make sure you also love yourself to that extent, where you will live life in a balanced way. Limit usage of light at night. As I told before, the usage of cell phones and the usage of Netflix, whatever the OTTs that everything is available in cell phone right now. Even if you are hitting the bed by 10 p.m., everything we roam from room to room, called as the social media apps. We roam from Instagram to Facebook, from Facebook to WhatsApp, again go back to Instagram. All this will happen for the next 2 to 3 hours till we get the sleep. And as long as that light is falling on your eyes, where will you get the sleep? So please make sure to either keep your phones in silent mode after 10 p.m. so that you get good sleep, or please switch off your phones. In case of emergency, keep one phone switched on in the entire house. And quit smoking, because we all know how nicotine is bad for a woman's health. Avoid overeating. We don't overeat because we have to. We overeat because there are various reasons. At times we don't know what to do. We just sit and try to concentrate on something. Out of tension, we keep eating. Eat, but at regular intervals. Make sure you're having your healthy diet at regular intervals, which will help you in balancing your hormones. Maintain weight. This maintaining weight is according to the heights, which is available in the medical charts. 5 kgs here, 5 kgs there is okay, but make sure there is no drastic changes in your weight. So always try to maintain the weight according to your body type. And this is the best thing that I found, the 8 best hormone balancing foods. The first one is the flaxseed. So you can add a teaspoon of flax seeds in whatever you're taking, and avocado. Add half avocado a day to your meals. There's this saying called as, an apple a day keeps a doctor away. But I guess a half avocado is going to keep the imbalance of the hormones at bay. So make sure you have an avocado. And carrots, which are really good. The raw carrots are really good. So be a bunny for at least 5 minutes a day and eat a carrot. We have sweet potatoes, leafy greens. Our moms are big fans of these greens. So please make sure to add these leafy greeny vegetables in your diet once a day. The salmon, as it is high protein diet, it will help you in balancing. Coconut oil. I guess the importance of coconut oil have started growing more from the COVID times. It's been used as a medicine in major Ayurvedic things also. So cook your veggies in the coconut oil, and I have seen many many elders drink 1 or 2 spoons of coconut oil. And apple cider vinegar. Apple cider vinegar, 1 spoon a day, and fill in glass full of water. It is going to help you a lot. The stress management, I'm again coming back to the stress management, because this is the part I love, and this is the part all the women are supposed to concentrate more. So adopting to a regular exercise routine. Make sure either you're exercising in the morning or in the evening. Make sure to keep a particular routine and stick to it. You can go back to building your body later, but it's all about toning your body so that whatever the organs are actually improper there's an improper function in the body, that will become more active. It will be healed internally. You don't have to go externally to a doctor or get a surgery. Before that, please make sure that you adopt a regular exercise routine, and that helps in your mental wellness too. Practicing daily meditation, this we all need to do, because right now, as I said, hormones and emotions go hand in hand. When emotions are going hyper, the stress increases. So in order to balance both of them, just close your eyes, concentrate on your breath for 5 to 10 or at least 15 minutes a day, meditate, and in that meditation, let go of all your emotions. Because meditation is a way to ground yourself to the universe and let all the positive thoughts get into your mind. Leave away the negative thoughts, let only positive thoughts flow into yourself and into your life, and that is going to take care of your stress a lot. Deep breathing exercises, as we all knew how this deep breathing exercises played an important role in the COVID management. How much people started realizing that, deep breathing exercises have always helped in, I'm sorry about that. So deep breathing exercises have always helped us in becoming more healthy. Improving your sleep hygiene. As I said, please do switch off your mobiles or keep them in silent mode, or you can use it from a particular period of time. And after that period of time, when you're heating your bed, make sure that, you are away from these phones. Because each and everyone who is messaging you at that particular point of time, or each and everyone who is calling you at that particular point of time just to talk something or the other, might not be important, but then it's going to stress you out and you might lose your sleep. So please make sure you sleep in a proper environment. Usually what happens, the youngsters, this goes to the youngsters. We sleep on a bed full of clothes. They will be piled up on one side and we will be sleeping on the other side. Or on the one side of the half of the bed goes for this mobiles, the laptops and everything, and we will be sleeping on the next half. Please take the entire bed for yourself so that, you will sleep freely and you will you'll give that space to your body to enjoy while sleeping. And minimizing your consumption of caffeine and alcohol. 1 cup of coffee in the morning keeps us going the entire day, but more than 1 cup is going to harm you. And the alcohol, please reduce your intake if you, a frequent intervals is fine according to your body type if you want to take, because it's a social way of socializing these days. But then again, please keep it in control so that it's not going to affect your hormones. De-stress with essential oils therapy. This is what I was discussing with Dr. Tarasha just before this session. Essential oils play a major role in the stress relief. I mostly choose the peppermint oil or lavender oil for the sleep, because a few drops are going to free up the entire stress and help you in de-stressing itself. But please do check for any allergies you have in case you are trying to take that essential oils in a steam or something also. Is hormonal balance important? So for the last 10 to 15 minutes, I'm talking about the hormonal balance, how to balance it, and how the improper balance is going to affect you. Now, how much is this important? I can say it's very much important. Why? Because when it comes to women's health, balance is very critical. I showed you in the starting how a woman is walking on a very thin rope. We exactly are walking on that thin rope on a very daily basis. But dear women, I really want to ask you, if we are not taking care of our health, our physical health, our mental health, our emotional health, then who else is going to take care of us? So please first take care of your body, because your body will be screaming of the red flags that, you know what, lady, today this is wrong with you. Can you please give me some rest? But we ignore it because outright a woman's mind is synchronized, or it's actually kept in such a way in tune, we auto-tune to the society's demands that we think that we are supposed to work for the entire family. We are supposed to work for the extended families. We are supposed to work for each and everyone in the family, but not for us. But please keep yourself first, because if your health is good, you can take care of each and everyone in any way you can. And what is the major risk if you are going to ignore the red flags of the hormones? And when the hormones are unbalanced, it leads to breast cancer. As I told you, The breast tenderness is one of the major symptoms of this hormonal imbalance, which speaks when the hormonal imbalance is more. Please do keep go for a mammogram or something and get checked once in a while, so that if it's in the starting stage, it will be detected. If we can watch the news, quite often we are seeing many women coming out with the cases of breast cancer. This is because the hormones are being imbalanced at a very high level, leaving the other symptoms aside, other causes aside. So please do take care of yourself. And the estrogen dominance is one of the major cause for this breast cancer. So please do make sure to balance these hormones. And this is my go-to message for each and every one of you. Balance your hormones and live your life queen size. Because all we have is one life, but being a woman, we done the hat, the jewel in the crowns are we are a daughter, we are a mother, we are a wife, we are a sister, we are a friend, we are we have a lot of roles to play. And this is on personal level, and on the career level, we play a lot of other roles. But it's really good to balance the personal life and also the professional life. But before that, please balance your hormones so that you can have a better life. And on this note, because it's Women's Day, I would like to tell each and every woman watching out this, sweethearts, you are queens and that crown belongs to you. Please make sure you take care of each and every jewel, because if the crown falls, no one is going to pick it up and keep on your head. You need to adjust it yourself. If the body is screaming any red flags, you need rest, please do take rest. And I urge each and every woman who is watching this right now and who is watching this later also, please fall in love with yourself. Take care of your body, take care of your emotional well-being, take care of your mental well-being, physical well-being, everything. The personal matters, the professional matters, everything comes later. Take at least 15 to 20 minutes for yourself in the entire 24 hours a day that you have. If you can spend that much on yourself a day, trust me, your life will be wonderful and you will be living life a queen size. And that's it, everyone. With this, I'm going to end the session, and I wish each and every woman a very happy Women's Day. And before ending this, I would like to, Dara, can you stop the share? Yeah, I'm sure. Before I end this session, I would like to thank each and every woman who played a major role in bringing up to this stage, because our mothers, our grandmas, everyone played a beautiful role in shaping us as a strong woman we are. But remember, ladies, you are beautiful the way you are. You're successful the way you are. You are a queen, because please don't go according to the judgments of the society. Please don't go into a competitive mode at all. Let's grab each other's hands and move forward. And exactly on this note, I would like to thank few men here, because without the support of men, maybe we'll not be sitting here. Maybe Dr. Darasha or Dara Sharma won't be sitting from 1 o'clock from yesterday organizing this entire thing, because there are men who are taking care of their families there behind. So to all the fathers who supported every daughter's dream, to all the brothers who took care of their sisters, to all the husbands who are supporting the careers of their wives, just like the beautiful women are doing out there, to all the friends who give us the emotional support, to all the sons who are actually sharing the chores along with the daughters, to each and every man out there who are supporting us deep down from our heart, we are really grateful to you. Not to forget, Hate This I Serve for the WOW group, because the way they are building this WOW empire, helping the women brigade come out and talk about the women problems. Hats off to you, sir. Thank you so much for this. And the IAP people, yeah, how can we forget them? We have Dr. Sanjeev sir running an entire IAP and supporting the women's wing, because I come from a women's wing state, being a state coordinator of Andhra Pradesh. And not to forget Dr. Ali Irani sir, who is in this session along with us. Thank you so much, each and every man who is present here, who is supporting us, and keep supporting us so that we will live a better life like queens. And all the queens, a very happy Women's Day. Thank you so much. And the technical team, thank you so much for having us here.
Thank you very much, Dr. Priyalini. It was a really very lovely and encouraging presentation from your end. So I think that let us go ahead with the next presentation from Dr. Diksha Singh, a very young, dynamic, and a very good physiotherapist. She is a women's health rehab. She's a women's health physiotherapist, and she has written already 2 books. One it's all about pregnancy and it's all about periods. And she is the editorial and review board member of ASWH International Journal and MCMS Journal. She's the founder and owner of Hormonal Wings and Perfect 10 Maternity Rehab and Physiotherapy Clinic for Women's Health and Counseling. And she's also a member of All India's League, Women Economic Forum, life member of Birds Beak Club Professional, public health volunteer at United Nations, and she is also a life member of PCOS Society of India. Over to you, Dr. Diksha.
Thank you so much, ma'am. I'm audible?
Dr. Diksha, you are audible.
Okay, okay. So thank you so much, ma'am. And first of all, I'll start with something from a day I started the women's health journey. Now, you know, I met two people. First is Dr. Dhara, ma'am. And then again, after her, I met Dr. Desai, sir. So these two people just changed my life, just changed my motto, just changed my behavior toward the women's health. Because earlier I used to work like a professional only. After meeting these two people, I used to engage with the women's life, how she's having, how she's feeling, what is impact of our profession, physiotherapy, in their life, and how we can have change her life, change her, help her in her lifestyle, in her disorder. So thank you so much. You both are my motivation and my mentors too. So I'll start with my topic, that is role of physiotherapy in puberty, adolescent, menstrual health and hygiene. So before starting, I'm having three agendas here. First is what is puberty, second, what is menstrual health and hygiene, and that is female reproductive cycle, ki FRC, that we call in short, and third is role of physiotherapy. So puberty is basically a significant stage in every girl's life. Here, lots of hormonal changes, emotional changes are going on inside the women body, a girl's body. So due to these changes, there is three formation is there. First is start with the remark of Thilars, that is your breast budding is there, start of your breast budding. Second is your puberty, that is formation or growing of your pubic hairs. And third is your menarche, your first menstrual cycle. That is the menarche, your most important phase of every girl's. You get your first cycle and you started behaving like now a woman. You are having that egg cells, your uterus, your ovary, and now they are reproductive organs and they are sexually mature. So puberty is the age, puberty is the time when a girl is changing into a woman, from a low pitch voice to a breast budding to pubic hairs to your menarche. So this is the puberty will lay your path to the adulthood. So this is your journey from puberty to adulthood. Then after the puberty, we'll move on to menstruation. Actually, what is menstruation? In general, everybody knows that menstruation is something like bleeding once a month for 2 to 7 days. But is it the only cycle going inside a woman body? No, this is not the only cycle. In a woman's body, throughout a month, a woman is having a cycle. That is 2 parallel cycle is going on inside your uterus and your ovary. That is your ovarian cycle and uterine cycle in 4 phases. That first phase is your menstrual phase. That is you call menstrual cycle. Second is your follicular phase. Third is your ovulation, and fourth is your luteal phase. From then we start with the menstrual phase. When the menstrual phase is there, that means your uterine wall, your endometrium wall is slough off, is in form of menstrual fluid. It is expelling out of your vagina via your vagina, and there is more contraction is there, and all hormones will fall off in this phase. Then there comes the follicular phase. Here redevelopment start, means in ovary and uterus, now redevelopment, mature cells will again start growing, and again thickening of uterus wall starting in the follicular phase. FSH hormone now at rose. Then there comes the ovulation phase. That is the 14 days in ideal time, but it can vary according to your lifestyle, your body shape and size. So in an ovulation phase, there is release of one egg from the ovary, and this egg will now move on to your ampulla and will keep on there till you get fertilized. This is from ovulation day, your fertility period started till your luteal phase. If you are getting pregnant, that it's okay. If you're not getting pregnant, then again your menstrual phase will occur. Then that means in ovulation phase, all your hormones is at peak. We started from menstrual phase where hormone is at low level. Then again at the your follicular phase is at coming to normal. Then to the ovulation phase, LH is at surge, means luteal hormone is at already at peak. Then comes the luteal phase, that is your post ovulation time. That means after ovulation, when egg is there, the hormone is at this level. But how these hormones are like impacting the behavior of your muscle? Two main muscles, that is inner core muscle, is first is your transverse abdominis and second is your pelvic floor muscle. So this is the front muscle, abdomen, that is transverse abdominis, that is inner core set muscle, and the lower muscle, center muscles of the body, that is pelvic floor muscle, sheet of muscles. How these two get impacted with this hormone fluctuation. So in the first phase, as we told, there is like every hormone is like at low level. Estrogen is at low level. That means at that time, the pelvic floor muscle will behave in a more loose manner. Means the pelvic floor muscle is leaking via vagina. The menstrual fluid is expelling out. So means contraction of more uterus and uterine wall and abdominal contraction is there to expel out the menstrual fluid. So the menstrual fluid will behave due to excess of estrogen, low of estrogen to behave in a more loose manner. Then there comes the second phase, that is follicular phase. Here again FSH level rises and your your mature follicle started again, your thickening started again. Here your that pelvic floor muscle behave strength comes to the normal stage, from weak stage to normal stage. Then there comes the third stage, that is your ovulation phase. Means your hormones is at peak. Now your estrogen is at peak, progesterone is at peak. Now this muscle will behave in a normal strength, normal tone now. Then there comes the fourth stage, that is luteal phase, or we call it post-ovulation time. So in this phase, there is basically our muscle is behaving in this manner. Now it will behave in a because due to hormone relaxin, the ligament laxity increases. So the muscle have to work in a hyper condition. So muscle will behave too tight, means too much strength is there. So now we can see in a first phase, the muscle is loose. In a second and third phase, it is coming to normal tone. And in a fourth and final phase, it is going again in a tight stage. So how the muscle is, this is how your muscle is fluctuating, behavior is changing according to the low and high of your hormones, that is estrogen, relaxin, and progesterone. So basically what is menstruation? It is your body preparing your uterus to get pregnant. And if you're not getting pregnant, that means the cycle will repeat itself again. It is a cyclic changes. It will now from 0 to 1, from 1 to 0 again. So it is going on. Now, what is the role of physiotherapy? As a physiotherapist, what the role we are having in this cycle? So it is not necessary like some girls is having some disorder, then only we can help. As a physiotherapist, we are having a very important role and a significant role in a women's cycle. That is what we have to keep our eye on the phases. As I already told you, how the muscle is behaving. So there are two phases, or the two basic management we can have. First is your journal management, which we can run for every normal cycle, and second is your normal, like if any disorder is there, any core management we needed. Then in the first part, we start with normal counseling. We try to seek out if she, like the cycle is going normal and additional she is having pain or cramp, which can be due to over contraction of uterine and abdominal muscle. So we can just go out for normal, we can use Electro part 10s, or we can just ask for the hot water bag and go for normal stretches, and therapeutic massage will also help. But if she's having any kind of disorder, so before moving to disorder, we'll work on the core rehab part first. That is your inner core, that is transverse abdominis, and second is your pelvic floor muscle. So as I already told you, there are 4-phase cycle in a 2-way, that is uterine and ovarian cycle. In a 4 phases, in the first phase, in the menstrual phase, for the 2 to 7 days, the muscle is behaving too loose. That means as a physiotherapist, we have to just ask the lady to just work on the strengthening part of the muscle with wrapping the abdomen and just strengthening part, or just go for the tension relaxation, that is asked to cleanse the whole body, then relax it. Then you can also go for visual imagery guided technique. Try to think about some good things and just try to relax and then hold your body. So just keep on this cycle for the first 2 to 7 days of your menstrual cycle. And once the cycle is over, second is your follicular phase. Just start here with the, because your hormone is now at normal, you can start with some kind of aerobic activity because your muscle is now come to normal stage. Then there comes the ovulation time. Here we have to focus more on your pelvis part, more on your hip part, more on your lower extremity. So just start with stretching, high intensity workout and strengthening part here. Then there comes the fourth part, that is luteal phase. As I already told you, there's tightness of muscle is there. So here we have to work more on the relaxed part. We have to work more on the relaxation with the functional exercise and additional accessory muscles stretching. That is आपके iliopsoas, piriformis, glutes muscle, hamstring, calf muscle. Every muscles we have to just relax the muscles along with the kegels and along with the that abdominal breathing using pelvic floor muscle movement. We have to release the muscle, and in the first phase we have to contract the muscle. So this is the 4-phase cycle for the core rehab. We have to go for the core breathe, in which we have to just inhale from the nose and try to feel your abdomen is protruding out, your like pelvic floor muscle is going down. And when you're breathing out, just try to use the pulse lip in this way and just try to feel your abdomen is now going in and your pelvic floor muscle is contracting. So just try to hold the breathe. Just try to, when you are breathing in, try to relax the breathe, but try to keep the relaxing part of the muscle at that time. So this is the core breathe, say. So in this way, we can just go for the core rehab part. Then there comes the hormone part, as Dr. Priyali ma'am already told us, how we can just balance our hormone and how actually physiotherapy can help. So physiotherapy indirect is working directly with exercise, electro, and some additional therapies. So physiotherapy is promoting good health, is promoting exercise, and exercise in addition is promoting the good health, that is promoting the good feel hormone, that is endorphin. There is rise of hormone endorphin when we are exercising, and this endorphin inside just help in inducing of your serotonin hormone, that is your sleep good hormone. And if you're having good sleep, no tension, less cortisol level, that means you are already is at ease, your cycle is already is at normal peak. And just one thing more, try to have your MMS card, that is your monthly menstrual summary card. Try to have some question, try to track your cycle via Excel sheet, via your calendar, via diary, via app. We are having applications for here, like you can use the Clue app, just have your date for this cycle, so that we can know when you're visiting a doctor or a physiotherapy doctor, you must know which phase you are going through. So they can actually help you, this phase you're going, your muscle behavior is this, this phase is there, we have to now act like this. Your lifestyle, we have to work on your lifestyle. If you are like you are not taking a sleep, you are not taking a proper diet, we have to work on a head project, that is home exercise and diet plan. So for this particular, we need, if you are suffering from any disorder, we need this, your MMS card, that is your monthly menstrual summary card. Just try to track your cycle. Second, try to write down if you are having too light cycle, too heavy cycle, how many days you are getting cycle, if you are getting regular cycle, if you are getting proper sleep, and if any of these you are not getting balanced, just immediately seek your doctor consultation, because you are having some kind of irregularity, because menstruation is a kind of report card. Every month, every woman is having this report card, if like she is having any kind of disorder. So this is whole thing. And when now we talk about the menstrual hygiene part, just try to use the sanitary napkins, menstrual cup, reusable pad, reusable panties are there, so you can use them, but try to avoid tampons, as there are side effects many then use, so just try to avoid them. You can use these products and just try to dispose them and try to change them at a time that is 6 to 7 hours. And if you're using the cup, it is very, but in case of sanitary napkin, you have to change napkins 6 to 7 hours and dispose them, and wash your hand after and before and after, and the use of napkin. And just don't try to shave your pubic hairs with a razor or armpit hair with a razor, because it will fluctuate your hormone. And don't use fragrant soap for your vaginal wash, because vagina is a self-cleansing organ. It will cleanse itself. You can just use the plain water from anterior to posterior, never from posterior to anterior. आपको हमेशा आगे से पीछे की तरफ ही wash करना है, never from back to front, because this will lead to your infection chances is prone. So this is everything. So this is what I told you, if it is visible. Like there are 4 phases, cycle is there. First is your menstrual cycle, hormone is at low and your muscle is behaving in a low manner. Then slowly your FSH is increasing with estrogen and hormone, your muscle is behaving in a normal. Then ovulation phase, there comes the time when everything is come at peak, and luteal phase, muscle is behaving too tight because of high estrogen, progesterone and relaxin, and ligament laxity is there. And if you're not getting pregnant, that means corpus luteum will disappear and you will again get the cycle. So this is the cyclic changes due to hormones we are having. And at the end, I would like to just steal some second for one thing, that is just happy International Women's Day to every woman sitting here, and try to have your MMS card. And if you want to know more data, how to rehab, what is disorder, and how to keep the assessment of these disorder, you can just read my book. It's all about periods. It is available on Amazon, and you can. It is available in ₹99 only, and it is my gift to every woman around the globe. If I'm there or not there, they will get help from it. This book. Okay, thank you. Over to you, Dhara ma'am.
Thank you very much, Dr. Diksha, for a very nice session on menstrual health and hygiene. With this, we are concluding our 2 days virtual event that was Khyati Wow PreCon 2022. Thank you very much, all the attendees, for joining us. Thank you to the speakers for managing that. We were running a bit late, but all of you were patient, and thank you very much for a wonderful presentation and giving a very good knowledge to all the participants, the delegates and the attendees who joined us or who would be seeing the link in the upcoming days. I would really like to thank Khyati College of Physiotherapy, Khyati Institute of Physiotherapy, IAPWC Gujarat, and special thanks to Dr. Dhara Sharma ma'am for constantly being there throughout for these 2 days. And there were lots of here and there and ifs and buts, but yes, we did it, and it was really a very fruitful session. Over to you, Dr. Bharvi madam. She's from Khyati College of Physiotherapy.
Thank you so much, Dr. Dhara ma'am. A warm good evening to all. I am Dr. Bharvi Malavya. What a wonderful event we had, covering all the aspects of intimate health with a take-home message to end the silent suffering. It gives me immense pleasure to deliver the vote of thanks for this event to all the speakers for their valuable time and sharing their knowledge. I extend our sincere gratitude and appreciation to all those who gave us this opportunity. First and foremost, I would like to thank IAP and IAP Women's Cell Gujarat for their constant encouragement and providing us with this online platform, and the technical team of IAP. We are grateful to WOW Group for arranging such informative sessions to bring awareness, research, rehabilitation, and education about pelvic floor dysfunction and its rehabilitation, along with different segments of women's health rehabilitation and men's health rehabilitation. Thank you, Dr. Head Desai, sir. I would like to thank Dr. Dhara Shah for leading this event and coordinating with the speakers. Thank you, ma'am. I take this opportunity to thank the team of Khyati Foundation, Mr. Karthik Patel, Chairman, Khyati Foundation, Ms. Binita Panchal, Director, Khyati Foundation, Dr. Dhara Sharma ma'am, Principal, Khyati College of Physiotherapy, Dr. Anju Makta Siddiqui sir, Principal, Khyati Institute of Physiotherapy, for organizing this event. Last but not the least, I thank all the participants for their wonderful presence. And here we come to an end of our event, Khyati Wow PreCon 2022. Let's end the silent suffering. Thank you.
Thank you so much, everyone. And I'm very thankful to IAP and IAPWC and the entire CEC for being there constantly and supporting us. A special thanks to Dr. Ali Rani sir as well for being with us throughout the event. Very thankful to Dr. Sanjeev Jha sir, Ruchi Varshne ma'am, and entire team of CEC once again. Very thankful to WOW Group, Dr. Het Desai sir and Dr. Dharasha ma'am for this wonderful coordination and leading this event. And again, the entire team of Khyati Foundation, Khyati College of Physiotherapy and Khyati Institute of Physiotherapy. And I feel that it was quite a successful event that we had for these 2 days, and wonderful, wonderful contribution from all the speakers sharing their expertise and experience on these topics. It was wonderful hearing you all, and I'm so thankful to all of you for giving us such insights. And as Bharvi ma'am rightly said, last but not the least, all the participants staying with us throughout and showing that passion and enthusiasm and showing, that willingness, that commitment to upgrade yourself and broaden the horizon of physiotherapy profession. So I'm truly thankful to all of you, and very happy Women's Day in advance to all the wonderful women who had been with us throughout this event, and as well as all the physios who are going to listen to us in the future days. Thank you so much, one and all. Thank you. Special thanks to IAP technical team. How can I forget that? For the immense support for all these 2 days and being with us constantly for this event. Thank you so much.
And heartfelt thanks from WOW Group as well for the IAP technical team.
Yes.
Thank you for arranging the things, making sure that everyone gets the email, the audio, video presentation and everything.
Thank you. Uttara ma'am, we can end the event.
Thank you so much for such an informative event. Now I'll close the session.
Yes.
Thank you all for attending.
Thank you.